हेलो।
OT2 में अभी सर्जन आ गए हैं।
हेलो।
सर्जन आ गए हैं, अभी वॉशऑप होंगे, उसके बाद ही OT स्टार्ट होगी। ठीक है। हेलो हेलो हॉल। हाँ जी।
हेलो।
हाँ जी।
हाँ सर, ओटी रेडी।
OT अभी सर्जन आ गए हैं, अभी वॉशऑप होंगे, उसके बाद ही OT स्टार्ट होगी। ठीक है।
ओके ओके।
ओके।
OT2 है। OT
ये कौन सी ओटी है?
ये ये जिसमें मेरा हाथ है,
हाँ
ये
हाँ।
OT1 है।
हाथ नहीं दिख रहा है।
ठीक है।
हाथ नहीं दिख रहा है।
ठीक है।
नहीं कुछ अभी हमको एक पेशेंट इंड्यूस होते हुए दिख रहा है। ये कौन सी ओटी है? हेलो।
सर ये OT2 है। हेलो।
हाँ हाँ।
जी सूरज जी
मैं
अरे
डॉक्टर संदीप बोल रहा हूँ। ये
बताएं।
अभी ये जिस ओटी में एक पेशेंट इंड्यूस हो रहा है, ये कौन सी ओटी है अभी जो
सर,
हमारे
ये-
स्क्रीन पे दिख रहा है?
ये सर जो स्क्रीन पे दिख रहा है आपको, वो ये OT2 है।
ठीक है।
इसको हमने OT1 बना दिया है।
ठीक है।
जो 1 थी उसको मैंने 2 बना दिया है।
तो ओटी अभी ये ओटी 2 है ना? ये
जी सर, ये OT2 है, इसको हमने 1 बनाया है।
नहीं, वो सब छोड़िए ना, ये ओटी 2 है। मतलब अभी हम इसको ओटी 2 बोलेंगे।
जी जी नहीं सर, OT1।
हाँ
ये रेशमा खातून है सर।
हाँ हाँ।
L5S1 फ्रैक्चर है सर।
नहीं, आपके हिसाब से ये कौन सा ओटी
ये
है?
OT नंबर 1
ठीक है, अभी ओटी नंबर 2 को 2 में फीड दीजिए।
दे रहा हूँ।
ओटी 2।
जी
ये ओटी 2 है। हेलो।
ये OT2 है।
ठीक है।
ठीक है सर।
तो ओटी 2 में अभी पेशेंट नहीं आया है, ओटी 1 में पेशेंट आया है। तो ओटी 1 दिखाइए।
जी सर।
ओटी 1।
जी सर।
ओटी 1। ठीक है। इस पेशेंट वहां पे कोई डॉक्टर है अभी?
हेलो सर।
यहाँ पे ओटी 1 में कोई डॉक्टर है?
हेलो सर।
हाँ मैं सुन रहा हूँ।
हेलो सर, रेजिडेंट जूनियर रेजिडेंट 3 बोल रहा हूँ सर, किशोर सर।
हाँ किशोर, अभी वहाँ पे कोई डॉक्टर हैं? और
सर अभी आए नहीं है सर, सर आ रहे हैं सर।
हैंड माइक की गेन बढ़ा दीजिए थोड़ा सा।
पेशेंट का एक्सरे दिखाओ और कैमरामैन को बोलो एक्सरे पे दिखाए। पेशेंट का एक्सरे लगा दो व्यू बॉक्स में। ओके, ये बड़ा वाला एक्सरे हटा दो, बड़ा वाला हटा दो, ये होल स्पाइन हटा दो। हेलो किशोर।
हेलो।
किशोर, ये होल स्पाइन एक्सरे हटा दो, बीच वाला। ठीक है ठीक है, इसी पर रहने दो, कैमरे को इसी पर रहने दो।
ठीक है सर। ओके।
हाँ
सुभाष भैया।
हाँ?
सुभाष भैया।
संजय बोल रहा हूँ।
संजय भैया, थोड़ा कैमरा ये जो सुभाष भैया ने फोकस किया ना, थोड़ा सा पीछे ले लीजिए, क्योंकि इनके कैमरे का व्यू आ रहा है पिक्चर में। ठीक है।
ठीक है। ठीक
या तो फिर ये कैमरा टिल्ट करवा दीजिए।
ठीक है।
अरे सूरज, ये OT2 है, जाकर कैमरा दिखाया जा रहा है।
ठीक है ठीक। सर लैपटॉप वहाँ OT में रहेगा, यहाँ भी
ये अभी
लगेगा।
जहाँ आपने ये जूम आउट कर दिया है, जूम एक्सरे पर जूम इन करिए। वो डॉक्टर साहब पीछे खड़े हैं।
भैया एक्सरे पे जूम इन कीजिए।
एक्सरे पर जाइए। ठीक है। सो गुड मॉर्निंग एवरीवन, गुड मॉर्निंग डेलीगेट्स। So today we are going to have live surgery telecast from the operation theater. So I'll just brief you what we are going to have. So we are going to have 6 cases today. May I know your name please, like one by one, if we can have.
MLN Medical College, Prayagraj.
प्रयागराज, ग्रेट. आप सर?
Doctor, I'm from Prayagraj.
अच्छा. आप सर वहाँ प्रैक्टिसिंग हैं? अच्छा, मेडिकल कॉलेज से, ठीक है सर.
Sir, myself Dr. Nitin Agarwal. I am from Gorakhpur, nearby Siddharnagar.
ग्रेट.
Myself Dr. DP Saroj, come from Lucknow.
लखनऊ. सर यू आर प्रैक्टिसिंग सर?
Myself Dr. Rakesh from Agra.
आगरा. सर आप?
Myself Dr. Ajit Kumar Bhatia, Ambedkar Nagar district.
ग्रेट.
Dr. Purushottam Gandhi from RML Lucknow.
RML Lucknow. So you are a consultant there?
No, I have completed my PG, just completed my PG.
Okay, great. So, so we have delegates from different places. That is one great thing. So we are going to have 6 cases total. I'm not sure whether you have got the information or not. So the first case we are going to have 2 OTs, which will run parallel. So everything has been organized for you. So whatever you want to see, you just ask us. We will switch the OT. So the 6 cases which we are going to have is, one is listhesis. So listhesis can be of different kind. So the one listhesis is degenerative listhesis, which is in the old ages, when there is facet, there is hypertrophy of facet, there is there is laxity in the facet, the listhesis which happens. Now another one which we are going to have is, the another one which you are going to have is lytic pediatric listhesis. So this is the X-ray for the lytic pediatric listhesis. According to Merding grading, so we have this grading like one bone slips on the another bone, and based on that we called grade 1, grade 2, grade 3, grade 4 or grade 5. So this is almost grade 5 because there is no contact between is not seen, U box is off, OT1 box is off. So when there is any contact of one vertebra over the another, it will be from 1 to 4. PPT है तुम्हारे पास? हाँ करो. नहीं अभी तो वो PPT जब तक नहीं ला रहा था तब तक ये डिस्कस कर लेते हैं ना. तो so we have in this conference, this conference has been organized only for orthopedic surgeons. All the cases, all the lectures, and even the cadaveric course is also for spine surgeon. Done my spine and I am doing only spine. Dr. Abhinav is also FNB spine. He is doing only spine. Dr. Nazim is doing only spine. So, but we have not made this whole course for spine surgeons. We have structured this whole course for orthopedic surgeons, so that at least those who are resident, they should develop an interest in spine, so that they can take up in spine. Like we have lot of subspecialty in orthopedics. Likewise, we have spine as a subspecialty. There are people who want to do only arthroplasty. There are people who want to do only hand surgery, or somebody who wants to do sports injury. So this course is the purpose of this kind of course, which we will have every year in different places in UP, will be to ignite or stimulate our resident so that they can develop an interest to take up spine. Spine is very much thought like this is very bad branch, or you can say this is very risky branch, non-rewarding, but believe me, this spine is developing in UP, and we have so many patients. If I talk to any ortho, sir, you are a professor there, so I talk to any orthopedic surgeon, everybody tells that 50% of our OPD is only spine patients. Am I right or wrong? 50% of the patient in OPD are spine patients. And so if you get a tag of spine surgeon, obviously those 50% of, or those patients who wants to show, let's say, super specialist, then they will come to you. So we have lot of patients and we need proper training to, like those patients who are operative, to operate them. That is another thing, like becoming a spine surgeon or becoming a super specialist. But talk about something, let's say a person who is doing private, anybody in private practice here? Anybody who is doing private practice, you are sir in private practice. So obviously you will get trauma spine, you will get disc, you will get lumbar canal stenosis. You as an orthopedic surgeon should be trained enough to do all those cases in your setup. This is our purpose. We'll train you to put screws, we'll train you to do discectomy, we'll train you to do laminectomy, we'll show you how to do, let's say, TLIF. Of course, scoliosis or minimal invasive TLIF is next step. Let's say you start developing, then you can do all those things. But basic surgeries in spine, all orthopedic surgeons should be able to do, like putting a screw in the trauma spine, doing laminectomy, lumbar canal stenosis, doing simple discectomies. So we have made this program exactly like that. We are going to show you discectomy, how to do a discectomy. We are going to show you how to manage a patient of traumatic spine injury. We are going to show you how to manage a patient of TB spine. TB is like we get n number of TB in UP. So what are the patient you will think about operating, or what are the patient which can be managed conservatively? And if you want to operate, if the patient is coming in the initial stage, not too much of deformity, not too much of bony destructions, all of you can do. So we are going to have one of such cases. Of course, as we have great faculties from all over the India. We have our past president, Dr. Sajan Hegde. He is world renowned in deformity surgery. So obviously we have kept a deformity also for him, so that you can have a look at what is deformity, how it is done. We have pediatric listhesis, that also sir is doing. Another degenerative listhesis, Dr. Vishal Kundanani is doing. He is one of the very famous surgeon from Mumbai, and he does lot of minimal invasive cases. So all those two cases, the first two cases are going to be pediatric listhesis, which will be done by Dr. Sajan Hegde sir and team, and another will be degenerative listhesis, which will be done by Dr. Vishal Kundanani. So we are here to help you out. Whatever question comes in your mind, just ask. Most of our delegates are residents, so we want you to ask resident level questions. You have to ask resident level questions, sir, what is this, why it is so, why you are doing this. All those questions we are expecting, and we have all our spine surgeon faculties here. Dr. Najim is there, Abhinav is there, I am there, whoever is there, we will try to answer your questions. Okay? So Reshma Khatun, she is 17-year-old female, and she has come with the chief complaint of low back pain since 6 months. So in spine, when we talk about symptoms, if we are talking about कौन से symptoms लेके patients आते हैं, सर आप इधर आ जाओ, आपको अच्छे से दिखेगा. तो there are two types of symptoms. One is pain, another is neural symptoms. So this patient has come with low back pain, so something related to the bone, joints, ligament, muscles, and difficulty in walking since 2.5 months. Bilateral radiculopathy. If something called like radicular pain, radiating pain, tingling numbness, if this comes, then you should think like there is some nerve related issues. And patient has a history of trauma 7 months prior as a result of skidding of bicycle. Next slide. So from the history you can understand that the patient has difficulty in walking. As an orthopod, when we get a patient of difficulty in walking, we have so many things in our mind, whether the patient has osteoarthritis of the knee, whether the patient has ankle sprain, whether the patient has any fracture, or why the patient has difficulty in walking. This is something which we can very well comprehend, we can very well evaluate, very well examine the patient and tell. Some patient can come with the deformity, and when you examine, you find the patient has FFD at the hip. So that patient can come with the deformity which is from the hip, not from the spine. A patient can come with the deformity, you find there is limb length discrepancy. Obviously there will be pelvic tilting and compensatory spine will be curving so that the patient can walk. So we as an orthopod, in spine we need to have all this knowledge, so that's how we can analyze. So on examination, gait is normal. Bilateral neurological claudication. Neurological claudication is one of the symptoms which patient comes with. It is like tingling, numbness, heaviness in the lower limb. Why does it occur? It occurs because there is compression over the nerves. So the blood supply of the nerve is compromised. When a patient walks, the nerve need more blood, more oxygen, more nutrition, and then the limb will start to become heavy if there is a compression in the lumbar spine. So any patient, if you walk, ask the patient history that how much you can walk. If we are walking, we can get fatigue and maybe we'll stop walking. But these patients, they'll give history of tingling, numbness, heaviness, which is the term which is used is called neurological claudication. It starts at 300 to 400 meters.
And it has to be differentiated from vascular claudication as well. So in vascular claudication, one feel heaviness from lower to above. That is vascular claudication. And in these points should be kept in mind.
So we will have more discussion ki what are the differentials with vascular claudication presents like that, or what all we'll talk, because this is going to be all operative. Surgeons will be operating there, you will be seeing, and here we'll be discussing. Okay, so bilateral radiculopathy in the distribution of alpha S1. So there's something called dermatome, there's something called myotome. So obviously when we examine the patient, we will see in the L5 distribution or in the S1 distribution there is some radicular symptoms. Decreased flexion and extension of spine associated with pain, which is more on flexion and extension. Okay, just leave this step. Palpable step. We expect our spine to be put one over the another, one vertebra one over the another. So when you look when we examine the patient from the back, all the spinous process will be in single line. Why so? Also because there is a supraspinous ligament which connects all the spinous process. So when you run your thumb, you will find like smooth curvature. And when you find a step, then you should think like there is some listhesis. One vertebra has gone over another vertebra. And SLR, what is SLR? SLR, straight leg raising, that is also can be called like active SLR, passive SLR. We'll leave that thing as of now. We'll discuss this later as we progress in the CME. So SLR right lower limb is 45 degree, left lower limb is 50 degree. Normally we expect a patient, if the patient does not have hamstring spasm or hip problem, to raise his limb at least till 70 degree. Or some patient can raise till 80 degree also. But this patient is having 45 or 50. Why so? Because when we raise the limb with knee in extension, the nerve which is coming out from the lumbar spine is getting stretched. So at 45 degree, the patient says, I'm having pain from back to the whole lower limb. So that is called SLR, which is related to spine. A patient who can have lot of back pain, if you raise the limb, obviously when you are raising the limb, there will be some effect on the paraspinal muscle. That patient can also complain of back pain, not the pain from low back to the whole lower limb. So that will not be considered as SLR related to the nerve. So this SLR has to be understood like when I am raising the leg, the patient is complaining of pain from low back till whole lower limb. So it is 45 and 50. Next slide. So this is neurological examination, and so when we talk about neurological examination, we try to examine the patient in few headers. Obviously history taking is there, examination of the local spine is there, that is whether the patient has tenderness, step deformity and all those things. And then we come to the neurological examination. In neurological examination, we as a spine surgeon just want to know whether the higher mental function is normal or not. Patient is conscious oriented, he knows where he is, he identifies people, he recognizes, that means higher mental function is normal. If we find anything problematic in higher mental function, then we are not the people who are going to deal with those patients, and it has to be referred to either neurologist or neurosurgeons. They have to look for upper story, we call from C1 above, which is brain. So when we talk about neurological examination, we divide it into motor examination we want to check the power, then we check the sensation, then reflexes. So these three major three headers. So sensation is we write like 0, 1, 2. If it is 2, then it is normal. If it is 0, that means the patient does not have any sensation. If it is 1, then it is less. How less, that is not important, we just write 1. And motor examination, MRC grading 0 to 5, 5 means normal. Next slide. So as of now, in history and examination, the most common finding with which patients of lumbar canal stenosis present is low back pain and radiation of pain. So this is the most common symptoms. Different grades of stenosis, listhesis, with anything patient can present, but this is going to be the most common symptom. Neurological examination may power is most of the time will be normal, sensation will most of the time will be normal. Why sensation will be normal at the time of examination? Because at the time the patient is at rest, the nerves are functioning properly, but when the patient walks, when the patient develops neurological claudication, then they will have some sort of paresthesia, but that will not be usually present when they are at rest.
So basically LCS is a dynamic condition. So when we examine the patient in supine, neurology is absolutely normal. Everything happens when the patient is going to walk.
Loading, either standing, walking, or sometime if it is severe in sitting also.
But sometimes in lateral recess stenosis, there may be pain in lying down also, because the nerve gets compressed in the lateral recess. We'll talk about that later on.
So
Lateral recess is on.
So when now, so lumbar, so when we see the another patient history, the degenerative listhesis, there also the history is going to be almost like same. No, back jaw back, or back. So there is, I see lot of doctors, lot of orthopedic surgeons, when they see any patient of spine with some nerve involvement, the investigation which they order is MRI. But we forget the basic investigation, which is X-ray. This should not be done. We should always order X-ray and MRI both. The reason being, what we see on X-ray is bone. If you want to see bone, you have to see X-ray. If you want to see nerve, you have to see MRI. Obviously, you can see something on X-ray which is in direct way, or something on MRI which is bony, but for examining thing, for proper investigation, you should write X-ray and MRI both. The one more thing which is important is, when we do X-ray, most of the places we do X-rays in lying down position. In lying down position, not in this pediatric listhesis, but in degenerative listhesis, usually do not manifest in lying down position. जब लेटा रहता है तो bone एक के ऊपर एक set हो जाती है, you will not find any listhesis. So you need to get X-ray done in also, if you are suspecting, X-ray also done in standing position. In standing position, if you will do, you might find grade 1 listhesis. We all have seen patients where MRI is absolutely normal, patient gives history of claudication, X-ray looks normal, then we are like stuck. What is the problem? Whether it is, as Dr. Abhinav is telling, like vascular problem, what is the problem? But the next step, what you do is you get a standing X-ray. You get a standing X-ray, you will find listhesis, and that explains everything. So standing X-rays are very important in spine, in especially like lumbar spine, or you can say dynamic X-rays also. Flexion extension, as Dr. Abhinav is telling, ki lumbar canal stenosis is a dynamic problem. So in this patient, what you can find, hair pointer. Lumbar canal stenosis, what you can find is that L5 is, there is anterolisthesis of L5 over S1, and finding this grade of listhesis, there is something called lytic listhesis. Until unless pars is broken, you will not find such a great extent of listhesis. So pediatric listhesis is most of the time is lytic listhesis. So we do X-ray. Is there need for MRI also? So we most of the time do MRI also. If you ask whether it is very much नहीं तुम explain करो.
So why this is congenital? So why this is congenital? Because of the bony anomaly we see. Normally the sacrum should be flat, but here it is dome shaped. And you can also see the difference in the pedicles, this size and this size. And also the lateral view, this pedicle looks hypoplastic. So there is, and the L5 is trapezoid shape. Normally it should be square or rectangular shape, but here it is trapezoid shape. So these all things denote that it's a congenital, not normal listhesis. That it's a congenital listhesis, and these are most of the time high grade if presenting with symptoms.
Okay, so we will have more and more discussion why it is congenital, why it is like congenital, you can say, or you can say some deformity or some abnormality in the spine. So one thing which what we want you to learn is like you are able to find there is listhesis. This is the most important thing which you have to understand in this X-ray. So if you find listhesis, that means the patient bone has moved from one bone has moved over the another bone in front. So you have diagnosed listhesis. Talking about which type of listhesis it is, lytic, degenerative, ischemic, that we can discuss later on. So next, MRI. So this is the MRI. It is most of the time it is for the information of the patient, that see you have nerve compression, and also to look for any other anomaly of the nerve. Most of the time it is very difficult to find that conjoint roots and all those things, but anyway we should get one MRI. Next, why CT is important in pediatric listhesis? CT scan is very important in pediatric listhesis is because ultimately we are going to put screws, and we need to know what is the size of the pedicle to put the screws. If the size, we should not, in spine the very important thing is, in spine is not very forgiving as compared to like if you do trauma. अगर आपने प्लेट थोड़ा आगे पीछे लगा दी तब भी चल जाएगा, अगर आपने TKR में थोड़ा बहुत अगर आगे पीछे हो गया तब भी चल जाएगा, लॉन्ग रन में गड़बड़ करेगा पर स्पाइन तुरंत मैनिफेस्ट करेगा. फॉर एग्जांपल, अगर 4 mm का पेडिकल 5 mm का पेडिकल है और आप 5.5 के या 6 के स्क्रू 6.5 के स्क्रू डाल रहे हो तो ऑब्वियसली पेडिकल बस्ट करेगा. और इस पेशेंट को अगर हम ऑपरेट करने जा रहे हैं तो L5 और S1 में अगर हम स्क्रू डालने जा रहे हैं या मान लो L4 में भी डालने जा रहे हैं, अगर हमने L5 का पेडिकल बस्ट कर दिया तो अल्टीमेटली L5 का एक पेडिकल गया, तो अल्टीमेटली हमको ऊपर और जाना पड़ेगा, L3 L4 को पकड़ना पड़ेगा. सो दैट्स वाई if you have any doubt regarding the anatomy, if you have any doubt regarding the bony numbers कि भाई कितना साइज पेडिकल है, कहाँ पे फैसेट है, क्या नहीं है, एक सीटी कराओ, स्टडी एक बार इसको देख लो कि कहाँ पे क्या आ रहा है और उसके हिसाब से आप लोग आगे बढ़ सकते हो. सो दैट्स हाउ सीटी इज ओनली इम्पोर्टेंट. अगर पेशेंट कहता है कि हाँ सर हमको ऑपरेशन कराना ही नहीं है, अब पेशेंट को ऑपरेशन कराना ही नहीं तो सीटी स्कैन क्यों कराना है? बिकॉज सीटी इज मेनली फॉर ऑपरेटिव प्लानिंग. It's not for diagnosing, it's not for like understanding how things are. Next slide. Next slide. Okay, so this was the first case. So this case is going to be operated by Dr. Sajan Hegde and team, and once they come in the operation theater they will tell about the planning, how they are going to plan the case, how they are going to do the surgery. Okay. So among us we have Dr. Shwetab. He is also FNB spine. Dr. Shwetab. He is a consultant spine surgeon in Medanta Hospital. Dr. Abhinav is consultant in Era Hospital. I am consultant in Chandan Hospital. We have Dr. Swaroop. He is in Varanasi. He is also one of the very renowned spine surgeon. We have Dr. Sanjay Yadav sir. He is a spine surgeon in BHU. And Dr. Najeem, he is a spine surgeon in Bareilly. So luckily you have a lot of people who are qualified spine surgeon who are doing exclusive work to tell you whatever you want to know. So Dr. Shwetab, second.
Who is moderating there? Sandeep.
So,
Hello?
good morning.
Anybody
this
in the
patient is
hall?
around
Can you hear me?
63-year-old
Hello?
female, and she has presented with complaints of back pain since 3 years and radiculopathy in left lower limb since 1 year. So once you start off with the history, you can make a background in your mind that in elderly patients, about 60 years, complaining of.
Hello.
Just a minute. Can you go back to the previous slide?
Hello.
Hello. Yes, you are
Yeah.
from which OT?
Yeah, I am doing that. I'm Appaji here.
Appaji sir, your voice is coming slightly less. Can you speak a bit louder?
Yeah, okay. Can you hear me now?
Yeah, we can hear you,
Yeah.
sir.
So we are doing a high-grade spondy. So we have positioned the patient right now. It's a grade 5 spondylolisthesis on standing. Can you show the patient positioning? Sharan, just come out of that place. Usko pura dikhana.
So delegates,
Hath mein.
this is the pediatric listhesis which
Yeah,
till now which we have
pediatric
discussed.
listhesis. And so we have positioned the patient like where hip is extension, right? Can you see the hip?
Yes, sir, we can see, sir.
So the patient is, hip is in extension, knee is in slight flexion so that you relax the sciatic nerve. And then can somebody zoom this?
The C arm.
Yeah. So can somebody, can you see the C arm?
No, sir, it's very black. You cannot see much.
We are not able to adjust that brightness or
Now it is looking slightly better, sir.
इसको थोड़ा कैसे करना है? लाइट करना है. हो गया? अभी दिख रहा है कुछ?
Yeah, it's slightly better, sir. Yes, sir, we
so
can see.
from C5, grade 5 listhesis, we have almost reduced it to grade 3 by positioning itself. Can you see that?
Yes, sir, we can see.
So this is a thing which we have published, how you can reduce spondylolisthesis by close reduction method. It's not our technique, it is by Jean Dubuisset, if you have heard of CD instrumentation. So Dubuisset had described how to reduce. So we modified it while positioning these patients in the table with hip extension, and they used to treat these patients with in situ fusion and casting. But now we will demonstrate how we will reduce. So the plan is to do a monosegmental fixation, S1 screw, L5 screw, and then try to reduce to at least grade 1 or 0.
Okay, sir.
Yeah, so the main crux of this is positioning. So we do a reduction maneuver while positioning the patient. I think we were not able to show it, so we give a traction, extend the hip, and then we press on the lumbar spine so that the pelvis goes from kyphosis goes into lordosis. So the hyperextended pelvis will become a flex pelvis, right?
Okay, sir. So,
Any doubts?
This is what sir is telling. Can sir cameraman zoom in the X-ray picture?
Yeah. That X-ray there.
X-ray.
That X-ray there. वो वाला नहीं. दिख रहा है अभी?
No, X-ray is not seen. It's still both the now X-ray is seen.
Yeah. ये भी दिखाओ. इसको भी दिखाओ ना. नहीं भाई इसको दिखाओ. So let them show two together side by side.
So what you can see here, the L5 is almost below. L5 is almost below. It is almost in the front of the S1. So what sir is telling, what he has done on lying down position, this pelvis is a single structure. Our hip can go in extension till 15 degree or something. After that, if you extend your leg, the whole leg along with the pelvis extends, and then this whole portion goes in front. So that's what sir has done in the positioning. He has made the patient prone, and then he has slight traction and then extension with the pressure on the sacrum, and this is how from this grade 5 he has almost achieved grade 3. Somebody is standing in front of the C-arm machine, C-arm. So there, if you can point.
Can you see? Sandeep.
Yes, sir.
Yeah, you can show them how it has got reduced
See,
from grade
now,
5 to
now,
grade 3. Yeah.
now this is the L5 and this is the S1. So there is some overlap. So you can call it like, now it is grade 4 to grade 3. So from grade 5, when it was anteriorly lying in front of S1, now it has come in some contact of S1. So this much of reduction we have achieved on positioning. So as sir has told, the planning is we were discussing we can put screws in L5, we can put screws in L4 also. If we are not able to put screws in L5, we can put screws in L4 also, so that we have 4 screw hole proximally, and we can put screw in S1, the 2 screw distally. But sir is here to show that they have been doing this type of cases by putting screw in L5 and S1 only. That is called mono segment. Mono segment. They are not sacrificing the L4 L5 disc or L4 L5 facet.
One important point I wanted to highlight is that you can.
Sandeep,
Yes sir.
so you should tell them, usually the presentation is a deformity in high-grade spondy. It is never a single segment disease. So if you leave them like this, they go in for a lumbosacral kyphosis. They may develop the lumbar sag and present as scoliosis. And then after some time, they have a S1 root dysfunction. So that dysfunction may lead to bladder and bowel involvement with foot drop in some of the adult patients we have seen. So it's better to treat them when they are younger.
Hello.
Sir is sir.
Yeah.
Sir is Dr. Sajan Hegde sir. Sir, he has been our teacher, and he has flown from Chennai. Sir is in Apollo Hospital, and he's one of the world-renowned deformity surgeon. And sir has come on special request. Last time sir also came. This time sir has also come, and he's going to show us 2 cases. One is pediatric listhesis, another is deformity. Thank you sir for coming to Lucknow. So anything, so what sir was trying to tell is, in case of listhesis, when in pediatric listhesis, let's say if you think, okay, this is the listhesis, just leave him, the patient. As the child will grow, the patient will develop deformity of the spine also. They will develop, the curvature of the spine will also get distorted, and these cases are very easy to manage now, because now they are they are not very fixed. As more and more time will pass, it will become fixed, and then it will become almost impossible to reduce. So if there is a deformity, if you find a pediatric listhesis with the symptoms, and on X-ray you find grade 4 or grade 5 or grade 3 listhesis, these are the cases which should be managed, and these are some single time surgery. Once you do surgery at 17 years of age, and whole life they are going to be happy and they will not have any problem. And if you leave them now at 17 years of age, whole life they will have problem related to spine. So that's what sir is telling, like it has to be done. Dr. Swaroop.
And just to add one more point, why we are doing this? Because the center of gravity has moved forward. It's like this. So what we are trying to achieve here, grade 1 or 0. Why we are going to put the center of gravity back? So the SVA angle will be in the line. So this is another reason why all these deformities occur, because the center of gravity has moved forward. So once we do it, जब हम इसको पीछे ले आते हैं, तो we are making a straight spine and things will move as in normal spine moves.
So what Dr. Swaroop is trying to tell is, what Dr. Swaroop is telling, we will try to explain that in whole spine model. We have certain kind of curvature in our spine: cervical lordosis, dorsal kyphosis, lumbar lordosis, and sacral kyphosis. So when I'm standing, my head and my pelvis, we can go into detail what Dr. Swaroop is telling, but अगर मोटा मोटा आपको समझना है तो हेड और पेल्विस ये एक लाइन में होना चाहिए. अगर मैं ऐसे हूँ तो मैं आउट ऑफ बैलेंस हूँ, मतलब मेरा जो सेंटर ऑफ ग्रेविटी है, इंस्टेड ऑफ फॉलिंग ऑन माय पेल्विस, इट इज इन फ्रंट. एंड एज अ ऑर्थोपॉड हम लोग को बहुत ही अच्छे से समझ में आता है कि अगर कोई आउट ऑफ बैलेंस है, आउट ऑफ सेंटर ऑफ ग्रेविटी है, तो वो ज़्यादा एनर्जी स्पेंड करेगा किसी भी काम को करने के लिए. So these kind of patient, they will be out of balance. वो आगे झुके रहेंगे, pelvis पीछे निकला रहेगा. तो इस तरीके से this is called morbidity. They are going to face morbidity whole of their life, and by doing this surgery we are going to reduce their morbidity. So can we have the PPT OT2, that the second PPT? We'll just go through the PPT of another case. So as we discussed, इसमें वहाँ signal so इसका पहले जाना, इसका नहीं बड़ा स्पाइन नहीं, बड़ा वाला मॉडल लाओ, इसको भी लाओ, बड़ा वाला भी लाओ, इसको भी ले आओ. इसके पहले का स्लाइड दिखाना, पहले का स्लाइड, इसके पहले का स्लाइड, हाँ, और पहले, और पहले, बस, हाँ. Next. So as we discussed, we'll just go through any kind of listhesis or lumbar canal stenosis will have the same kind of symptoms: low back pain, radiation to both lower limb. Just as it was in pediatric listhesis, it will be in adult listhesis also. Next slide. So antalgic gait, patient is homebound with neurological claudication. What happened in these kind of patient? With lot of compression over the nerve, their walking distance will decrease. Previously they were able to walk 2 km, 3 km, but now they are able to walk only 100 meter. So what they will do, they'll stop going out of their house. They'll stop going to functions. They'll stop going for like कहीं घूमने जाना, वहाँ भी नहीं जाएंगे. अगर फंक्शन में जाएंगे तो इनको चेयर चाहिए होगी, क्योंकि ज़्यादा देर खड़े ही नहीं हो पाते. तो मोस्ट ऑफ द टाइम ये लोग फिर घर में रहने लगते कि भाई घर में ही रहो, यहीं पे शांति है. They are on bed, they are on chair, they hardly go to the toilet. Radicular pain radiating to left L5 dermatome. Lumbar canal stenosis is not necessary कि दोनों पैर में बराबर सिम्टम हो. कई बार पेशेंट बताते हैं कि हमको बाएं में ज़्यादा है, दाएं में ज़्यादा है, ऐसा हो सकता है. Increase in extension. What it is? This symptom is like shopping cart sign. When the patient is in flexion, he opens up his canal. When I'm like this, I open up my canal, and so there is some relief in lumbar canal stenosis. So some of the patient, if they are neglected, they will start walking like this in stoop forward posture, so that they can open their spine a little bit and they have less of neurogenic claudication. But when they extend, they have more of symptom. Palpable step. Some grade 1 listhesis is very difficult to find, but grade 2, grade 3, grade 4 you can find. SLR, left lower limb 0 to 40, hamstring tightness is present in positive phalan. Sir, you want to explain this? Positive phalan Dixon sign. Okay, we'll go to the next slide. Next.
Why there is hamstring tightness? Because as we know, the patient is stooped forward. In order to keep the spine erect, he's always stretching his hamstrings to try to stay erect. And that's why these patients have constant hamstring tightness and chronic back pain. And as we were in the last case, because of very high grade listhesis, these patients tend to develop total spine lordosis, because now the kyphotic of the spine has been obliterated, because these patients stand like this and try to erect their spine by flexing their hip, so the whole spine goes into a lordotic posture. So this entire thing creates a mismatch in the spinal alignment. But here I think it is a low grade listhesis, so we'll see later.
So here also you see neurological examination is normal. Most of the lumbar canal stenosis, if they are not very severe, the neurological examination is going to be normal. There is one question which we will discuss after some time. One question which should come in your mind कि power normal है, sensation normal है, केवल चलने में ही तो थोड़ी तकलीफ हो रही है, तो सर्जरी क्यों करना है? This question should come in your mind, and we will try to answer that later on. So X-ray, CT scan, MRI. CT scan is like only for operative purpose. We don't order CT scan immediately for the patient. And when you see this X-ray, here you can see this bone is one above the another, this bone is one above the another, but this L4 is slightly in front of L5. So this you can find only, most of the time you can find only in standing X-ray or flexion extension X-ray. Sometime you can find in supine position, but not always. That is why this loading X-ray, or you can say standing X-ray, is important. Whole spine X-ray also we take whole spine X-ray. The reason behind, we want to have the look at the deformity. So this is CT, this is MRI. If you see in the MRI, uh, here you hardly find any CSF, or I'll try to explain you here. Normally in spinal canal you have nerves and it is floating in a bag of CSF which is inside the dural sac. So when you see this place, here you find this spinal cord, and in front and the back you find CSF. If you find CSF in the front and the back or in the axial section, there is all around CSF, that means there is no compression at the nerve. ढेर सारे लोग आते हैं कि MRI LS स्पाइन किया, उसमें PID है, PIVD है. ऑब्वियसली अगर 1 मिलीमीटर 2 मिलीमीटर PIVD है तो रेडियोलॉजिस्ट लिखेगा क्योंकि वो उसका काम है कि L3 L4 पे there is a small PIVD seen, L4 L5 पे small PIVD seen. But we as a clinician has to interfere in perform that MRI whether there is nerve compression or not. तो अगर यहाँ पे हल्का सा PID है भी, पर अगर all around CSF है nerve के या spinal cord के, that means the patient is not having any nerve compression. So as a clinician, this is our responsibility to tell the patient. So here you find CSF, here you find CSF, here also you find CSF, but what about this place? This is that L4 L5 region where you hardly find any CSF. And this MRI is done in supine position, लेट के किया हुआ है. लेट के किया हुआ है तो ऐसा दिख रहा है. जब ये पेशेंट खड़ा होता होगा तब उसकी बोन आगे जाती है, तब ये कंप्रेशन और एक्सैजरेट हो जाता है. So this compression which you are seeing is actually more when the patient stands. So इसमें हम लोग ये क्यों नहीं कह रहे हैं कि PIVD है?
Hello.
Yes. From which OT?
Hi, this is Dr. Vishal Kundmani, and we are from OT1.
Okay.
OT2 with a case on degenerative.
So the case which we are discussing, degenerative listhesis, is going to be operated by Dr. Vishal Kundmani. Can cameraman switch to OT2, that Dr. Vishal sir case?
So now I'm going to show you the case that we are going to be operating here today, and
Cameraman?
the surgical plan as well we will be discussing now.
So this is the operation of that pediatric listhesis. They are skin incision has been given. Whenever the hand is coming, so pediatric listhesis, the incision has been given, the deep fascia has been opened, and we are dissecting paramedian, bilateral, paraspinal. Dissection is being done. The dissection is done.
So
Yes, sir.
can we have the camera? Are you able to see the case? That
No, sir. The cameraman is showing the case of other OT, that is pediatric listhesis. Please ask them to switch the camera to your OT.
Can we have the switch over, please? Cameraman, can we have the switch over, please? Bolo?
Yeah, now we can see you, sir.
Yeah, perfect. So,
So first of all, I want to thank you for coming to Lucknow, and let me introduce you also. Sir is Dr. Vishal Kundmani. He is one of the very famous spine surgeon from Mumbai, and he does most of the work by minimal invasive, and he is here to demonstrate this degenerative listhesis by minimal invasive technique. Sir, over to you, sir.
So, we are looking at a patient who's 60-year-old female. Huh? So, 60-year-old female.
No, voice is not audible. Can you adjust your mic more?
Can you hear me now? Can you hear me now?
Yeah, we can
Can you?
hear.
Can you hear me now?
Yeah, we can hear now.
So, there is a 60-year-old female presenting with mechanical low back pain, chronic in nature, with worsening claudication for last couple of months, has been given a trial of conservative care along with a root block also. However, the symptoms have been worsening and affecting the activities of daily living. Investigations were done to find out the exact cause of claudication. On examination, the vascular cause of claudication was found to be negative with palpable DPA-PTA. Patient is a non-diabetic with no obvious signs of peripheral neuropathy or any other secondary cause. The sacroiliac joint tests are negative. The SLR is negative, and patient has no obvious neurological deficit except a progressive worsening claudication with walking distance of less than 100 meters, affecting the activities of daily living. X-rays done in this patient reveal that this patient has a L45 degenerative listhesis. Can you appreciate that? Zoom please. Can you appreciate here? Hello?
Yeah, we can appreciate,
Yeah.
sir.
So it's a L45 listhesis in a 60-year-old female, mobile with vacuum sign on flexion extension views noted. MRI shows a tall disc with degenerative spondylolisthesis with intact pars at L4, grade 1/2 listhesis at L45 with very severe facet effusion. Can you appreciate the facet effusion here?
Yes, sir.
The facet effusion is defined as, if you see here at L34 and at L23, the facet joint has a very minimal fluid in there. Whereas at L45, the facets are full with more than 2 millimeter of fluid seen there, with compressive lumbar canal stenosis due to ligamentum flavum hypertrophy, facet hypertrophy, facet effusion, and of course facet subluxation, resulting into listhesis at this level. So a 60-year-old female with left more than right claudication affecting activities of daily living with progressive claudication, degenerative listhesis, compressive lumbar canal stenosis. The plan here is to do something to relieve her symptoms, which will entail doing a good decompression and fusion. Decompression will be at L45 from left side, and fusion will be interbody at L45 with instrumentation at L4 pedicles and L5 pedicles. The steps that we are going to follow today in the surgery called TLIF or transforaminal lumbar interbody fusion are positioning. We have taken almost 30 minutes here to position our patient in such a manner in liaison with the anesthesia team that the head is high, all the bony prominences and eye is padded very, very well. The lumbar lordosis is kept neutral. We have kept vertical bolsters instead of horizontal, but there are surgeons who use horizontal bolsters as well. All the bony prominences are padded with Gamze oblique cotton roll already, and the lumbar lordosis is kept in neutral position. After positioning, painting draping was done, and for level marking, we have put in a needle there. Come, show me. If you can appreciate the needle placement here, can you see this?
Yes. Yes.
For level marking, that's L4, that's L5, S1, L45 vacuum sign, and a needle is placed at L3 spinous process just above L4 pedicle. Our incision, this level marking is very important because this will help us to have a minimalistic incision. Here we are going to do a conventional open TLIF. I would have loved to do a minimal invasive microendoscopic TLIF in such patient. However, here we are going to do a conventional open TLIF using L4 pedicle screws, L5 pedicle screw, interbody work at L45 and decompression at L45 level. Putting in a needle will help us to have incision from there to there, exposure from there to there. Now the steps of TLIF surgery after positioning and level marking include, start. Exposure. Now what I feel is that 80% success of surgery is determined by a good, clean, hemostatic, meticulous exposure. If you are able to do a good exposure, your rest part of surgery will become absolutely clean, meticulous, precise and hassle-free. For good good exposure, what I mean is that your exposure should from the tip of TP
Sir, the
on the left side,
yes, now it is seen.
tip
now.
of TP on the right side for L4 and L5. It's very important to visualize the TP on both the sides of L4 and L5 to get good convergence of screws. And a good exposure is one which gives you all the bony attributes seen very clearly. Unless and until you have seen the transverse process of L4 and L5, or what we call instrumented vertebrae. Unless you have seen the instrumented vertebrae tip of TP on both the sides, you will probably be struggling with instrumentation big time. And that's why a good exposure is must, and good exposure involves visualizing all the bony attributes which I just discussed here. While doing so, absolute hemostasis is very important to reduce blood loss. After a good exposure, the step number
Volume
3
has
would be-
decreased, sir. Volume has decreased.
Yeah. After a good exposure, the next step will be pedicle screw insertion. And pedicle screw insertion, we are going to demonstrate here today. We are also going to have a workshop today and tomorrow as well during cadaveric. We are going to see how to put pedicle screws in cadavers. But today you will see that to put in a pedicle screw, you not only have to see the transverse process, the superior facet and the pars has to be visualized very clearly, which we will be demonstrating today. The entry point involves the intersection of superior facet to the transverse process, and the steps of pedicle screw insertion will follow as we demonstrate in the surgery. After our pedicle screws have gone in, the next step would be to do inferior facetectomy, which involves removal of the inferior facet of L4 to access the disc area and to do decompression of traversing nerve root, if required exiting nerve root. In this case it may not be required to decompress the exiting, it's degenerative, so traversing nerve root will be decompressed, visualized, and we will land in the foraminal area visualizing the disc directly. This is the step which determines how easy and how nice disc preparation you will be doing. After inferior facetectomy, we will be doing discectomy and interbody preparation. Interbody preparation involves taking out the whole disc material, including the cartilage, using various type of curates, pukkas, distractors, and preparing the area for graft and cage insertion in the area of L4-5 disc space. The size of the cage will be decided intraoperatively depending on what size of pukka and distractor goes in snug fit there. In this case, since it is only left-sided symptoms more than right, left 100, right 10, we will only be doing left-sided surgery. The right side of the bony area will not be disturbed, and over-the-top decompression on the opposite side will be achieved. That will have a decompression of traversing nerve root left side where inferior facetectomy is done. And on the contralateral side, we will not do a laminotomy. We will just remove the ligamentum flavum and visualize the nerve root of the opposite side, doing an indirect decompression of the opposite side. Once this is done, the rods will be coming in, compression achieved over the cage, and closure done using absorbable sutures. So that's the whole surgery that we are going to be seeing now. The entry points of pedicle screw insertion, inferior facetectomy, how much to do, how less and how optimal inferior facetectomy is to be done, and how well to prepare the interbody space are the steps to watch out for in this surgery. Any questions so far?
So, whatever questions you have, anybody has any question they can ask? Yeah, Swaroop.
Dr. Vishal, this is Dr. Swaroop.
Hi, Dr. Swaroop.
Hi, sir. Sir, the chief complaints which the patient has, she was having a back pain for 3 years and a progressive neurological pain, the claudication pain, which is there for 1 year. So how you are going to, your surgery is going to benefit these 2 points just for the audience sake?
So expectations from surgery have to be very clearly defined and counseled to the patient. no amount of surgery will take care of back pain by 100%. However, symptoms which are dynamic in nature always get better completely. Like in this lady, I am told mechanical low back pain is a constant feature the moment patient starts walking, associated with claudication in both the legs, and all these symptoms get better the moment patient is sitting or lying down. So now we have two kind of symptoms, dynamic and static. Dynamic symptoms of claudication completely get better with surgical decompression and fusion. However, static symptoms, the ones that are present at rest, even when the patient is sitting or lying down, which involves some amount of back pain, that does not get better by surgical maneuvers. For that, aggressive rehab, osteoporosis treatment, and sarco strengthening, that is muscle strengthening exercises, helps and goes a long way. Neurological deficit, which this lady does not have, also does not get better just by surgical decompression. And any foot drop, EHL weakness should not be promised that the recovery will come across after the surgical decompression. It may or may not come across, but any such promise made to the patient is a flawful word to the patient.
Thank you, sir. That was really important, I guess, for the for the people here to understand the difference between the static and the dynamic back pain and the neurological claudication. Which
So now I'll wash up and we'll be demonstrating you the exposure and all the steps that we just discussed here.
Can the cameraman zoom the OT1 operative field?
Zoom the OT operative field.
Switch to main OT.
Okay, thank you.
Hello.
Switch to OT1.
So one good thing is that in minimal invasive whatever conferences I have attended, the very big problem is like very difficult for audiences to see. So that minimal invasive TLIF we have converted into open TLIF. So now you can see all the structures. So here we have this spine model. How many of here are residents, like who are still doing PGs? Can we have raise of hand? Residents? That is great. Okay, so so this is the spine model. So we have this patient lying down like this. So what sir was trying to tell is the 50% of the work is done if you have very good exposure. We are not very sure like where we should put our cautery, what are going to be the landmark. So in exposure we are going to see everything. In both the cases probably we can see. So this is the C-arm picture which they are taking after paramedial incision, the incision and the exposure. OT1, anybody can OT1?
Yeah, Sandeep.
Yes sir, Appaji
Yeah.
sir. So till now what all you have done, can you please tell to audiences, because it was in OT2, Dr. Vishal sir has told everything about is their planning.
Yeah.
So what you have done, can you tell here?
Yeah, so
Your voice is not coming properly.
no, the mic fell off. Yeah. So we have done the exposure. Can you see the wound now?
Yeah, we can see the wound.
And then we did a C-arm picture. इसको हटाना. C-arm को यहाँ नहीं रखने का.
So we can see the operative field.
इसको यहाँ से ना. नहीं यार, इसको यहाँ नहीं रखने का. पीछे रखो.
Can someone this show by retracting the muscles?
Hey, Vignesh. Yeah, that's the S1 facet where.
No, we are not able to see. We are seeing only cob and the hand. Yes. Can that make it main picture, the operative field main picture? Operative field as main picture, not in the, yes. Yes, now you show, sir. We can see, can you explain what all structure? Yes. What is
Yeah.
this facet?
That is a L5S1 facet.
Okay.
That's the sacrum.
Okay, sir.
You can see how superficial the S1 is.
Okay.
And then the K wire is placed on the S1 entry point.
Okay, so this is the caudal. Can you tell us also the caudal end
Yeah.
and the cranial end?
Put here. Yeah. That is where the cautery is the caudal end.
Okay.
That's the cranial end.
Okay.
This is the right side.
Okay.
And that's the left side.
So K wire is left side and
Left
caudal.
side on the caudal on the S1.
Okay.
Yeah. Both lumbar.
Restoring the whole thing. And also, Appaji and I do not believe that in a young child we should insult the sacroiliac joint in a growing child and put screws as the Americans do, or as the North Americans do. We do not believe that that is required in our children. And this is what we are going to demonstrate today.
Your light and blue.
Hello. Sir, we have one of the esteemed faculty from Mumbai, Dr. Gautam Javeri, sir. He is one of the very famous spine surgeon, and he is also the secretary of Association of Spine Surgeon of India, which is the national body for spine surgeon. And sir is here to help you out, whatever your queries are, whatever your questions are, sir.
So as you can see, hi, good morning. I believe most of you are orthopedic residents. Can I have a show of hands? How many of you are residents in orthopedics? Oh, so rest of them are not residents. So rest of you all are all consultants in private practice. How many are consultants? All right. So, and do all of you do spine surgery? Is there anybody who doesn't do spine surgery and has just come to get an experience of what modern spine surgery is all about, or all of you are actively involved? Who does not do spine surgery? All right. So great. So this case actually highlights to you what is why people are afraid of spine surgery. This is probably one of the worst cases you can do. A high-grade spondylolisthesis in a child. The risk factors start from the very beginning. The bone quality is not very good. The bones are very thin and small, so putting in screws is not that easy. Reducing, when you try to reduce this listhesis, the screws can pull out. When you try to reduce this, the compression when the nerve comes out in, and that patient who has no neurologic deficit can land up with a neurologic deficit. So it's a challenging procedure. Now, as young spine surgeons, though there are consultants, most of you look very young. He is a consultant, but he hardly must be 35.
I have a scoliosis to do after.
36.
I have a scoliosis to do
Right?
after.
So, all of you look very young, and at this stage in career, what I will tell you is only one thing, and that is the benefit of surgery lies in
You have case there in Bombay?
patient selection.
Huh? Oh.
In any field, whether it is spine
So
surgery,
you will make
shoulder
10 lakh
surgery,
rupees
joint
tomorrow.
replacement surgery, the
Huh?
key is good patient
12 lakh
selection.
rupees
The more better you select the patient,
For
the
yourself.
better it is. And
or for the team.
the more careful you select,
Good
your
man.
patient, the better will be the outcome. It is
I
better
make
to
that in a
operate
month.
less than more.
Yeah, man.
That is the
Yeah,
principle.
yeah.
So
Really?
good patient selection, appropriate choice of surgical procedure is also extremely important. A lot of you keep on reading in the books and everywhere nowadays. Everybody is advertising, I do minimally invasive spine surgery, I do tubular retractor surgery, I do endoscopic spine surgery. But first learn to do a good spine surgery, then try to do all these things. Okay? And then of course executing it. So this, in the step 1, I'm sure Dr. Appaji must have told you, was to do a wide exposure of the spine.
you need to expose right up to the tip of the transverse processes in a high-grade listhesis. What happens over here is, as the bone goes forward at L5S1, the root of L5, which comes out from below the L5 pedicle, is stretched, slightly stretched, and it is further compressed below the sacral promontory at S1. And you have to release that root completely before you start the reduction process. Are we live? Appaji, can you hear me?
Yeah, Gautam.
All right. So, Appaji, we can see what you are doing. Can you please orient us? Which is the cephalad end?
I'm just scrubbing in. I'll come there.
Okay, which is the head end? Which is the tail end? I would like to know.
I'll just
as soon as you come in, please. So, anyway, for some of the junior residents, you said you are a resident, right? Yeah, senior resident. So, what is spondylolisthesis? Please tell us. Please let all of us know that.
Outer gloves on and off.
Yes, it is the translation of one vertebral body over the other. What are the types of spondylolisthesis you know?
No back tie, yeah? No back tie.
नहीं switch. PIP में OT2 लगा दो. PIP में OT2.
Turned after.
Right. Yes.
Sir, great gloves. Yeah.
Good, very good. You've done good. Sit. Anybody wants to add to this? The gentleman here, you want to add to what he was saying? He described 3 types of listhesis. Which are the other 4 types? I know, but he was also talking, so I got it. Bolo. So he said it can be congenital, it can be degenerative, and it can be traumatic. He talked about 3 conditions. There are 4 other things in the Wiltshire classification. Do you know that? Okay. So great. Type 1, there is a classification which has been, but before I describe that classification, simply put, anterior listhesis. So listhesis can be listhesis can be to the side, called as lateral listhesis, or listhesis can be rotary, which is called as rotary listhesis. So this is on the direction in which the listhesis occurs. Now, based on the pathology, you can divide spondylolisthesis into 7 types. So, doctor, what happens in a congenital listhesis? You don't know. Anybody who wants to tell me what is congenital spondylolisthesis? You want to tell them?
So congenital listhesis basically which has a congenital component, like the children are born with it, and there are certain features like you can just look at the X-ray or the MRI. It's better to comment upon the X-ray for the congenital listhesis, which clearly tell you that you just look at it and you tell it as
hold this.
Clearly, like this is a congenital
Hold this.
The prominent features of it are the L5 will be trapezoid in nature. The sacrum will be dome shaped. Now you can ask why does it actually happen? I mean, why?
Gautam, can you hear me? Gautam, you done.
The reason is because again a very basic fund of orthopaedics comes into play. So when this listhesis happens over a period of time, because it's congenital, it has been there for a number of years, that L5 being in front, being translated in front of S1, it, keep that wear and tear. In simple words, you can say that L5 end plate keeps degenerating because of this force which is there on it, because it's not in its normal position. Similarly, because it is shaving upon the S1, it's translating in front, so that kind of feature, the dome shaped feature of S1 comes into play. So these are the typical features of it, and looking at it, you can clearly say that it is a congenital listhesis.
So would you say that this dome shaped sacrum and the trapezoid L5 is the cause of congenital listhesis, or is the effect of congenital listhesis?
नहीं,
what is the cause? That is the pathology.
यहाँ आकर ऐसे करो
what is the pathology in
अंदर आकर ऐसे कर सकता है
listhesis?
ऐसे कर सकता है
Exactly goes wrong. Why should a
वो बार-बार इसको
congenital
नहीं
listhesis occur?
करना है ना
So usually a congenital listhesis occurs. A listhesis occurs why? Because there is a deficiency in the posterior elements of the vertebrae. Okay? It is the posterior elements of the vertebrae, the posterior ligaments, the posterior muscles which hold the spine in its place. If there is a deficiency in the posterior elements, then there is a listhesis. So in congenital listhesis, these are, as you all know, there is a vertebral body. This. Behind the vertebral body are pedicles. Behind the pedicles, these are the facet joints. And this is the area of bone, which is a part of the lamina which joins the superior facet to the inferior facet of the same vertebra. This is called as, anybody? Pars interarticularis. So what happens in a congenital listhesis is that there is a deficiency in the facet joint. So the facets are either very hypoplastic or small, and they are not able to resist the forward slip of the vertebra. In some patients, this pars interarticularis is congenitally longer than normal, and that is why patient develops a congenital. So there is a deficiency, a congenital deficiency either in the pars interarticularis or in the facet joint, which allows the vertebra to go forward. Now, what is very important about that? The important thing about that is that when it goes forward, the forward part of the vertebra goes, not only the vertebra goes forward, but even these posterior elements will go forward with that. So if there is a significant spondylolisthesis,
you go up then.
L5 over S1, like this, and everything has gone forward, what will happen to the dural sac? The anterior elements have gone forward, the posterior elements have gone forward, so the spinal canal has gone forward. And it has not gone forward in a small way. If it's a listhesis like this, it has gone forward more than one full vertebral body. So what will happen to the spinal dural elements? The dural elements will be kinked. In congenital stenosis, typically, you will find a narrowing of the spinal canal.
It will come here, so we want to go there. So thoda और 5 degree और निकाल दो.
ये can you focus more और magnify करो वो X-ray picture please. Main frame में कर दो उसको.
Entry is okay.
Please ये जो X-ray picture है सियाम का picture वो main frame में लाओ हाँ.
This entry is fine.
So Appaji sir, what you want to tell? Can you tell loudly?
Yeah. नहीं.
You are not audible.
Is it already reduced partially?
He has to get a good quality X-ray.
नहीं इतना ही आता है सर इसमें.
अच्छा picture
इतना ही आता.
Apache, it seems to be reduced by 1 grade. It's now about grade 4, I think.
Yeah. So actually, Gautam, when you were not there, we were demonstrating to do a close reduction.
Right.
So we could get it to grade 3 only by close reduction.
Right.
And then we were now actually after exposure it's grade 4, but we are trying to show the trying to see our angle of S1 screw. After I remove the drape on the patient, I'll show you the position and other things.
All those wires which are being seen on the CM, they are neuromonitoring wires?
No, those are I think cautery wires.
Okay, are you using neuromonitoring over here?
No neuromonitoring for a low back.
Are you, when you position the patient, Appaji, for these patients, and you try to reduce the listhesis partially or more with positioning, are you worried that with positioning you can cause any neurological?
No. Actually, if you extend the hip and flex the knee, you actually decrease the transgression length for L5 root.
Right.
Previously, people used to flex the hip and flex the knee.
Right.
There, the L5 root will get lengthened.
Right.
So transgression length of this will be increased.
Okay.
So you cannot reduce now with extension of the hip, like in acetabular fracture. You will reduce the transgression length for L5. So you can easily reduce it. You will not get, it's a described technique by Jean Dubuisset.
So you have got a couple of pillows below the thighs.
Yes.
And then from the knee you have flexed the knee higher up.
Yes.
All right. Great. Fantastic. This looks good. What now? So have you started screw positioning? Have you put in insertion? I can see something at the S2 level. What is that?
Which one?
Yeah, that what you put your finger on right now.
Yeah, that is a L5 S1. That's a retractor.
Okay. Can you, with your fingers, are you washed up now? Or sir is there, na? Sergeant sir is there.
Yeah.
Sergeant, can you trace the L5 vertebral borders for us, please? And S1 vertebrae, because we are not able to see it very clearly. Please zoom in camera.
Yeah.
See, you can see that is the S1 body that Dr. Sergeant Hegde is.
L5.
Sorry, I'm sorry. L5 body, that's the L5 body and the S1. So you can see that it is S1 is, L5 is just ahead of the anterior border of sacrum right now.
This is the sacrum. Yeah, yes, sir.
On the sacrum.
Yeah. There is a little dome. Yeah.
Okay, that is better. That is better.
Okay, ये position है.
This-
अभी ले लो.
See, this is the L5 here. This is the S1 here.
The screw is good.
Yeah. So you tell him.
So what happens, you know, in these patients is
Gautam,
yeah, tell me.
can you see the sharp point which is pointing?
Yes.
Where Dr. Hegde is pointing the finger.
Yes.
So that will go directly into this promontory. So that's where we are working into the C-arm. So we want that tricortical purchase specifically in these cases because you are trying to reduce it.
Right.
And when you try to reduce it, if you do not have hold, then that's a disaster. So the first, the only time where we keep on checking in C-arm for a low back surgery is this high grade listhesis. And we want the screw to be perfect in the first attempt.
Right. And so your direction of the screw from your starting point, is it any different than what you normally do with sacral screws, or is it the same?
We go 10-15 degrees upward towards the promontory, not parallel to the S1 end plate.
Right.
We are like 10 degrees cranially angulated towards the promontory.
Right. And you will break through the anterior promontory
Yes.
and take it.
We have a instrument which is a like calibrated instrument. Steffi All, you would have seen that all. It has a calibrated instrument, so we just keep on increasing the length till we break the anterior cortex in S1.
Lovely.
The strongest part of S1 is the anterior promontory. You can see the sclerosis around there where Dr. Hegde is pointing out,
So
right?
this is what he is referring to, the anterior sacral promontory, right below the L5S1 in place. It's the strongest part of bone.
Yeah.
And he is
Yeah,
trying
yes,
to
sir.
say that normally when we put medical screws, we don't break through the anterior cortex of the vertebra.
Yeah.
Here he is planning to break through the anterior cortex.
कौन है
When
ये?
you break through the anterior cortex, you are a little worried because there are blood vessels in front. Luckily in the sacrum, the bifurcation has already occurred. So if you have
Down or
medially enough, you should be safe. Okay, anteriorly there is nothing but the medial sacral artery, which usually
Give me
doesn't
the-
get damaged most of the time. So that's what he is trying to say.
Yeah, so I'm trying to go in more. Prof, and get the Steffi ready.
PIP में OT2 दिखाना. PIP में OT2.
Which is this retractor system, Appaji?
This is a specific system I don't think anyone else has in India because this was bought Dr. Hegde directly from Failing. So this is called Failing low back retractor system. You can add 2 or 3 more like these hooks at the on the side. So you can either do it a single level, you can do 3-4 levels also with this retractor system.
Okay.
And it has a thing which goes in like that. So it bends inward so that it doesn't come in your way of putting the screw.
Right. Appaji, we are going to just go for 5 minutes to Vishal's case.
No, just see this instrument.
Yeah, just show. Okay.
So this is a Steffi All which I was talking about, and it has this calibration here which says about the centimeter. So we usually keep it at 35-40 to start with, and this is the calibration where you can increase or decrease the length of the awl.
Okay, we'll wait here and we'll see you putting in the sacral screw before we go.
Yeah.
Okay.
Yeah. We are doing 35. 35. Yeah. So I'm using a 35 a calibrated length.
Normally an awl is an instrument which is used to break the posterior cortex so that you can put the gear shift in place or the Lenke probe to make your track. In this case, what Appaji is doing is he's using the awl also to break through the anterior cortex.
So if you can hear the sound of this all going in,
Yes.
so I'm in the cancellous bone. As I reach the anterior, so it becomes very hard. So you can hear one sound, okay?
Yes, we can hear the change in sound. It's
Yeah.
become more of cortical.
Yeah, that's it, I think. Give me the probe. Angle was correct, no?
अभी क्या करेंगे? ये भी important stage पे है. एक screw दिखा के देख लेते हैं.
Hmm? No. That's where. Yeah, that's where.
Yeah, it's 40.
35. 40 is out, no?
But this is 60, 50, 45 it has also like it. It has got to 45.
That's where. We leave it, let's her know. Yeah. You want to check Siam? Siam? This is at 40, no?
This is at 45. This is 50 mark. This is
Vishal, are you here?
Yeah, Siam. Sheet.
Vishal sir? Hello?
Hello.
Dr. Vishal?
Yes, can you hear me?
Yeah, can you show the landmark?
No,
please?
don't show. Wait for 5 minutes. Vishal, just wait for 5 minutes. Appaji is at a very crucial point in the surgery, which is very important for the residents. So, and all our delegates. So, he's just putting in the sacral screw. We'll be with you in 5 minutes, Vishal.
नहीं शीट चाहिए हमको शीट ऐसा ना ये वाला शीट अभी पिंक वाला शीट दे दो 4-5 रख ना या वो दे दो but you keep lots of sheets yeah sir.
So for the residents, I mean like Dr. Sandeep and Dr. Shweta were explaining in the beginning,
How much ever you can
the Phelan-Dixon sign, like
That's
because the
enough.
vertebra
Leave
has
it.
fallen in front. So, I mean, the person goes like this to balance it. He has to, make this
We'll pull it this way.
postural body.
Come.
So, I mean, once X-ray comes in between, just look at the sacrum. It's very vertical. It's retroverted. So, that is also a feature of a high-grade spondy. The same thing which is seen clinically, that Phelan-Dixon sign, because the vertebra is slipping in front, the patient is moving in front to balance himself. He tends to become like this. So that is what is also seen in the X-ray. So, I mean, we should also take that
ये
into
तो sterile
consideration
है
when we are
unsterile
considering
कर
the
सकते हैं
surgery.
इसको टच कर सकता है इसको नहीं टच करना है
45 crore.
वहाँ जा
इसको छोड़ 45 crore. Do you have 45 crore?
Okay, let's move to the other OT. Can you show Dr. Vishal's case, please?
yeah
This is Vishal's. Dr. Vishal, can you show? We are with you now.
Hi sir, can you hear me?
हाइट ठीक है ना
Yes, we can hear you also.
शूट करो
Can you
एक बार
see this surgical field here?
sir you are not wearing
Vishal sir, can you
So this is the cephalad
so
end.
it's gone in the correct line
This is
It's at
the-
40 35 में ठीक हो जाएगा 45
OT2 में करो.
Yeah.
OT2.
I've got
हाँ,
little bit
सही है.
anterior. I'm touching
अभी
the
ये change मत
I can
करना.
feel that
So you can see this is the head end of
35
the
में हो
patient.
जाएगा.
This is the head end.
This is
Yeah,
the
no,
tail end.
35.
This is the tail end.
Yes,
That's the right side.
yes.
This is the left
Yeah.
side.
Okay.
Gautam
That's L4.
Appaji will be with you in 2 minutes. Just 1 minute.
yeah
L4.
Yes.
That's L5. That's the capsule of L4 on the left side.
Yeah. We can't see. Can you ask the cameraman to come from the top? He's coming from the side.
कर सकते क्या कुछ भी? मैं कह रहा था कर देता
और अंदर आ जाओ.
हूँ. आ जाओ. Top से आओ.
Meanwhile, while you adjust the camera a little bit, we'll be with Appaji. Please shift to OT1, please, to our Dr. Appaji's case, please. ये केस को magnify.
OT1 big करो. OT1 big.
ठीक है ना
OT1 big करो और OT2 को PIP में.
थोड़ा नहीं थोड़ा इस तरफ यार ये कितना क्यों घुमाते हैं आप लोग
OT1 को बड़ा करो. OT2 PIP में.
या गौतम
ये ऐसा दिखा दो.
गौतम
Sandeep is there. Bolo, we are looking at you only.
ठीक है
Go on, Appaji, we are looking at you.
yeah can you see the Siam picture now
No.
ask them to इसको दिखाओ यार मेरे को क्यों दिखा रहे
We are in darkness.
इसको आ रहा है. में आ रहा है वो इम्पोर्टेंट नहीं है दोस्त, जो उधर दिखाना है वो.
Can you see the CM?
Not yet.
Ask them to show you the CM.
Yeah, now we can see the Siam. Can you zoom the PIP? Zoom the PIP and make the other OT small. Zoom the PIP. Yes, now we can see this big.
Look at the probe, which is like at the coming out at the promontory. Can you see that?
Lovely, lovely, very beautiful.
So it's around 35 millimeters length. So we'll use a 6.5 35 millimeter screw. Yeah. आपको screw ये wire डालकर डालना नहीं.
For the residents, I mean what Zaveri sir was saying, it's very important. I mean it's when you're aiming to reach this position, you should really be medial. I mean if we are not well trained, we may tend to be a little lateral because there are a lot of soft tissue play in it. I mean there's a difference when we do it in a model, in a cadaver, but then when we are doing a live body, the play of soft tissues really come into it. And then we tend to be lateral, and when we are lateral and we are breaking the anterior cortex, there are crucial vessels, crucial nerves. Although L5 nerve just passes over the promontory laterally. So if our screw is lateral and has breached and is a bit longer, it can really cause vessel injury, it can cause nerve root irritation, become a reason for radiculopathy post-operatively. So what I basically want to stress upon the point of sir is that when you are aiming for this, and in sacrum we should most of the time rather always aim for a very medial and a tricortical thing, because sacrum is a cancerous
Vishal
bone.
sir,
It's just a bag of soft tissue.
Can you show the technique of putting the screw? OT2 को बड़ा करो, OT2 बड़ा, OT2 zoom. OT2 को big करो, OT2 big.
Sharp point. And give me the empty screwdriver.
Vishal sir, can you show the entry point of the screw,
Yes.
the facet, the lamina, little bit? Can you show?
Yes. Are you able to see this view? Our cameramen are struggling to show the view around. Are you able to see the surgical field?
We are able to see the spinous process and one screw.
Yeah. So
One screw and spinous process.
So we have put two on the right side. We have
That
put
we
one-
cannot see, sir.
Can you see now?
Vishal sir, we can see only one screw and the spinous process. The camera is at an angle.
Unfortunately, the top mount is not there.
Vishal asked the cameraman to come on top of the field. He's showing it from an angle.
Unfortunately, sir, he has his own way of doing things. So we'll have to accept what he's doing. He tried level best.
Then I might as well close down this video presentation and take a lecture.
Yeah, I think that will be better. On how to
See anything at all.
Yeah, we are also.
So, for the audiences, this for any listhesis, the few of the OT requirement which are important is, I think during exposure you must have seen the surgeons using bipolar. Most of the orthopedic surgeons usually don't use bipolar, they use only monopolar. But if you are going to work in spine, one of the very important thing which you should have in the operation theater is bipolar. So, operative step, as Vishal sir has told, the skin incision, the exposure of the lamina, like we have to expose, what sir was trying to tell that,
You'll find, huh? Take a screw ke liye.
when you have to expose the spine for putting screws, you will be learning tomorrow in the cadaveric course also. Like you have to put an incision in the middle, you have to go dissect the muscle, the paraspinal muscles, you have to see the lamina, then you have to go till transverse process. Identifying the transverse process is important because it is very important landmark. It helps in putting the screw and it acts as a landmark. So in both the cases, they have identified transverse process. And
35.
This instrument is called distractor, which they are using. Vishal sir,
Anji sir.
You are using distractor. Can you tell why you are using distractor?
I am using a distractor. I have put in screws there already.
So your volume is less. The voice volume is less.
Our audio visual guy is less.
Never use demonstrating. No, don't want any mixture. No.
So what I have done is I have put in screws on the right side and I have put a rod there and connected it and distracted it on the opposite side so that I get space on this side to work.
Because this side it broke. So we'll use that side to reduce.
Number 5
this
forward.
side से interbody work.
ये सब हटा लो मेरा वाला इंस्ट्रूमेंट किधर है सब हटा लो
Yeah.
हटा लो ये सब हटाओ सब हटाओ सब हटाओ टेक अवे
Give me the top.
ट्रॉली को अपने पास रखो चल चल This is how you work here. Is this how you work? चलो receive board.
So Vishal sir, you are going to start the inferior facetectomy.
That's right. That's right. I am doing the inferior facetectomy from the left side.
Okay. So have you put the L5 screws also?
No, I have not put the L5 screw on the left side because the screw here on the left side may come in my way of putting the cage. So I have kept the L5 hole prepared, but I have not put my screw in.
Any specific reason why you have not done that?
For the same thing that my because the L5 screw tulip may come in my way.
Okay.
While putting my cage there. So the screw, that screw comes last. That is ready karo sir. Nar hook ready karo.
Sharp point.
Graph ready kijiye
Sharp
implant
point.
team please. So I have done the inferior facetectomy totally. Now I am taking down the overhang of superior facet of L5. And we are
So this
reaching
was
the
going
ligament
here.
flavum in the
And
foraminal
that
zone
angle
now.
is almost 20 degrees,
It's very
30
important
degrees.
to do this TLIP here and to take care of the pedicle superior wall because in an attempt to remove the superior overhang of L5 facet,
Wait.
sometimes the superior wall of pedicle may get breached. So,
See, I'm ready.
Narhook and Patty ready.
ये शीट सब क्या है? स्क्रू है.
Patty also.
நம்ம இன்ஸ்ட்ருமெண்ட் நம்ம எடுத்துட்டு வந்ததா?
So we can discuss like in lumbar canal stenosis what are the options, like what are all the surgeries we can do. So one surgery which is very well defined is laminectomy, which we do in cases where there is no listhesis, there is no instability. If a patient comes with lumbar canal stenosis, there are n number of surgery which you have heard. Sir has told about endoscopic. Those are the method. Like you want to go to Delhi, you can go by train, you can go by bus. You can
यहाँ
go
से
by
आ जाना.
So
कुछ नहीं होगा यार. लाइफ क्या होगा?
techniques
टच करेगा ना बस. हाँ.
So there are various techniques of reaching Delhi, various ways of various mode of reaching Delhi, but ultimately the person is reaching Delhi. In the same way, when we are doing decompression or when we are doing management of lumbar canal stenosis, we have X number of surgeries. Those are the surgeries, and we have X number of ways of doing it. So we can do open, like the way which you are seeing. We can do tubular, we can do minimal invasive, we can do endoscopic. There are various ways. So we will not talk about ways, like what are the ways of doing, but we will talk about what are the different types of surgeries which we can do. So one of the surgery which we can do is laminectomy. In laminectomy, what we do is we expose the spinous process and the lamina, and we remove only the lamina. And of course, we will undercut the facet or lateral recess decompression. So here, what we are seeing, both the surgeries is transforaminal lumbar interbody fusion. And what is TLIF is ultimately we have to do interbody fusion. What is interbody fusion? Interbody fusion is when we talk about the structure of the vertebra. This is the body, and these are the posterior structures. So if we are fusing this body, one body to another, that is called interbody fusion. And there are various ways of doing interbody fusion. And one of the ways of doing interbody fusion is transforaminal interbody fusion. So transforaminal when we talk about foramen, this is the foramen from where the nerves are coming. So if you want to do transforaminal, the root has to be through the foramen. For going through the foramen, we have to remove this facet. That is what Vishal sir was telling. We have to remove the facet. If we remove this facet, we'll have clear way of going. As soon as you remove this facet, you will find root and the disc. These are the only two structures which will be in front of you. So the root which you have to protect, you push it up, and in front of you you'll have disc. So from there you can go directly inside the disc and you can put the cage. So that is the transforaminal lumbar interbody fusion, which both of the cases we are going to have T-lift, transforaminal lumbar interbody fusion. This is the most common interbody fusion which is being performed. Then we have PLIF, posterior lumbar interbody fusion. Most of the people are not doing that. That used to be like in that technique we don't remove the facet. And by the technique of discectomy we do that fusion. That most of the people are not. Then we have oblique lumbar interbody fusion, we have lateral lumbar interbody fusion, we have anterior lumbar interbody fusion. So you can put the cage between the body. As an orthopod, our aim is to put the cage between two body. This is the body, we have to put cage here. Cage means cage filled with bone graft. Ultimately we have to achieve the fusion.
No.
So you can put the cage from the front.
So this is going downward. So
you can put cage from the lateral, and you can put cage from the foramen, or you can put cage from the posterior. The posterior technique is almost like nobody is doing, almost obsolete. The most common technique is transforaminal, and the second most common is OLIF, oblique lumbar interbody fusion. The lateral and the anterior also is being done, not very commonly, but the main is transforaminal. So when you talk about the steps, obviously we have to do the exposure, till the transverse process we have to put the screws, and that's what in both the cases it's being done. You need to have very strong proximal curve. So that's why sir was like they aim for promontory. They check CM again and again and they aim for promontory. But in L5S1, as you have seen, Vishal sir has not seen. Like he has made the hole, made the trajectory and put the screws. Because it's grade 1 listhesis, it's a degenerative listhesis, it's immobile. You don't need lot of forces to correct the listhesis. That's why, and also even if it is L5S1 degenerative listhesis, even if your screws are parallel to the S1 end plate, it will do the work. So both the sides we have done the exposure, we have put the screws. Now what Vishal sir is doing is he is cutting the facet on the left side because the patient had more symptom on the left side. Vishal sir, hello. OT2 volume, OT2 volume. Hello.
नहीं है ज़्यादा हो रहा है तो सीधा कर लेंगे.
OT2 volume.
We'll feed there.
Can you hear? Hello, can you hear me?
Yeah, Vishal sir, we can hear you.
Yes.
Sir, we are able to see mainly the spinous process. If it is possible to bring the camera to your side, at least show the inferior facetectomy. Yes.
Can you see that now?
Yeah, now we can see.
So we have already done the discectomy and prepared the template. We have used a sequence of distractors and pukas.
Okay.
Our size of the cage has come out to be 13.
Can you show the this sizer?
Yeah, that's the sizer.
So just show in the camera. So this is the sizer. We have different size of the sizer, like from 6, 7, 8, 9, 10.
Load.
So when we want to put the spacer between the body, we want to know the size of what is the space between the body. So for that we use sizer. We put the sizer inside, we check whether it is snugly fit or not. And we will be putting the sizer. If it is 10 size, that means 10 is the size of the cage. And obviously when you are, all of you must have seen any kind of arthrodesis. When we want to do arthrodesis, we'll remove the cartilage from the bone. Similarly, the end plate is there. We have a cartilage. We have to scrape the cartilage. We have to remove the whole disc and the cartilage, the nucleus pulposus and the cartilage, so that we can have raw bone. And then sir is putting the bone. Ultimately, anterior interbody fusion. You have to achieve anterior interbody fusion. So obviously you will put some bone inside, then only the bone and the bone and the bone graft and the bone, they will attain the fusion. And the cage is being put, we also put graft in the cage. And we put the cage. Cage is there to support. Because as we know, in the process of the fusion, the bone will ultimately demineralize and it will become soft. So if it becomes soft, it will lose the structural support. The structural support is being given by the titanium or the cage which we are putting. And the bone which we have put, ultimately it is going to cause the fusion. And also the screws which we are going to put behind, they will also give support. So this is the whole concept of interbody fusion and the posterolateral fusion. What we do in posterolateral fusion? You must have heard like screw. We put the screw and we do posterolateral fusion. We don't do posterolateral fusion. The intactness of both the facet is important, because what we are going to achieve is the facet fusion and the inter-transverse fusion. In posterolateral fusion, we achieve the facet fusion and the inter-transverse fusion. If you are not going to do the interbody fusion. Saru? OT2 zoom, OT2. This is OT1, OT2 mainframe. OT1 mainframe. Yeah, OT1, yes. So Vishal sir? Hello? Vishal sir, have you put the cage?
Yes.
You have already inserted the cage?
Yes, the cage is gone, the fourth screw is coming in.
Advantage of keeping the midline structures intact once we are doing a TLIF, because we are using it.
The advantage of keeping midline structures intact is that the muscle attachment is going to be natural. And the reattachment, rehab time will be lesser. And there is no need of removal of this. Plus, the other side we can put graft for fusion. So number one, better fusion, less morbidity, better muscle reattachment, less fibrosis, less epidural issues, lesser lamectomy membrane, so multiple. So midline structures will be intact always in my cases. Unless the symptoms are bilateral, significantly bilaterally equal.
Sir, you have one question from the audience.
Yes.
You have not removed the midline structure, you have not removed the other lamina. Yes. Are you confident that the patient nerves are adequately decompressed? This is the question.
Yes, I am 15 years confident.
Sir, suppose the patient is having the canal stenosis also, the posterior space is less. Is it suffice to go from the lateral side?
So if the patient has bilateral symptoms, if the patient has...
No, I am talking about the canal stenosis only.
So what is the question? Sorry, I didn't get it.
Bilateral, the patient is having the radiating pain. Only the lateral is enough.
Only if the symptoms are bilateral, that the bilateral decompression or lamectomy will be done in my cases. For unilateral symptoms, only radiological compression doesn't requires exposure of the lamina on the other side.
So the gratification.
So for the residents, I mean, when we are putting the cage, youngsters are often afraid कि यार cage back out ना हो जाए. So I mean, there's certain points, certain things we can keep in mind कि यार ऐसा करेंगे तो cage pull out, back out नहीं होगा. So the things are, one thing is cage should be adequately sized. That is why sir was using those sizers over there. He's trying to find the adequate sized cage over there. Number one. Number two, end plates, like sir was explaining about TLIF. So TLIF and what is arthrodesis. So like knee arthrodesis is done. Similar way we do, see TLIF is nothing but arthrodesis of a spine. The vertebrae are being fused. So that is preparing the end plates is really important. Taking out that cartilage as we do in a case of knee or ankle is important. And thus putting an adequate size cage, bone graft over there to fuse the two bones together and thereby prevent any back out of the cage is important.
Dr. Vishal sir.
Yes, sir.
Sir, do you plan pre-operatively the size of the cage?
No, never, never. It is an intraoperative decision.
So that is only by your gut feeling or the hand feeling which you get how tight or snugly fitting it is?
So it is not gut feeling, sir. It's an objective feeling that the size of the pucca going in, giving a grating sound intraoperatively while preparing the end plate is what decides the size of the cage.
Agreed, sir.
We use sequential dilators, sequential distractors, sequential cage sizes and sequential puccas. And the one that gives you the most grating sound, the most snug fit with distraction of the vertebral body while you're preparing is the size of the cage that you use.
Sir, what is pucca?
I will show you pucca. That is pucca.
No,
This is pucca.
No, we cannot see.
This is pucca.
Okay, okay.
Sir,
This is
what is
shaver.
the ill effect of putting a bigger size cage? So over distracting.
The bigger the size you put, the higher the chances of subsidence. And in osteoporotic spine, you can actually damage the end plate. And end plate damage intraoperatively can result into post-operative severe leg pain, severe back pain.
Vishal sir, Ashish here.
Hi, Ashish.
Sir, there was a question regarding the decompression aspect few minutes back. So I think if you can provide an understanding of the over-the-top decompression, that will help the audience understand the principle of release on the other side.
Yeah, over the top means preserve the midline structure and go from underneath the spinous process and do a decompression on the opposite side. Here like we are doing this.
So can you explain to the audience why do you have the patties there? We can see the threads coming out of the operative field.
So
for the
we
better
have three patties here. One patty is in the traversing nerve root area. One is in the axilla of the exiting nerve root. And one is in the foramen.
just to protect the neural tissue while we are
Yes,
inserting
that's
the
right.
cage.
ये धागा है पैटी अंदर।
So there was one instrument used which was distractor.
Yes.
There are two instruments which we use in our spine, like lot of instruments. One of the instrument like compressor and distractor.
That's right.
You must have seen like sir was distracting screws on the right side. He put screws, he distracted over the screws. It was to distract the vertebra because our screws have anchored the whole of the body. So when we put a distractor, it will distract the vertebra. It will create a space between the vertebra. So ultimately we will size it, let's say 13 mm it comes out. We put the 13 mm cage. When we have put the 13 mm cage, obviously we have gone from the foramen. We have gone from the foramen, put a 13 mm cage. So don't you think after if we just leave like that, this hole which we have made, if it is 13 mm size, is there possibility of the cage coming out or not? So the answer is like there are chances of this cage coming out. So what we do for that, we ultimately compress. So we compress from behind, anteriorly it is cage. So there occurs asymmetric compression. So let's say we have distracted. Now we have put a cage here. Now we'll compress, it will compress like this. So the hole which we have made, the size of the hole decreases. So we we do it very consciously, we check also. Let's say we have put 13 mm cage, we check that whether the size of the hole has decreased or not to, let's say, 10 mm. Even if it is 10 mm, you are pretty sure that the cage will not come back. If it come out on the back, then it will again cause neurological compromise, nerve compression. So that is the one purpose. The second purpose of compression is, let's say your size is 13.5. So, but you are not comfortable in putting 14 size cage, you are putting 13 mm cage. So you can put the 13 mm cage, compress it, so the whole above and the below end plate, it will just, it will have a strong hold over the cage. So that is the two purpose of doing compression. So we talked about interbody fusion. The whole concept of interbody fusion transforaminal is this: you put a screws, you cut the facet, you protect the nerve root which is going, the nerve root which is exiting, the exiting nerve root, the traversing nerve root, you make a hole in the disc and you put bone graft and cage inside. So can anyone tell when we are putting the bone graft and the cage inside the disc, is there any chance of the disc and is there any chance of the bone graft and the cage coming anterior to vertebral body? Isn't there any chance, because we are removing the disc? Can anyone tell why it is not so? Why does it stays below? It stays inside. The question is, when we are putting, when we make a hole in the disc, we put bone graft, where we are putting, is it not like anteriorly it will come out? It will not come out because of the structure of the disc. The structure of the disc is like annulus fibrosus and nucleus pulposus. So if you talk about the nucleus pulposus, it is inside a bag of annulus fibrosus. Annulus fibrosus is all around 360 degree. Superiorly there is bone, inferiorly there is bone. So we make a hole in the annulus fibrosus. We take out the nucleus pulposus. So we have, what we are doing is we are putting the cage and the graft inside a bag of annulus fibrosus. That is why anteriorly it doesn't go on the side, it doesn't go on this side. The only way the cage can come out, the bone can come out from the hole. And that is why we compress and decrease the size of the hole. So this is the X-ray. So what you can see here is 3 dots. This is the 3 dot which you can see. These 3 dot, the cage which has been used is the peak cage, and the peak cage will have a marker. These are the 3 markers which will denote the location of the cage. There is another thing which you have to understand: what should be the position of the cage? Is it like, if it is like the posterior half of the body, will you be satisfied in leaving the cage in the posterior half of the body? The answer is no. Your cage should at least go till the middle of the body. It can lie in the anterior 1/3 and the middle 1/3, but it should not be behind in the posterior 1/3 of the body. So it should not stay in the posterior half of the body. So we have instruments, like we put the cage, then we have punches. We put our punch through the hole, through the disc hole, and we push with the hammer the cage anteriorly till the time we are satisfied. So you put the screws, you do the facetectomy, you cut a hole into the disc, you remove that nucleus pulposus, you scrape the end plate, you put a bone graft, you put a cage, put the rod, compress, and what some people do while doing TLIF, they cut both the facets. Both side facets cut, because sir has this question: if it is very tight stenosis, obviously we have to do bilateral facetectomy and bilateral decompression. This patient was not having so much of symptoms on the right side. That is why sir has opted for indirect decompression. Like, he has distracted it, the ligamentum flavum will become tight, and he has very less symptom on the right side. So that is how it's by like tried and tested, you can say. But so on the right side there was indirect decompression, on the left side it was direct decompression. That they have removed the lamina, they have removed the facet. So in this patient, this is the first pediatric listhesis. So there we are going to have closure. So closure also has to be done in layers. Very important. Spine. Sometimes you'll have CSF leakage, and the closure becomes more important in CSF leakage, because what we have to achieve is a watertight closure. So in closure, there are like few surgeons follow different. The different layer in which we suture is, first we take a bite in the muscle layer, then we take bite in the facial layer, then we do subcutaneous, and then we do skin. These are the 4 layers in which we do closures.
Do they have the Mesonex?
Yeah, now, hello.
Yeah, wires वो सब यहाँ क्यों रखा है? नीचे से
Appaji sir?
Yeah.
Can you tell which screw we are putting?
So we are using the L5 screws now. We have put the probes, so we will check in the CM and put in the screws now. S1 screws are seen in the CM.
Yes sir, we have seen the
So
S1 screw.
the L5 screw, we have checking the we have got both the entry points and the, into the body. We'll just check and put the screws in.
Sir, are you going to remove the midline structure and do full laminectomy?
No, usually we do not do a midline at all.
Okay.
We do not do a midline in any of our cases.
So you
degenerative or pediatric or anything.
So you will do only one side facetectomy and do the TLIF?
No, bilaterally we'll do the decompression, because L5 route we have to see bilaterally.
So both bilateral facetectomy?
Yes.
Okay. So sir, to answer your question, what they are going to do is they'll remove bilateral facet, and they'll see bilateral decompression, but they'll preserve the central midline structure.
Yeah.
So
yeah, you are in.
Sir, Appaji sir, can you tell us, is it so important to preserve midline structure, that spinous process and supraspinous and interspinous ligament?
Why we preserve is, if you read about the new Lenke paper where he talks about DJK, PJK, he starts putting a tape around the spinous process after removing the ligament which is already naturally there. Why do you want to remove that ligament? Okay, and here, can you see the CM now?
Yes, we can see.
So the L5 screws, both the sides we have got the entry into the L5. So we'll put the screws now, and then we'll do the reduction maneuver in another 15 minutes.
So this is the S1 screws. These are the pedicle probe, the ball probe to check for the position of the screws for the L5. You can use K-wire also. So people use K-wire, but just to, when you are using K-wire, just make sure that your K-wire are not pointed, because an S1 screw we make bicortical. If your K-wire are pointed, they might injure some structure. So if you are putting K-wire, cut the end. They should not be pointed, or you can use ball probe.
Wires, two screws, 40.
Any questions you have, because Vishal sir is the
we'll
case has finished. Any question related to TLIF? Because now these are both the cases are TLIF.
Which side to go
down?
down?
The next case we are going to have discectomy and the TB.
Threaded one goes down.
Sometimes it is difficult to put the E-screw in the interior. It has gone in L5, S1 listhesis. How to identify, easy way to put the E-screw in L5?
Something is
okay. In listhesis, the first question is, it is grade 5 listhesis. The anatomy is so much distorted.
So the easiest way to find the entrance point.
Entry point for L5 in L5 S1 listhesis.
L5 S1 listhesis.
Appaji sir?
So we use a cannulated screw because we do not, as I told you, the first attempt is the best attempt. We do not want to change the screw, nothing. So we have made the hole. So we are using a guided screw inside, okay?
Sir, the audience has a question.
Yeah.
In normal spine, if you are taking C-arm picture, sometimes it becomes very difficult to find a pedicle.
Yeah.
And what about a listhesis case where the bone has moved anteriorly? How to find the entry point?
It's not on fully. Long. Yeah.
The easy.
See, you can see the C-arm. No, we are seeing the things nicely.
So the easiest way is
lateral view first.
You take the C-arm,
Yeah.
And in AP, you have to tilt the C arm so that you are almost end on to the L5.
Yeah.
And then you put a probe, you put a K wire
grade
there,
2 हो जाएगा
and then
ना?
you do a lateral
हो
and
जाएगा
then
ना,
you
sir?
redirect it.
Huh?
So if
बस
somebody
ना?
is not into spine,
बस ना?
not into spine means not exclusively doing spine, I would not suggest them to do like grade 4 or grade 5 listhesis. It is always advisable if you are a part-timely you do spine, you better do grade 1 or grade 2 listhesis because there are more chances of landing up in doing mistake in grade 4 or grade 5 listhesis, especially pediatric listhesis. So in spine, one more thing which is most important is once the damage is done, it has been done and it's going to stay whole life for the patient. So that is why even sir who has done maximum number of cases in India of pediatric listhesis, he is also using C-arm machine. Just people who are doing like in a month like 4 cases or 2 cases or 3 cases, it's always advisable to use C-arm. It's better you use C-arm and put a perfect screw or put a right screw rather than doing free hand and landing up in doing not good screws.
Any difference in strength of the cannulated screw, and the upper is non-cannulated, the lower one is cannulated?
So why sir is using cannulated screw is,
Yes, sir.
you must have seen like if you make a hole in the bone and if you are putting screws, the screw might go this direction or that direction. It does happen. So the same thing happens in spine also. If you have made a hole and you are trying to put a solid screws, there are chances of that screw going on some other direction. But if you are putting cannulated screws, like we do put cannulated screws in bone, you have put the wire, guiding wire, and over that if you are threading your screws, there is no chance it can go in any other direction.
Sandeep.
Yes, sir.
So somebody asked about the solid screw and cannulated screw. 6.5 has no failure rate. They have done enough biomedical tests. So there is no difference in strength of a cannulated screw or a solid screw.
The only difference is about the price.
Yes.
Cannulated screw is costlier and the solid screw is cheaper.
Yeah.
So if there is a budget constraint, you should use solid screws. But you will be using solid screws. But if you have the luxury, then better use cannulated screws when you think like putting a screw is going to be difficult. And also there is this concept in the ortho under tapping. Under tapping the screws is there in orthopedic surgery. Like if you are going to put 3.5 mm screw, you under tap with 3.2 or 3.1. But in spine, if you find like bone is very strong, like in young patients, obviously there are a lot of spine surgeons, they have different habits, but if I am putting 6.5 screw, I always tap with 6.5. Because I don't want to tap with 5.5, ultimately landing my screw to go here and there. If the bone is not so strong, lightly osteoporotic, then you can go for 5.5 and then you can put a 6.5 screws. So now we have Appaji sir. Sir, we want you to show audiences when you are preparing the end plate, when you are putting a sizer.
So you can see Dr. Hegde is going to use the bone scalpel. Can you see this now?
Yeah, we can see this structure.
So we are doing the laminectomy using a bone scalpel.
So this is a bone scalpel instrument.
Yeah, so we do not do it's an osteotomy.
Bone scalpel is an instrument to do laminectomy, which not many people have privilege to have. So most of us are doing laminectomy with rongers, Kerrison rongers. But this is one of the very good instrument because this does not cut the soft tissue. You cut the bone and below is the soft tissue, it will not cut it. So if you are going to do multi-level laminectomy, bone scalpel is like it will do the work in minutes, which your ronger or your drill is going to take time. So doing laminectomy is by different ways. Previously people used to do laminectomy with nibblers. Now Doing laminectomy with nibbler involves slightly increased risk of damaging the neural structure. Then we have this rongers. Rongers are safer than nibbler. Then we have high-speed drill. Orthopedic drills are also there, but now we have spine drills, spinal attachments. So you can just rub the bone with the drill, high-speed drill, and then you can take it out. And now we have this bone scalpel, which is the most advanced system for doing laminectomy, you can say, cutting the bone.
Anything, you can even do corpectomy, laminectomy. This, we are doing a laminotomy, we are not doing a laminectomy because we are preserving the midline.
Okay.
Yeah.
Okay.
Yeah. Scoop.
Osteodome surrender.
So, I hope it is. Can the cameraman put his camera into operative field?
Sir?
Operative field.
Yeah, very thorough. Yeah.
Okay.
Camera,
Yeah.
can you show?
The other scoop.
Careful.
There are two cameras in OT1. One camera you make PIP and one camera you can make main camera. One camera into PIP, other camera into mainframe.
Okay. So now we have done a laminotomy. Now we are going to do the reduction.
Okay.
You want to do this right? No. Third. Sandeep, you have to be with us now for next 5 to 10 minutes.
So we are with you only because the other OT case is finished.
Okay.
And so this OT is, we are getting feed from this OT only.
Be careful. Yeah. Give it to me. I'll do it. You are too
So in
tall.
orthopedics, when we do reductions, what are the
Thoda
different
lamba
ways
hai
of
wo.
reducing?
ठीक है.
ये छोटा लग रहा है.
Can anyone tell what is the concept? How do we reduce in let's say
Head
DHS?
aligner kuda. Head aligner to.
Anybody can, sir, you can tell. Anybody who does DHS here?
Head aligner.
Yeah, but nobody is lifting their hand. Now everybody does spine.
1 minute.
Simple way is that to reduce the pattern of the fracture is important to know the DHS is unstable
Sandeep.
fracture or the stable
Sandeep.
fracture. DHS.
Sandeep.
Great. Yeah. Okay. Yeah.
नहीं आ जाएगा. वो distraction से एक आएगा. तो reduction से आएगा. Yeah.
So we have one more spine surgeon for Dr. Harpreet. He is also one of. So anything you want to ask from audiences?
You know?
I think most important part here reduction. So once you put the rod in, you have to have your best hold in L5 screws, right, sir?
Yeah, L5 S1, both the screws, because
Yes,
S1 is a
definitely,
levering screw,
and then you have
L5 is a reduction screw. Give a forceps, man. Yeah. Okay.
So is there, sir, any trick to achieve complete reduction? So many of the times we are able to achieve partial reductions only.
Wait. Tighten karo.
Yeah, you de-talk it. The key is to
So any particular sequence you follow
See.
to screw?
There is no sequence. See the rod is left proud of the L5 screws. Can you see here? So we use these reduction towers. You see these reduction towers?
Yes, sir.
So instead of a reduction screw, we use these reduction towers.
So, but sir, there is any trick to achieve complete reduction? Because most of the time we are left with partial reductions. Or you are happy with partials only?
Most of the time what we want is reduction complete.
Okay.
Yeah. Okay.
So, reduction, what we are talking about is reduction. Basically, reduction is something like bringing the bone back, which has moved anteriorly. So, it's simple. You put a either you hold the bone, which we can hold only through the screws. We have put the screws, so that will act as an anchor for my bone to pull it up. So, the L5.
So we are doing a distraction between L5 and S1 and slowly one more click.
Camera, हाँ.
एक और क्लिक हो सकता है एक ही क्लिक दो हाथ मत यूज करो एक हाथ से स्क्रू ठीक है ना सर नीचे मैं देख रहा हूँ इधर से दिख रहा हूँ
Sir, why are you distracting and then reducing? Can you tell audiences?
Yeah, see, if you do not distract, how will you get the 5 out?
The
It
5 is anterior, was anterior to S1.
Yes.
Now they, on positioning, they reduce it to grade 4. Now, if they not distract, the dome of the S1 will hit the L5. So they will not be able to pull it behind. So that is why they are distracting, so that it is above S1 and distract and then pull behind. It is here, so distract and pull behind. This is what they are doing here. And when you are reducing, it has to be done bilateral. Here you see they have applied bilateral towers and they are pulling from both the sides. You have two anchors in the L5. If you pull from one anchor the whole L5, there is high chance that L5 will, that screw will come out. So it's always better you put bilateral and bilateral tower and then you pull from both the side. Both the side you tighten and both the side it will gradually, slowly it will come back. It is attached to the screw. Ultimately we are pulling the screw.
Don't do that.
So there is something called reduction screw. In reduction screw, the screw has an extension, and that act as a tower, you can say, over which you can tighten. Here in global system, now most of the system we have separate towers. You attach to the screws, it acts as extender, and then you tighten up and.
एक ही जाना ओके नहीं
No.
Yes.
ये थोड़ा नहीं ये रॉड छोटा है तो the other thing is slipping out. The other
operating view.
Give me the no not distractor यार इसको रॉड थोड़ा नीचे डाल देंगे डीटा टाइटनर yes sir नहीं रॉड को थोड़ा नीचे डालना
because of that deformity and the
Switch to operating view.
reduction screw that tower I was having a hindrance of that tower
Switch to operating view.
push करो
and S1
अभी हो जाएगा
so is there any pattern when we are putting in a reduction screw that the other screw will not hinder in the trajectory of putting
glove
You had L4, L5 listhesis.
L5 S1.
L5 S1 and the L5 was grade 4.
Yes sir.
So when you put the L5 screws, there was hindrance in putting S1 screws.
Yes sir. Because the trajectory was such.
Yeah, it happens. It happens.
How do?
So there are few
Operating
things.
view.
There are few things. I'll just let them reduce. Then we will talk about this.
Nizam.
एक और जाना है 2 मिलीमीटर वेट करो डिस्ट्रैक्ट करेंगे थोड़ा नहीं हाँ नहीं एक मिनट
That is one of the very genuine question which happens. In L5S1 there is lordosis. So what happens? This S1 and L5 this entry point is like this and this entry point is like this. So when you
image
it almost becomes like this. And when you're putting reduction screws it collides. So how you can manage is this S1 screw instead of putting like this you can put from below towards promontory. So you can
Sandeep.
Yes sir.
We have done the reduction, we removed the towers. You can see now the S1 screw, the sacrum was like this.
Please zoom inside. Cameraman, zoom inside.
So the sacrum was like this and the screw was plowed out here. Now with the reduction it has gone downward and we have got the L5 almost out into the same line as L4.
Sir, the cameraman is showing the other camera picture, not the over operation camera. He is showing the opposite side, not the camera which is looking in. Yes, now we have. Now you can see the S1 is back.
Yes.
So now you explain, sir. We can see very nicely.
Yeah.
So can you explain again?
Yeah, I'll show. So, एक minute. So follow my suction tip.
Yes.
So that is sacrum, which was up like that.
Yes.
So we put the rod there and then we have pushed the sacrum along with the screw into the L5 and pull the L5 also out.
Yes.
Okay, so now we are trying to get into the foramen.
Okay, sir.
Foramen.
Yes.
So that's the foramen.
No, there is a hand holding the suction, so we cannot see the foramen. Yes.
Yeah, that's the foramen. Sir is trying to remove that soft tissue ledge which you get.
Okay.
For a high grade spondy. This is the soft tissue you get.
Yes.
Okay, this will become the major compressing force is that only on the root. So now we will see the L5 root.
Okay, sir.
Yeah, so the L5 root is here. Yeah. So that's the L5 root there.
Yes, we can see, sir.
Yes.
So in lytic listhesis, this is the fibrous bridge which forms, and ultimately whenever there is a listhesis, this fibrous bridge causes compression over the exiting and the traversing nerve root. So whenever you are doing lytic listhesis, if you have jagged it up, sometimes it stretches and ultimately makes way for the exiting nerve root. Otherwise, in high grades, it is very important to remove this fibrous tissue which sir is removing. If you will not remove this, there will remain a compression laterally. There might be, you might have achieved decompression below the facet, but lateral to the facet compression will still remain. So removing this fibrous structure is important in case of lytic listhesis. This fibrous structure will not get in
root canal probe.
Degenerative listhesis.
A patty आधा काट कर देना. Small patty. Give me a scissor.
PIP में दूसरी OT2 का पिक्चर डाल दो. PIP में OT2 का पिक्चर.
थोड़ा नीचे यहाँ. वो रूट है. नहीं करते. यहाँ होगा सर. ये.
Sir, when you are going to take the lateral picture of this C-arm picture, sir?
We will get into the interbody space and then take a lateral picture.
Okay, sir. Okay.
Give the नहीं यार nerve root pro.
So they are trying to expose the disc. The one which we talked about. The one which they are going to expose the annulus. Then they'll make a hole in the annulus with the knife because annulus is a tight, and then they'll put a bone graft inside and put a cage inside.
ये S1 root है. ये disc है. Bipolar. Reduce the bipolar. Reduce it to 25. No, that 38. Yeah, 25. Yeah, thank you.
So this is the root. This.
No, 1 minute.
This is the root which
You're
is
not
there.
still fully.
This thick cartilage structure.
इसको निकाल देंगे.
It has been medialized
Bipolar से बंद कर.
towards the center and laterally.
Yeah.
This
No,
is
no,
the
we have
foramen.
finished with the.
We have done.
Distal screw. This is the proximal screw, and this is the
Our
foraminal
disc will be
area.
here.
From where
इसको
the
निकाल.
cage will enter. This is
नहीं,
going to the
bipolar
area
है.
from where the cage is going inside.
Foot pedal.
Cage will go inside, and the L5 is here. L5 nerve root exits from here.
Yeah, give me a scissor. Not required. Not required.
Appaji sir, can we go to the we will just switch to OT2
Yeah, you can
for
go.
some time
Yeah.
to know what case they are going to operate.
Yeah.
Is there anyone in the OT2? OT2? Hello?
Not there. No. Yeah.
Anyone in OT2?
That's a place. You have to create that space.
Yeah, I don't know why it is. We have a.
Scissor.
Be careful. Dissector, another dissector.
Kumar,
Another
you-
dissector.
Hello, sir. What are the indication to fuse this listhesis in the grade 1, grade 2 cage or posterior lateral fusion?
You are asking me?
Sir, the question you are being asked is when we should do inter-body fusion with the cage?
Yeah, give me the
Grade
root
1,
canal.
grade 2,
Root
grade
canal.
3, grade 4, or can we manage grade 1 by posterolateral also?
Yeah. Usually, if it is a pediatric high-grade spondylolisthesis with a deformity, so that's what I said. You have to treat this as a deformity, not as a
OT2, we are
listhesis.
talking to OT1. We will come back to OT2 in few minutes.
Garrison or dispense?
Yes, sir. Appaji, sir, you tell. So we are into OT2 live. OT2 who is there? OT2?
This is OT3, no? यही OT2 है. Hello.
OT2 who is there?
Hello.
Yes.
Am I audible?
Yeah, you are audible.
Yeah, we are from OT2.
Okay.
So I'll just give the mic to Dr. Javeri.
Okay.
Sandeep,
Yes, sir.
where are you with us? Is some other surgery, Dr. Apparji's surgery is over?
No, sir. Appaji surgery is there in the PIP, and your OT, we want to see your case. Your
Okay, good
history.
morning everybody. I'm Dr. Gautam Zaveri, and with me I have a team of Dr. Gurdeep Das, who is the Associate Professor of Orthopedics and Spine Surgery at the All India Institute of Medical Sciences in Bhubaneswar. And we also have Dr. Jain, who is Ashish Jain. He is from Lucknow itself, and he is also going to join us. I will first take you through the case. Can you please focus here, cameraman? So this is a 15-year-old boy who has been having back pain for the last 4 months. He has progressively increasing back pain. He has developed a kyphotic deformity over the spine. He has no neurologic deficit. His X-ray picture, as you can see over here, shows this is the lumbar spine going into the thoracic spine. This is D6. The D5 vertebra is completely destroyed, and this is the D4 vertebra over here on the lateral view. You will appreciate this more in the MRI picture. This is the D6 vertebra which is involved. This is the D4 vertebra, and the D5 vertebra has completely disappeared. How do you know that? Trace this D4 vertebra. This is the spinous process. This is the D6 vertebra. This is the spinous process. The D5 spinous process is alone. There is no vertebra body with it. Now what has happened is, whenever one vertebral body gets completely destroyed, the body tries to compensate by causing kyphosis. And you can see there is a significant 40-degree kyphosis over here. But what has happened is the D4 body is now touching the D6 body. So it has already auto-stabilized. This is not going to collapse anymore. So the decision here is, and you can see prevertebral abscess, you can see epidural abscess, but there is no neurologic deficit in this patient. Now the question here is, what should we do? Should we operate on this patient? Obviously the primary problem here is instability and deformity. So what do we want to do in surgery? Stabilization. The second thing in surgery that we want to do is, usually we want to decompress. But if he has no neurologic deficit, the decompression is not necessary because the infective tissue is going to go away with anti-tubercular drugs. So we are not bothered about decompression that much in this patient. But the third problem is this anterior column reconstruction. There is a problem here in the anterior column, the D5 vertebra is gone. Now we have three options for anterior column reconstruction. The first is we accept this deformity. We don't do much, it's not bad, it is in the middle of the thoracic spine. All we do is stabilize the spine by putting in thoracic pedicle screws and compress a little bit. Don't even decompress, don't stabilize, don't do an interbody fusion, just decompress, just stabilization, and interbody fusion is already happening, in situ fusion. The second option that you have is that you can do a decompression transpedicular, remove this pus and granulation tissue, and then compress body, bring body on body. If you bring body on body, you will have corrected partially the deformity, but you will not have to put in a cage anteriorly. And the third option is to put a cage anteriorly. So we'll see what to do. My plan, surgical plan right now, is to open the patient through a posterior approach, put in pedicle screws. This is D4, we'll put pedicle screws at D2, D3 and D7, D8. So we'll put 4 pedicle screws. Then the next step will be, at least on once, if we plan to do a transpedicular decompression, on one side we will put a rod. Because when you do a transpedicular decompression, you are destabilizing an already unstable area. So the spinal column can translate forward. So to prevent that translation, we'll put a temporary holding rod on one side. And then if we are doing the transpedicular decompression, we will go down the other side, debride, decompress, and then correct the deformity and put in a cage. So that is the plan. Now, to show you how we are executing, can we go on to the patient? And I would like to show you the positioning of the patient. Now, the positioning of any patient in any surgery is vital. So this is in the mid-thoracic spine. So this is the level of the kyphosis. You can see the kyphosis which is over here. When we position the patient prone, I like to use horizontal bolsters. This inferior bolster is placed around the curve of the iliac crest so that
Sir,
there is
we cannot see the bolster. He has focused on the patient's skin.
Now can you see the bolster?
Ask him to zoom out, sir.
Zoom out कर. थोड़ा पीछे जाओ और पूरा patient दिखाओ. ये दिखाना है. दिख रहा है? So ये जो है, these bolsters, one bolster is placed.
Zoom out करो, और zoom out करो.
Placed below the curve of the iliac crest so that it does not press on the abdomen. The abdomen, as you can see, is completely free.
Yes, sir.
Especially the lower abdomen, you have to check. This upper bolster is placed below the lower thorax to give it proper support. I don't like this. I want the shoulder and elbow to be at less than 90 degrees so that there is no stretch on the brachial plexus and also there is no stretch on the vessels. So blood flow is good. And on both sides you put this at less than 90 degrees. The head of the position should be in slight flexion of the neck. This is especially important in older patients because as you get older, you develop spondylosis. So if you keep the neck in extension for surgery in thoracic or lumbar spine, patient may wake up with a neurologic deficit from a cervical spine. So therefore, slight flexion beautifully given over here. We then position here, the patient is positioned on the head ring. when you are positioning, make sure the eyes are completely closed like this, and when you close it, you have to put a tape on that. After putting the tape, put gamgee and then strap it so that there is no leakage of any chemical into the eye. And make sure there is no direct pressure on the orbit, because that can result in neurologic deficit. The elbow, knee, hips are flexed and the knees are flexed. I usually in Bombay, we put a couple of pillows below the legs in order to flex the leg. Okay, so that is the type of position that you do. Remove all the clothes. Here, by the time I came in, these clothes were already there, so I am not changing it. The last thing is you are operating on the upper thoracic spine, which is sloping down. So can we do a head high? Does the table go into head high? Table tilt hota hai? Nafis, table tilt karo aisa head high. So last thing you want to do is to take a head high so that your operating area is parallel to the floor. You want the operating area to be parallel to the floor. Very good. और थोड़ा बस और थोड़ा हेड ऊपर टेबल ऊपर लो. So that's perfect. So the operating area should be parallel to the floor. That makes your surgery easier. Now, the other reason to give head high is because the venous congestion reduces, so your bleeding it reduces during surgery. So this is your positioning. Now we will paint and drape. The pre-operative antibiotics have been given just now about half an hour back, and we are now going to paint and drape the surgery, and Dr. Ashish Jain and Dr. Gurdeep will take you through the exposure of the patient.
Thank you, sir. So, PIP reverse. Yeah. So, OT2 in PIP. OT2 in PI, yes, okay. So, Appaji sir, can you listen? Can you hear my voice? We cannot hear you, sir.
Tell them to.
Yeah, now we can hear. Hello?
So we are doing an interbody work.
Yes.
So we we have the rods on both the sides. We identified that's a L5 root.
Okay.
So we are doing the interbody preparation.
Okay, sir.
So we will do the sizing and then that's it. We are done.
So that is the annular hole.
Yes.
Where they are putting the disc forceps.
Heavy duty nahi hai kya? Really?
So the instrument which sir is holding.
I am holding the nerve root of S1.
So sir, what the instrument sir is holding is the nerve root retractor, and he is holding the S1 nerve root, which is the traversing nerve root, which is being protected, and in the hole from the annular hole, these are the curettes which are being used to scrap the end plates.
Is that correct?
Yeah.
So Appaji, one question was asked. Do you do interbody fusion in all, or there is some scope of posterolateral fusion also in listhesis?
No, not when you reduce. If you reduce, you should do an interbody fusion.
So this is the answer. Like even if the patient has grade 1 listhesis, you are reducing the spine, so it's better to go for interbody fusion to achieve good fusion between two vertebrae. So sir, do you have any indication of posterolateral fusion?
I have not done for last 20 years. Sergeant sir has not done for last 30 years.
Okay sir, so nowadays all the surgeries is almost interbody fusion. You can do in whatever way you want, TLIF, PLIF, OLIF, LIF, LLIF, but interbody.
So not 20 years, 15 years, because 5 years with Sergeant sir I was a fellow. So
but where I have trained, I trained with Somajit Basu sir.
They do
so
PLF.
there the concept we were using is like if there is grade 1 listhesis, degenerative, and the disc is not very tall, there we used to do posterolateral fusion. And if the disc is very tall, the facet has lot of effusion. If there is tilting of the vertebra, or there is a grade 2 listhesis or 3 listhesis or lytic listhesis, in all those cases we used to do TLIF. So if you ask me what was the percentage of TLIF versus posterolateral fusion, it used to be 70 or 80% TLIF and 20% posterolateral fusion. We have other people also, Dr. Rishi, Dr. Shwetab is from Ganga Hospital. He has done his Gangaram Hospital FNB. He'll tell about the TLIF and PLIF.
Especially in these patients who are of dysplastic listhesis, the role of PLF, the posterolateral fusion, is quite restricted because these dysplastic patients have got hypoplastic transverse process. So the intertransverse membrane is very short. You don't have adequate bed for the graft to lay on. So these type of dysplastic patients must get an interbody as which is being done now. So even in our fellowship days, we hardly saw maybe 10% patient getting a posterolateral fusion. Most of them ultimately had an interbody because that is the area where there is highest amount of blood vascularity and a graft bed is properly available. So in dysplastic listhesis, getting an intertransverse fusion is very difficult. So that is
So we have Dr. Naseem from Manipal Hospital. He has trained under Dr. Vidyadhar sir. So let me talk to him like in what all cases he does posterolateral fusion.
Usually there is a concept nowadays that for posterolateral fusion, they say that if area of the transverse process is more than 2 centimeters square, then the results of posterolateral fusions are very good. If it is less than that, less than 2 centimeter per square area of the transverse process, then it is better to go for interbody fusion. In case of dysplastic, it is better to go for interbody fusions rather than posterolateral fusions because most of your brunt on the screws, it is minimized by interbody fusions. Whereas posterolateral fusions, the posterior parts are already dysplastic. The fusion, if you are planning for posterolateral fusion, in case of dysplastic cases, the fusion potential is already less.
No. We are convinced that in dysplastic listhesis we will do interbody fusion. We are talking about, is there any indication where you do posterolateral fusion? Any indication where you do posterolateral fusion?
Posterolateral fusions, I would rather go for...
Or is it like you do 100% TLIF only?
In case of dysplastic, if you are talking about this...
Does all your lumbar canal stenosis or listhesis patient undergo 100% TLIF? Or there are some patient in whom you do posterolateral fusion also?
See, posterolateral fusions and TLIF both have equivalent results if you are going for grade 2.
Till grade 2.
Till grade 2 you go for posterolateral fusions. If it is more than that, then it is better or we are more inclined towards transfer.
According to Dr. Naseem, even grade 1 you can manage by posterolateral fusion. What about myot, Rishi? What was the trend in the myot? Will you do all cases as TLIF? So is there any strategy to prevent collision between these two screws? So you can see the L5 is almost reduced over S1.
It is not completely reduced.
You can.
Yeah, it's reduced to grade 1 only. We are not able to reduce it fully. But the lumbosacral kyphosis has got reduced a lot. Can you see the L5 now? The
Yes.
L4, L5 is come in the harmonious lordosis now.
Yes.
And then the interbody space is more than, somebody was discussing about 30-40%. It is more than 40% contact has come. So
Yes.
we should be able to, once we compress it posteriorly, we will get a good reduction of another grade. So it will be grade 1 minus one reduction of another grade. So it will be grade 1 minus once we finish the surgery. Okay?
Okay, sir. So can you answer that question like what are the strategies to prevent collision of the screws if you are putting reduction screws?
Reduction screws, that's what. So the main crux is do not use force. So never use force to do any reduction maneuver. Do it like what we call as creep in fracture reduction. So use the same creep in spine also. Hey, the suction is not working.
OT2 in PIP please. OT2 PIP में कर दो.
ए सक्शन थोड़ा देख लो यार.
OT2 PIP में.
दोनों सक्शन.
So any other question anybody has?
So when you are using the reduction maneuver or a reduction screw, be careful, use the creep, let it, suction काम नहीं कर रहा है यार. ये वाला बहुत धीरे-धीरे काम करते हैं.
Hello. Appaji sir, this is question for you.
Yeah.
So when you are doing a high grade listhesis like this,
Yeah.
so if you are using a bullet cage, so you want to go use 2 cages or just one single cage is good
One
enough?
bullet cage is a olive cage.
Yeah.
What is the length? 24, no? 26. Give me the now root retractor. So bullet cage is a T-lift cage. So it is usually used as a single cage.
Yeah.
Not as double cage. Only P-lift cage is used as double cage.
So I agree, but in such high grade listhesis for stabilization, do you one is good enough?
Yeah, one is good enough.
Okay.
ठीक है ना? तो इसको right तोड़ और मार लेंगे. Yeah. No, आगे नहीं. I wanted to open like that.
So what degree of reduction we are aiming at final closure in this case?
वो निकालने के लिए दे दो. नहीं है ना सही सर? 10 kg. Yeah. Bone graft. ये तो knife.
So that is the annular hole in which suction is there.
Yeah.
So
we have prepared the interbody space. We have got a good bony end plates. Wash ready.
So this is the annular hole from where we will be putting bone graft. We will be putting cage into the interbody space, into the disc, and it will lie between the two bodies.
You want to, then you have to correct it. But we can do it, we can compress.
Compress it, yeah.
So shall we accept?
Wash. Mallet. So we are putting the interbody graft. कितना है? Nicely. Yeah. No. Mallet. Cage. 10 into 26 ना? Dissector. एक मिनट. क्या पता नहीं मेरे. Mallet. और जाना है? और जाना है ना आगे?
Sir, are you hammering the cage?
Yeah.
So the cage is inside, but surgeons feel that the cage should be pushed more forward. So these are the punches which we use. That's the punch which will be kept at the cage and hammered, so the cage goes more inside. And we will check the position of the cage in X-rays also, C-arm also.
Yeah, the root is here, root is free. Yeah, we are below the bone, Yeah. So we'll.
Right. So shall we compress it?
Yeah. Come detox tightener. C-arm ready. AD line, na? Probably we should have distracted. Maybe.
Yeah.
Yeah, I'm just going to loosen it.
Is it ridden over the top? No.
Yeah. Huh?
It's not ridden over the top of the rod. No.
No.
Yeah, now it is. Okay.
ठीक है?
Yeah. Oh. Okay. Is it okay? Is there rod? Yeah.
Yeah.
Just
So in situ, not in situ.
Yes. Okay.
Over compression.
Some more?
Yeah.
Okay. Compressor.
I'll loosen it. Once sir puts it, I'll loosen it.
Yeah. Okay.
Or?
Got.
Just to orient you guys, I mean in the other OT, we're just checking the levels. So that is why sir has put the needles over there.
Wash.
So those are the needles in place just to see the levels under C-arm, so that we are in the correct position when we start exposing.
So this pediatric listhesis is almost done. Screw were in place. Abhi hoga. They will take. So Appaji sir, you will take the picture, lateral picture, see how?
Yeah. We are going to take the lateral picture now.
Yes. So the screws,
vancomycin
screws are in
powder
place and bone graft was put, the cage is inserted and compression was done. So this almost work is done. Final X-ray picture will be taken to make sure that everything is in right place.
It will come to grade 1. Because the body itself is only 35. This is more than what we achieved closed, and with compression it has moved a little bit more posteriorly. To get that kyphosis.
Sir, what is the post-op rehabilitation protocol for these high-grade listhesis?
Monosegmental, where you can see the, No, 90. Yeah.
Audiovisual team, can we just have the C-arm image in the other OT, OT2?
Yeah.
OT1, sorry, in the OT1, can we have the C-arm image, please?
और इस तरफ थोड़ा इस तरफ बस
OT1 audiovisual team. So guys, here we have the pediatric listhesis reduced case over here. The lateral image which we were waiting for a long time.
No.
It's almost ये पीछे वाला है. So it's almost.
So it's almost.
Can you guys, Sandeep? Give me an artery.
Yes sir, we can hear you.
Yeah, can you see the picture now?
Yes.
So this is the harmonious see, you saw that the sacrum was like this.
Yes.
And L5 was lying down like this somewhere. Yeah, here you can see the sacrum is straight
Can you focus this?
Yes.
And then this was the pre-reduction, right?
Yes.
Now if you can see L4, L5, S1 is come in a harmonious way.
Yes.
The L5 end plate is, S1 end plate is here, L5 end plate is here. So
Yes.
it's almost like grade 1.
Yes.
We got a cage which is like slightly anterior, but we want it slightly anterior because we don't want the L5 root to be irritated here.
Yes.
So it is almost reduced to grade 1.
Yes.
But the most important thing is you can see the sacrum has come into like 30-35 degree of lordosis.
Yes, sir.
From a straight sacrum like this and a L5 like this, you have a S1 and L5. Like if you do a slip angle now, it will be almost like less than 10, which is acceptable.
Yes, sir.
Okay.
So this is very important in listhesis. It is not, the most important thing is not to achieve grade 0 listhesis.
If you can, you can. Yeah.
The most important thing is to achieve the alignment. That is that takes precedence over the amount of listhesis or the reduction in listhesis.
Sir, can you outline the sacrum, promontory and the anterior sacral
I
borders?
will do that. I
Yeah.
will do that. Yeah. So you see the screw here. That's the L5 screw.
Yes, sir.
That's the L5 body.
Yes.
Okay. So that's the sacral. This is the posterior element of the sacrum. This is the anterior element of the sacrum.
Hmm.
So we went into the promontory, right?
Yes.
So the screws have breached the promontory. They are like 1 or 2 millimeters or 4 or 5 millimeters anterior to the promontory. So
Yes.
the sacral promontory is going there.
Okay.
You can see this C-arm picture, it's going there. So
Yes.
the screws are slightly anterior. So we got a tricortical purchase, as I said. And the L5 is a trapezoidal, it's not a rectangle like that, right? It's a trapezoidal body. It's not a rectangular body. So you see that the anterior is slightly more towards the S1. So that is L5. This is S1. So the posterior line, body line is here.
Yes, we can see, sir.
Yeah. It has reduced to grade 1, not 0, but this is what we wanted. We wanted to achieve this lordosis of the sacrum and the L5 coming out into the sacrum.
Sir, just one hypothetical question. If we want to achieve 0, what else we could have done?
In this case, see the issue is it's a very small body. The end plates were very cartilaginous. We couldn't even scrape out the end plate clearly. So we were trying to be careful. The only thing which we could have done otherwise is, I think we would have achieved the same grade 1 reduction if we had done a distraction between L3 and S1. The Harms technique. That we have done for few cases, but when we get a reduction like this, we usually do not go and do a L3 breach unnecessarily.
So any advantage in if we would have gone one level up?
If you do not have a good hold on L5, yes, but L4-5 is a new mobile segment now, so she will have a better mobility. If you have gone to L4, you are unnecessarily immobilizing a mobile level.
Sir, one last. Sir, would you prefer little more compression posteriorly to achieve a little more lordosis between L5 and S1?
We were discussing that, but I think we have compressed more than enough.
Okay, sir.
So the cage anteriorly will not let us compress it more posteriorly.
So anything specific for post-operative rehab in such patients?
Yeah,
Because
so
I think
post-op rehab,
they kind of got a lot of stretch pain, these patients, when you reduce high grade.
No, that's what. So previously when we used to position the patients in a flexed hip position, we used to, in the post-operative ward, keep the patients in a 90-90 flex position and extend the hip slowly. But these patients are mobile from next day with a good lumbar brace. Anything else?
So guys, in my opinion, I mean, we not even target a grade 0 reduction. Grade 1 is more than enough because reducing to 0 it causes more of, it can cause a more of traction injury. And reducing to 0 can itself become a reason for post-op pain and even a post-op
screw break.
So that is just perfect in my opinion. Reducing a grade 4 to grade 1 is ideally
Sandeep.
grade 5. Yeah, so that is just
Sandeep.
perfect.
Yes, sir. Yes, sir.
You want to ask Dr. Egde any question?
Dr. Hegde sir?
Yeah. Yeah.
No, no, there is no more questions now. Whatever people will ask,
During the lunch break.
Yeah.
Yes, okay.
One
Thank you
more.
then. We are closing up and then we'll start the next case here after half an hour.
Okay, sir. One more thing, Dr. Appaji and Sajjan sir said that the most important thing in spondylolisthesis is not the grading which you have to reduce. The most important thing is you have to reduce the slip angle, which Dr. Appaji mentioned, which is more important. Because slip angle is one thing which you have to harmonize. In that case, he has reduced that slip angle to less than 10 degrees. Slip angle is what? You take a line either from the superior end plate or the inferior end plate and a line along the posterior cortex of the sacrum and perpendicular to that. In case of dysplastic listhesis, that slip angle is more. So if you reduce the slip angle, if it is less than 10 degrees, the harmonious nature of the lumbar curve and the lateral curve is achieved. And it will serve much purpose rather than going from grade 4 or grade 5 to grade 1 spondylolisthesis reduction. So slip angle is much more important, and in this case Dr. Appaji said that he has reduced it to less than 10 degrees, which is quite commendable.
So I think on behalf of the audience, we thank you, Dr. Hegde sir and Dr. Appaji, for nice demonstration and discussions.
Okay. So in OT2 we have this case of tuberculosis which Dr. Gautam Javeri sir is operating. So anybody want to have some break, they can go out and they can come back, because here the exposure is going on, and in another OT we will have another case. So we can have a break of 5 or 10 minutes. So everybody had coffee at least. No, no, now the battery is on. Now we will talk about this case. So, hello, OT2, can you hear us? OT2? OT2? Hello?
Hello, hello. Yes.
Hello, OT2?
Gurdeep, are you able to hear us? Gurdeep? Dr. Ashish?
So, all of you must have seen cases like this, where one body is completely destroyed, and there is some compression over the cord, but the neurology is normal. So, is there anybody who does not want to operate this patient? Anybody is there who does not want to operate this patient? So, what is the approach? What is your approach if you see a patient of spine infection? We will not say TB, it's spine infection. If you see a patient of spine infection, what is your approach? Like history examination, and you have taken the history, you have done the examination. Obviously, you will order an X-ray. On X-ray, you find some erosion of the end plates. So, you think that it is infection. What is the next step you will do?
Sir, if the neurological status is normal.
Neurology is normal. Patient comes with back pain, night pain for let's say 2-3 months, and examination is normal. He has tenderness in the back. You get an X-ray and you find some erosion of the vertebra, end plate, some erosion of the end plate. So, what is the next step you are going to do?
Sir, we have to confirm the diagnosis. We can go for the biopsy, sir.
No, you have done X-rays. So, are you not going to order MRI?
MRI, yes, sir.
Okay, you'll order MRI. Okay, so you have X-ray and you have MRI. So, sir, in the MRI you are seeing some edema of the bone, L3, L4 bone, and some pus in the psoas. So, what do you say? The history is of 3 months. So, what does your mind says? It is TB. Start the ATT.
We want some blood, other investigations.
Oh, great.
Yes.
Blood
CBC,
investigation also. What blood investigation you will do?
CBC, SR, CRP.
Great. And what is the purpose of doing that?
We want to know the ESR basically.
Okay.
We want to know the further follow-up of the patient.
Hello, Sandeep. Yeah, we can hear you, Ashish sir.
Hello, Sandeep.
Yeah,
so we are right now exposing.
Yeah.
Can you see the live field?
Yeah, we can see the live field. Can you orient us to the field? We have audiences who have taken coffee and samosa and jalebi. They are charged now, and they have a lot of question for you.
They must be charged, and the blood sugar must be high of each of us. Each of you might be sleepy, so I'll just orient you.
Yeah.
So this is the cranial side.
Which is the cranial side?
With the
section we can follow cranial.
Yeah, section is the cranial side.
Okay.
This is the caudal side.
Okay.
This is the right. Yeah.
Show with
the
the
right
section.
side.
Yeah.
This is the right side. This is the left side.
Okay.
Dr. Gurdeep has done a fantastic exposure, and we are there. Dr. Shwetab and myself.
So we want you to show audiences the supraspinous ligament, the spinous process, the lamina. Slightly you can work, slightly you can erase more of muscle and the tissue so that they can see live.
Yeah, sure. We are showing you that.
Your voice is less audible.
Hello, yeah. So we are showing you that. So this is the spinous process. Can you appreciate this?
Yeah, we can see that spinous process.
This is the interspinous ligament.
Okay.
Yeah, and you can see the lamina over here of the dorsal spine.
Yes.
So we have tried to do an exposure so that we can put 2 screws above and 2 screws below the involved segment.
So whenever you are putting screws, we want you to show to the audiences the entry point and the Lenky probe and the entry owl.
Sure, give us a minute for that.
Yeah,
Sandeep,
sure.
Give us a minute for that.
Yeah. So we are discussing about how people approach a case of infection of spine. So whenever you want to show something, you speak, we will listen to you. So okay, so you have done the CBC, ESR, CRP, and you have seen the CRP is high, ESR is high. Anything you want to see in the CBC?
There is a lymphocytosis.
Okay.
And most of the patient there is a POTS spine, there is low HB.
So we will not use the term POTS spine as of now. We will use only infection of the spine. Okay, infection of the spine. You can see either increased neutrophil count or increased lymphocyte count. So what is the next thing which you will do? We have done the blood investigation. So you understand English? Yeah. So you have there is a patient, 30-year-old male, who gives history of low back pain for 3 months, and on X-ray also he has night pain also. On X-ray we are seeing L3, L4 some erosions. On MRI there is edema of the bone and there is psoas abscess. Blood investigation was done and we have seen CRP to be high, and there is also increased lymphocyte count. So what is the next step you are going to take?
Sir, we send MRI.
No, we have done the MRI and we are seeing psoas abscess, edema in the bone and some erosion of the bone, but no nerve compression, nothing. So what you are going to do? Are you going to start some medicine? You are going to order some more investigations?
More invasive investigation. We take a biopsy then.
You do biopsy. Okay. So there is, you don't want to start any medicine? Yes, you want to say something? You don't want to start any medicine for the patient?
Sorry to interrupt you, Sandeep. I have an important announcement for all delegates. Those who want to present posters. So what you need to do that just deposit your poster just in pen drive or something that you have. Mr. Rishabh sitting down there, and you can just send your posters to that guy so that we can start your poster. We can display your posters, and the poster session is going to start by 3 p.m. probably. We'll update you regarding the time, but what you need to do, all the delegates who are interested to present posters.
Ashish sir, this is very excellent exposure. We can see the lamina very beautifully here.
I was waiting to comment, Sandeep. So before the exposure starts, we have to take a meticulous note of the patient positioning. We have to ask the anesthetist to keep the BP maintained. For more bloodless exposure, we usually take into note that tranexamic acid has been infused prior to the incision, and it depends on practice to practice whether you want to infiltrate with adrenaline or not. That has got its own advantages and disadvantages. So right now we have tried to expose because the culprit level is D6 and that has been completely collapsed, so we are exposing 2 levels up and 2 levels down. And right now we are about to check the levels. Before making incision, we put a needle, as you saw in the audio earlier. That needle was used to check the level, and now we are, after exposure, we are rechecking the level prior to putting the screws.
So what is your plan? Are you going to put 4 screws up and 4 screws down, or 2 screws up and 2 screws down?
So 4 screws up means 2 levels up and down.
Okay, so you are going to 4 screws up and 4 screws down.
Exactly, that's the plan.
Okay. So
right now we are checking the level. So you can probably see that we are putting the image intensifier in place. Can we have the C-arm picture?
C-arm picture?
Yeah, I think the cameraman is trying to align us to the C-arm picture. So in the exposure, it is important that we have a bloodless field. We stay as close to bone as possible, not enter into the paraspinal muscles. And we try
not
to
able to see the C-arm picture because of the C-arm this.
Gurdeep, you are coming in front of the camera, I guess. Yeah, so Dr. Gurdeep.
Yeah, now we can see the C-arm picture, yes. Yes, we are into the lower vertebra.
So we have started to identify the level. We got into the D7 vertebra, though a bit inferior, we'll correct that. But above that, you can see the kyphotic mass, that is the D5, D6. So that is our lowermost instrumentated level. So now we'll start with instrumentation.
So your entry owl is at which level?
At D7.
Okay.
Yeah, just above that you can see that kyphotic collapsed.
Yes, yes. So you are going to put D7, D8?
Yes, and above in D2, D3. Sorry, D4, D5.
D4, D5, yes. Okay. So, so we have one for delegate. Can you yes, just show this picture. Can you increase the brightness of this field? I'll tell the delegates the structures of the spine.
Yeah, I think I will ask Dr. Gurdeep to demonstrate the structure.
Yeah, Gurdeep, please tell the structures. No, you are not audible.
So just orient you again. So
Yes.
this is the caudal end. This
Yes.
is the cranial end.
Yes.
And I am standing on the left side, and Dr. Sweta is standing on the right side.
Okay.
So we put a marker at T7.
Okay.
And we have planned that we'll go to T7, T8. We will do a transpedicular decompression or something at T6, and we're going T4, T5.
Okay.
So that is our plan. So first plan is we'll put screws at T4, T5 and T7, T8.
Can you just show the lamina and the transverse process of the dorsal vertebra from
So-
a camera which should focus from above?
Okay. So can you see my pen field 4?
Change the yes, now we can see yes.
Yeah. So this is Dixon Cheney, so I am using that.
Yes.
So this is your spinous process.
Yes.
Then you come to this. This is spinous process, and this is the lamina.
Yeah.
And then you can see it is going laterally and cranially.
Yes.
So this is your transverse process.
Okay.
So in the thoracic spine, so we are in the mid dorsal spine. So in the mid dorsal spine, the entry point will be at the junction of the superior part of the transverse process and the lateral part of the lamina, the pars.
So when you have to instrument dorsal spine, make sure that you are exposing till transverse process, as it was also there in case of lumbar spine, because the structures of the dorsal vertebra and the lumbar vertebra varies. In dorsal spine you will have this triangular looking thing. So obviously when you start erasing the muscle, you will find this lamina, and just follow the bone laterally and you will find this transverse process. So this is
here.
important to instrument the dorsal vertebra.
So we can see over here.
Yes.
This is the transverse process.
Yes.
This is the facet joint. This is the inferior articular process of T6.
Gurdeep, you saw on the other side, that is seen very nicely. This side, yes.
This side?
Yes, yes.
Okay, okay.
Yeah. Now it is seen very nicely.
So this is the transverse process.
Yes.
And this is the lamina.
Yes.
And this is the pars.
Yes.
Okay. So if you see, this is the T6 vertebra.
Yes.
T6 lamina.
Yes.
Okay. So T6 lamina, this inferior articular process of T6 is overlapping the facet joint.
So this is the facet joint.
Yeah. So it is hiding the superior articular process of T7.
Yes.
This is the facet joint that you can see.
Yeah.
This is the facet joint of the dorsal vertebra. The orientation of the facets in dorsal vertebra is different. In the cervical vertebra is different, and in the lumbar vertebra it is different.
So the facet joints in dorsal spine are in coronal plane,
Yes.
whereas in the lumbar it will be in sagittal.
Okay.
Okay. So one can excise this inferior articular process, or what we can do is nibble off the superior part of the transverse process and line with the pars to get your entry point.
So this is how you get the entry point. Can you just retract soft tissue a bit and again tell this point again, because this is important. We can see this live. Retract the paraspinal muscle. Somebody retract, and then yes. Now you can tell slightly more. It is coming in. Yeah. Dr. Gurdeep, can you tell again? Dr. Gurdeep, can you tell the entry point again?
Hello, Sandeep.
Ji sir, ji sir.
This is Dr. Gautam
Yes
Zaveri.
sir. Yes sir.
Now we will do everything. Don't worry. Get this CM outside.
So we were on. So doctor, so you will start some medicine or not? You have done the MRI, you done the blood test, and you were told like we'll do biopsy also. So are you going to start some medicine, or you will wait for the biopsy report to come?
Hello.
Yes sir, we can listen you.
Sandeep, you can hear me, no? I'm just getting washed up.
Okay sir, okay.
And give me 2 minutes, we'll start off again.
Sure
okay?
sir.
So my
Guided by-
Gurdeep and Ashish
Yes, sir.
and the team have done Shwetav have done a fantastic job. They've exposed the spine in less than 15 minutes.
They didn't allow me to have a tea and coffee also. They were so fast. And I'm here. Anyway, so that's that. Can I have 8 number gloves, please, sister?
Okay.
Just give me 2 minutes.
So, sir, we are discussing with the audiences the approach to patient with.
Can I just? There are more since there are a lot of residents. Either rakh dijiye, sister. There are a lot of residents in the this thing. So I want to show them. ये जरा दिखा सकते हो? मैं gloves पहन रहा हूँ.
Just show.
I am at a head of department.
Sir, just wait, sir. We have the feed is from the OT1. We want the feed to be changed to OT2. Change the feed to OT2. Audio visual. OT2. Yes. Now, sir, will show you how to wear the gloves.
Department in a hospital in Bombay. The residents don't know even today how to gloves or gown. So this is how the glove is opened. You never touch the inside of the glove. You take the glove, hold only the outside and wear the glove. That is how a sterile technique is done. I have not touched the inside of the glove at all. Now this side, you hold it inside and you do. This is how sterility needs to be maintained. Now you put these 2 gloves in. Now you hold the gown. You have the gown. Now, with the sterile gloves, you have the gown gone in and you wear the gown. Boys, the most important thing in the OT is to make sure that everything is sterile. In orthopedics, the biggest problem is an infection post-surgery. One infection ruins the patient's life. It means an additional cost of 4-5 lakh rupees for the patient. They may be disabled and they cannot carry on their daily activities. So please make sure that you give your preoperative antibiotic within half an hour of the surgery. Make sure that the sister maintains a very sterile trolley, that all of you, when you pass by, you do not touch the trolley, and make sure that all this draping, painting is done in a perfect manner, gloving and all that. Before you learn surgery, learn these things. These are far more important. Surgery you can keep on learning. If you don't learn these disciplines now, you will not learn. So anyway, now that we are focused, this is the cautery tip is at the top end, that is the head end of the patient. Now the cautery tip is at the bottom end of the patient. So this is the head end, this is the bottom end.
Yes,
okay?
sir.
In this spine, can you come here? You are fine. So this is the exposure that Ashish, Shwetang,
the cameraman previous this is very nice picture. You keep this picture. Yes.
So this is the spine.
Yes.
Now it is vital in the thoracic spine that the exposure is done to the tip of the transverse processes. So this is the spinous process. Can you see that and appreciate it? This is going into the lamina here. In the lumbar spine, in the morning, you saw that Dr. Vishal and Dr. Appaji put it pedicle screws. The facet joint in the lumbar spine is like this. It is placed in the AP direction. In the thoracic spine, it is placed like this, which is that it is in the coronal plane. So this is the facet joint over here. This is the inferior facet of the superior vertebra. The cartilage is on the below, and this is the superior facet of the inferior vertebra. This is the transverse process. You must expose till the tip of the transverse process, which is beautifully done over here by the surgeons who have been assisting me. Have we confirmed the levels?
Yeah, it has been confirmed.
So this is D7, this is D6, this is D5, D4, D3. We are going to miss D5. We are going to go pedicle screws into D6 and D7. Is that correct? D6 is completely collapsed. So we are going into D7, D8. So this is D7, right? And this is D8. Now to plan your pedicle screw.
PIP reverse.
So first thing you do is, having exposed right up to the tip of the transverse process, always remember you must see the pars interarticularis to pass your pedicle screw. So this is the pars.
PIP reverse. PIP को reverse कर दो.
So this is the lateral border of the, this is the part of bone which is joining the superior. So this is the pars interarticularis. And if this is the pars interarticularis, I have to go in line with the pars interarticularis on this ridge. Can you see this ridge? So this is your entry point in the thoracic.
PIP reverse करो.
निबलर देना sister.
Sir एक second PIP reverse करना है. Hello?
PIP reverse करो भाई जो.
Audio visual. हाँ. अब sir बताइए ridge sir. So we need little more light in the operative field. Little more light in the operative field. It is very dark. Where cautery is there, nothing is seen.
लाइट थोड़ा देना, ये लाइट थोड़ा एडजस्ट करो, ये लाइट थोड़ा, ये थोड़ा.
Can you increase the light inside the operative field?
So my friends, what is important is that surgery step 1 to step 100 has to be the same every time. That is important and that will improve the speed of your surgery.
So which ridge you were talking about, sir?
So you can see this transverse process here.
Yes.
This is the transverse process of the D8 vertebra. This is the pars interarticularis. So I am going at the lateral border here and this is the ridge which I will put my screw from. So how do you do it? You take a nibbler and you take off. See the direction of my nibbler. My nibbler is cutting bone in a mediolateral direction of the transverse process. Okay? Bone. Keep the bone, please. Starter.
Now the light is good.
So now you see this is the lateral border of the pars. Can you see that well, Sandeep?
Yes, sir. We can see, sir.
This is the ridge. So this is your entry point. Now we know that at D8 he has kyphosis and the vertebra is go. So the way to do it is to go parallel to the lamina. So perpendicular to the lamina and at an angle of 15 to 20 degrees medially. So see this again. This is the lamina. I am going perpendicular to the lamina and at an angle of about 15 to 20 degrees medially. You have to use the gear shift with two hands. One hand is on the patient's body to prevent your gear shift from plunging in, and the second hand does this in a wriggly rotatory motion. What is this? How much has gone in? So 30 has gone in. I'm going to stop at that. Filler and peanut with bone wax.
This is a ball-tipped filler.
So this is a filler. This filler is meant to feel the walls of the vertebra, of the pedicle. So you can feel the upper superior wall, this is the inferior wall, the medial and the lateral. So it tells you how deep you have gone. Very good. And then what I do is that I use a artery on which is applied this bone wax. Okay, so see this is peanut and peanut on that of that is bone wax, and then what you do is you apply this and you turn so that the bleeding from that area stops. Okay, so that is how you go. So it's as simple as that. Nibbler. Now we are going for the D7 screw. So same way, level 100%, bone starter. Okay, this is the lateral border, the pars, and this is the ridge from which I want to go. So this is the entry point. I'm going perpendicular to the this space. Okay, filler. Again, I can feel all four walls very well, so I am in good position. Bone wax. So you can see this is the bone wax. It has to be made into a small nipple at the tip. The peanut has to be held as distally as possible. And you make a nipple here of the bone wax and you apply it here. Push it down and rotate and your bleeding stops.
PIP में OT1 कर दो. PIP में OT1.
This is D6. D5 we have to go for. Actually, I just want to show you something. So, can you see this? I don't know how much you'll appreciate. This is the superior facet of this joint.
Yeah, we can see, sir. Here it is seen very nicely.
Which is there.
Your
It is
assistant,
being
can you
seen
ask
because
him
it
to?
is going down from kyphosis, so there is a little subluxation of the vertebra upwards, and therefore you are
Your
able
assistant head is coming.
So
Yeah, now see.
So just a small query. Why
So
are you?
this, can you see this? My
Yeah.
McDonald is going into the facet joint.
Your assistant head is coming, sir.
Okay, this is going into the facet joint. Okay, just to show you. Yeah. So who had a query? Please ask.
So why are you not putting screws at the same time rather than you're just making the hole or the end, and then you're not putting the screws and putting the bone wax?
Because you must remember this, that however I have put more than 10,000 screws, but for this patient this is the only screw which is going to go in, so I have to make sure it's in 100% in the proper place.
So you will put K-wires or
I will put
and
K-wires
check
and
under
I will make
image.
sure that the Siam that
Alright.
they are all in good position before I
Put this.
put the screws in. So we have a young audience here, and my request to you is don't be cavalier about any surgery, especially not spine surgery. There is no shame in taking x-rays intraoperatively and making sure you are in 100%. When I was at your stage in life, I used to take pictures while with the starter, with the filler, just to make sure that they were in 100% in the right place. So there is no room, there is no ego. In surgery, if you have an ego, your patient will suffer, eventually you will also suffer. You don't have to have an ego. ये देखो ये lateral, this is the cartilage, this is the pars interarticularis here. This is the ridge, I am on the ridge. This lamina is slightly facing this way, so I am going perpendicular to it. So here again I am in all four are in proper place. No, yeah, you also do put your 4 screws, then we'll do all 8 together. Chalo. We'll do the same thing. Dr. Gurdeep will do the same thing on his side. I think P8 is yet to be exposed on his side. So once that exposed fully, then he can do it. So, I don't know, you as surgeons, all of us feel we are the God's gift to mankind. But you must remember that there is no room for any cavalierness in surgery. You have to be precise, you have to be focused, you have to be meticulous. As I always tell, I never hurry during surgery. I always take time, but yet my surgery gets over very fast. Because step 1 to step 100 is the same every time. I know what I am going to do next, my staff knows what I am going to do next. My assistant knows what I'm, so it makes it easier. So there, Dr. Gurdeep has already put, because the exposure is so good, we are able to put screws so fast.
There are different surgeons do different ways. As Dr. Sanjay was asking, why are you not putting screws? Even till now, I don't put screws directly. I make hole as sir has made, then I'll put K-wires and I check AP and lateral. I check AP and lateral, make sure that my K-wires are in the right position. Let's say if they are not in very good position or slightly below or above, I'll redirect.
So
and then I'll put the screws.
Okay, yeah, so that is very good, Sandeep. I agree with you completely that you must take multiple, I mean you have to go stepwise, take your time. Don't chalao, kaam mat karo. Do the best kaam. This is your lateral border of the pars again here. This is the ridge. Can you see this? Appreciate this ridge. That is where he will start over here.
So in TB spine or in the infection of the spine, till now what the discussion which we had is the X-ray was done, the MRI was done, and we had discussion about biopsy. So there are different ways by which you can take out sample. Sample means a sample which can be tested. So if you have pus, so in different region you can have infection, cervical, dorsal, lumbar region. In the lumbar region, usually if the pus forms, it stays in the paraspinal, the psoas region, or it can go to the prevertebral region. So there can be a stay, if the patient comes very early, you might not find lot of pus. You might find edema inside the bone, a little bit of pre or paravertebral soft tissue. So there are different ways by which you can take out sample. One is by ultrasound guided. If there is lot of pus, the radiologist, they will do the ultrasound, they will see the psoas, they will put a needle and they can take out the pus. That is the easiest way of doing it. The same thing they can do in dorsal region also if there is lot of pus. Either ultrasound guided or CT guided. The second way of doing it, let's say if there is not lot of pus, then you have to take out sample from the bone, from inside the bone. And the way of taking out inside the bone is transpedicular route. You have to, like the way you are putting the pedicle screw, you have to make a hole in the pedicle. You need to have small forceps.
Samir, we have we have made entry points for all 8 screws.
Yes, sir.
Now we are going to mark and take a Siam picture, please.
So this is the marker which they are going to put in the pedicle. They'll put all the 8 markers and they'll take AP and lateral view. Just to make sure that all the position of the screws are in,
I'll put on my side. You put
are good or perfect or whatever is the position.
Because otherwise we won't be able to.
So the question arises, if there is not, you might send for biopsy to your radiologist if you are not doing yourself. Your radiologist might tell that the patient does not have lot of abscess. Pus is not there. So if the pus is not there, then they can take out the sample from the bone by CT guided method. That is the only way out. Or you have to take the patient in the operation theater and you have to take out sample by transpedicular.
Can I just
yes,
talk?
sir.
So you can see now we have put in temporary wires. On one side we have put pins which are thicker and
Yes,
the other
sir.
side thinner so that we can make out which side is which.
Yes.
The other thing is you can see that all the screws on both sides line up in one direction. So your adjustment with the afterwards is, so you must try to, when you are making your entry points, see that the entry points all line up in one line. So that subsequent. And then what I do is I put this towel to cover the wound and then bring the Siam in. So boys, do not be ashamed of taking, all that is bravado that I never take Siam and all that. Never listen to people like that. These are not good teachers. They are only self-glorifiers. You have to learn to take Siams. You have to 100% give accuracy during surgery. Be meticulous with your surgical exposure, thing, because one error is enough for us. And you know our field is a field where everybody can see your pictures post-op. And you know, you may have done a perfect job, patient may be fine, but your one screw is not perfect and he goes to some other surgeon, then he will say, हाँ सब अच्छा है, लेकिन ये एक screw कुछ गलत मजा नहीं आ रहा है. That is enough to put patient in doubt about you. So make sure that you do a perfect job. बस और थोड़ा head end जा. और थोड़ा बस shoot. Okay, so you can see the lower two screws, these two screws.
Can you show the Siam picture?
He is थोड़ा oblique है picture. थोड़ा head end जाने दे और थोड़ा floor की तरफ जाने दे. नीचे. नहीं ये oblique एक मिनट हाँ मेरे को जरा देखने दे. दोस्त ये जो है ना ये साइड ले ऐसा. पीछे ले, हाँ, और थोड़ा वो साइड कर, बस, ठीक है, अभी शूट कर, बस शूट, थोड़ा एक ही जगह पे रख, थोड़ा थोड़ा मूवमेंट्स करो, ये ऐसा जा रहा है, थोड़ा ऐसा करो, और थोड़ा और थोड़ा और थोड़ा और थोड़ा और थोड़ा, बस अभी थोड़ा नीचे आ जाओ पैर की तरफ, बस बस बस, बहुत ज्यादा हो गया, शूट, या बेटर, पेशेंट इज ऑब्लिक, तो ऐसा कर दे, कर पैर की तरफ, और ला टिल ही इज परपेंडिकुलर, जाओ और ऊपर जाओ, स्टेबल, पूरा ऊपर जाओ, ओके, वेरी गुड, चलो शूट,
So we were talking about taking out the sample. So sample you have to, why it is important to take out sample? Everybody just listen, that's it. So any patient who comes to me of infection of a spine, I have very simple thing. He asks me, sir, मेरे को TB है क्या? My answer is I don't know. आपको TB है, ये मेरे को पता नहीं है. आपको इन्फेक्शन है स्पाइन का, ये सच्चाई है. ये भी सच्चाई काफी हद तक है, बिकॉज एमआरआई में हम लोग अगर पस वगैरह है तो हम लोग बोल सकते हैं कि इन्फेक्शन है, अगर केवल सॉफ्ट टिश्यू वगैरह है तो उसमें मैलिग्नेंसी के चांसेस भी रहते हैं. तो द फर्स्ट क्वेश्चन इज सर इन्फेक्शन है, द आंसर लेट्स से इफ इट इज इन्फेक्शन केस आई विल से यस. क्या टीबी है मेरे को? माय आंसर इज आई डोंट नो. सो सर आपको कैसे पता चलेगा मेरे को टीबी है? वो उसका आंसर है हम सैंपल निकालेंगे, उसकी टेस्टिंग कराएंगे, उसके बेसिस पे ही हम ये बोल सकते हैं कि आपको टीबी है. और टीबी में भी आपको नॉर्मल टीबी, एमडीआर टीबी, एक्सडीआर टीबी है, ये भी हमारे सैंपल निकाल के टेस्टिंग कराने पर ही पता चलेगा. सो दैट्स हाउ आई काउंसल माय पेशेंट. और उसके बाद अगर पेशेंट बोलता नहीं सर आप ऐसे ही दवा चालू करो, हमको बायोप्सी नहीं कराना है, तो मैं अपने पर्चे पे लिख देता हूँ पेशेंट को बायोप्सी करने को बोला था, पेशेंट ने बायोप्सी नहीं करवाया है. कल को अगर वो, और मैं नॉर्मल टीबी की दवा चालू कर देता हूँ बिकॉज वो मोस्ट कॉमन है. नॉर्मल ट्यूबरक्लोसिस ऑफ द स्पाइन, इन्फेक्शन ऑफ द स्पाइन, नॉर्मल ट्यूबरक्लोसिस in 70 to 80% of the patients. Our practice is like that. So अगर पेशेंट बायोप्सी नहीं कराता तो ये पेशेंट की रिस्पॉन्सिबिलिटी है, हमने तो भाई आपको कराने को बोला था.
चलो स्केल दे, ये कितने का है? How much? 35, 40, what do you want to do? 35 का स्क्रू देना, 5.5.
One more thing you have to remember कि जब आप blood investigations करवा रहे हैं, the residents here said कि CBC, ESR, CRP, whatever is there, one investigation you forgot to mention is blood culture, which is very much important because it gives about 30 to 40% of the cases में आपको culprit मिल जाएगा. We are in a setup where TB is common, but you cannot rule out infectious spondylolisthesis also. तो आपको blood culture भी करवाना है, and after that जब आपके सारे investigations हो गए, you go for biopsy. Most of the times it happens कि biopsy के results inconclusive होंगे. You go for transpedicular biopsies and results are equivocal, कुछ नहीं भी आएगा, but you are suspecting कि ये infection हो सकता है. Then you have to plan कि मैंने transpedicular या जो भी biopsy ली है, so my results are unconclusive, but clinically I am inclined towards कि infection है, तो you should be able to go for other forms of biopsy. आपको open biopsy भी करनी पड़े, you have to plan it because you want to find the culprit.
So now what has happened is that if you see the screw, I can feel it is very good. It is
Sir, your voice is not coming, sir. It is coming very less. The volume is very less.
Now I am in the pedicle.
Yes, sir.
But the CM shows that the screw is slightly angulated more distally. So I want to change the direction. So now with tapping, I said tap. Why is he giving you everything but tap? Tap देने का, हर एक चीज में tap देने का.
So this is very important. What sir is asking, after you make a hole, you have to tap the hole.
When you are tapping, you can change the direction of your screw also. If you are not very happy with the direction, if it is out, it's a different matter. Here it was not out, it was in a good this thing, but it was still, I wanted to change it to make it look better. So I just changed the direction.
So you will give more importance to your anatomical feeling of all four walls and floor intact, or the C-arm orientation?
So the four wall intact thing is very important for me for the mediolateral thing. The superior inferior I can see very well on the lateral view, so I will depend on the lateral view for that also. ये रिमूवर के लिए ये पिन रिमूवर दो.
We welcome here Dr. K.D. Tripathi from Allahabad, Prayagraj.
Dr. Javeri, do you always tap it?
Always.
Always.
But I under tap it.
Okay.
So if I am putting a 5.5 mm screw, I will tap to 4.5. If I am putting a 6.5 mm screw, unless it is very osteoporotic spine, then also I will tap, but I will just start off with the tap. क्या 35 का स्क्रू दिया है ना सब फर्स्ट रेड. Again I am feeling after tapping, because with tapping you are increasing the width of the diameter of the canal of your hole, so you have to feel that you have not broken through. We'll do the same kind of tap with the procedure on Gurdeep's side. Start. My friend. Okay. ये दे दो रॉड दिखाओ. नहीं रॉड दो खाली डायरेक्टली. इससे बड़ा लगेगा. एक मिनट कट मत करना, पहले देखते थे ना क्या साइज चाहिए. एक आर्टरी दो सिस्टर. चलो उसको स्क्रू दो और एक 35 का लोड करके रखो. मेरे को इतना रॉड चाहिए. ओके चलो. टैप उसको दो. मेरे को रॉड काटा. और लिए हर एक जन अलग अलग बोलता है. थोड़ा मैं उसको प्रो बोलता हूँ.
Sir, what is the size of the screws we have used? 5.5?
5.5.
At all 4 levels?
At all 4 levels. I generally in the lumbar spine I use 6.5. In the sacrum I use 7.5. In the thoracic spine up to D8, D9, D7, D8 I generally use 6.5, and then above from D8 to D4 I use 5.5. At D1, D2, D3 I may use 4.5 or 5.5 depending upon the size of the patient. This is typical bender.
And how you decide the length? How deep you go?
The length is decided on CM picture. Bas. Thoda. Bas. You can easily see the picture. Na? So here, for example, on the CM, I thought we were short. So it was 30, measured at 30. So we put in 5 millimeters long and decided to go for 35 millimeter screw. Or ek rod le le.
Dr. Javeri, suppose the disease is on D10, 11. So you take D9 and D12, or you use the D10 and 11 vertebra?
So usually what happens is that we don't put the disease in the destroyed vertebra. But on MRI is a very sensitive test. It shows a lot of inflammation of the vertebra called as osteitis. So in those osteitis vertebra you can afford to put screws. So those screws I do not leave. Suppose I am spanning one destroyed level. Now in this patient D6 vertebra is destroyed. So only one level is destroyed. I am going to span only one level. Then I will put 2 screws above and 2 screws below. But suppose 2 levels are destroyed. Suppose I find that D5 and D6 are gone. Then I will typically use 3 screws above and 3 screws below. So the decision as to how many screws above and screws below is depending upon the length of the segment that you are going to be spanning.
PIP में OT1 दिखाइए, PIP में.
In those cases, actually, the X-rays or plain radiographs give you a better idea because the MRI is more sensitive, as told by sir.
Very good. Yes, I agree with you completely. You should always look. MRI tells you the pus and all everything. Diagnosis के लिए important है. But rod holder, please. What MRI does not tell you is the amount of bone destruction and health. So in order to plan your surgery, either plain X-rays or CT scan are far more. Sister.
So we discussed about one of the scenario where the patient did the biopsy, or we took out the sample. Patient agreed for the biopsy. We took out the sample. We tested the sample, came out to be tuberculosis, sensitive to rifampicin in the gene expert, and we started the CAT1 ATT. Now the patient is being managed. Now we will discuss about another scenario where the patient has
OT2 main picture.
where the patient has refused biopsy, or the sample which we have taken out is inconclusive. Neither any bacteria is positive, no TB is positive, nothing has come out. So Harpreet boss, what is going to be your strategy in that kind of cases? So we are talking about another case scenario where the patient is not agreeing to biopsy, or where the sample is inconclusive.
So Sandeep, you can see now all the screws.
Sir, can this audio visual OT2? Audio visual? Yeah. Yes, sir, we can see.
So these are the screws. The D8 screws are in good position. D7, all of them we have felt and passed.
Yes.
They all look perfect. There is nothing. Now we are going to put the rod, okay? We are happy with the screw position.
Yes.
We'll take the CM out and I will put a rod on the side opposite to the side from which I am going to do the transpedicular decompression.
Okay, sir.
Okay.
Sir, so is there any plan of putting anything anteriorly?
I am hoping, I will see now, yes, I am hoping to do so now we will do, so now we are putting in the temporary rod. I want to do a little bit of correction with this temporary rod. So I have kept it under contoured.
So you are putting rod on the right side of the patient?
Yes. You fix this.
PIP reverse. Reverse the PIP.
Final tightener.
PIP reverse कीजिए.
Final torque anti torque किधर है? इसके साथ जाएगा ना?
PIP reverse कर दीजिए.
Thank you. So now I am final tightening the lower screws.
Yes, sir.
Because I have no plans to at present to do anything more. So it will help me to reduce. आवाज आएगा एक ही कि दो? Can you retract?
PIP reverse कर दीजिए. PIP में OT1.
So I have checked that there is enough rod below the last screw. Now we have checked that the inner screw. Now Dr. Gurdeep is going to push the rod into the vertebra, and that's it. Now you can see we have corrected the deformity to some extent just by under contouring the rod, and now we are tightening it. Another nut. Okay. This now retract, remove, distractor, final tightener. Now I am going to distract a little bit between the two screws on Dr. Gurdeep's size. ऊपर वाला loose कर थोड़ा, ऊपर वाला loose कर दे. Now do this. In order to create a space for my cage. Ready? So I have distracted. Okay. Pass. That one you can just tighten. You don't need to fully tighten because we are going to compress later. So there your temporary rod is done. It is stable. Now I am going to do my transpedicular decompression. Let me just show you. This is the pedicle of the destroyed vertebra. Okay?
Yes, sir.
So can I just nibbler? I am going to cannulate that just so as to thin down the pedicle of that vertebra. Sister, save this bone starter.
Sir, how you decide from which side you are going to do transpedicular decompression? Here you are going from the left side of the patient.
So usually from the side of the worst neurology.
Gurdeep, can you put water from saline from little far? So this is the dural sac here. This is the dura, which you can see here, just below the bipolar.
So this is another important.
Whenever there is a severe compression of the cord or compression of the cord, there is venous stagnation in the area. So epidural vessels are a little bit congested. So you have to take care of them.
The method of using bipolar, because we are working close to neural tissues, the saline actually reduces the heat and chances of damage also.
Whenever you are using bipolar, you must remember that you never touch the two prongs. It has to be held separately and the tissue in between, because the current jumps from one prong of the bipolar to the other.
So sir, here in with audiences, we are discussing one case scenario. Normally we if we have a patient of infection of the spine, case scenario one was that we did the biopsy and we proved it that it is tuberculosis, and we have started the treatment. And the another case scenario is where the patient has refused the biopsy, or where the biopsy was inconclusive. So Dr. Harpreet, what is your plan for those kind of patient where the biopsy is inconclusive? What you will do, you will start pyogenic
No, biopsy is inconclusive when you have already taken a transpedicular biopsy under anesthesia.
There are, either we have taken the biopsy and biopsy was inconclusive, or the patient has refused biopsy.
So
in both the scenarios, we don't know the diagnosis.
So what I think is most practical is that there are two things you have to see. Is the patient history is typical of tuberculosis, and MRI findings?
Can you tell to the audiences the typical history of tuberculosis?
When you release,
if your patient is having pain for 3-4 months, pain radiating to the ribs, pain radiating to the abdomen, back pain, and slowly developing neurodeficit, and there is no other reason of immunocompromise. So your patient is not CKD, chronic kidney disease, chronic liver disease, he is not on steroids. So you have no strong reason to suspect pyogenic infection. So that is from history. From history you want to rule out that you have a strong reason to suspect pyogenic infection or not. That is number one. Number two is your MRI picture is typical of tuberculosis or not. If your MRI picture is also typical of tuberculosis, like you have a large pre and paravertebral abscesses with very little ESR, CRP raised, or maybe CRP is not raised, patient is not having any high grade fever. So these are all typical history and MRI findings of most likely it is tuberculosis. So if you can't aspirate pus or your biopsy is negative, then you can start ATT with patients in confidence that you can repeat after 6 weeks. If you are not able to
repeat after 6 weeks, MRI.
No. If the patient is not having any relief after 6 weeks, then you maybe have to do a transpedicular biopsy
So
under anesthesia.
what kind of relief you are expecting? Clinical or radiological?
Clinical relief. He should have a decrease in pain, appetite should improve, patient should report now I am feeling better. Then you can continue ATT with the clinical guidance.
Let's say at the 6 weeks patient does not say any improvement.
Then you have to either take him in confidence. If the patient is operative, he has lot of pain, then either you operate and take biopsy.
No, if the patient is conservative.
Conservative, then you have to take a call and take a biopsy under anesthesia.
Again biopsy.
Under anesthesia. Transpedicular biopsy under anesthesia.
And let's say if that also comes out to be inconclusive.
Then you have to operate. What is the point? How many biopsies you will do and it comes out inconclusive? Then if he is not responding to ATT, that is one thing you are saying, that after 6 weeks he is not responding to ATT. You have already done a biopsy. You have done a transpedicular biopsy under anesthesia. That is also inconclusive. Then there are only two options. Either you operate and take a large sample.
If the patient does not agree for operation,
then you continue ATT.
Yes,
you cannot start IV antibiotics without any reason. No?
So
continue ATT. Tell him to review after 3 weeks and 6 weeks, and you will follow. If there is a deterioration or patient develops neurological deficits, you have to tell them that now there is no option, we will have to operate. Or otherwise we can just closely follow you up. Sometimes patient responds very late on ATT. So he may respond at 3 months, but then he should not deteriorate. If he is deteriorating, then you have to take a call.
No, we are discussing about case scenario where neurology is normal.
That's what. But if he develops any deficit or pain is increasing, and your 2 biopsies have already failed, then I think somewhere he has to take a call what he wants to do.
Just I would like to add on of his talk. There are the many chances that the patient is having MDR, multi-drug resistance also. So keep in mind also these things also, because in 10 of my cases I have seen there was 3 of the cases was the pyogenic, as was showing the kissing lesion, everything was there. Pus has come out, caseing everything. I sent for the pathology and it was a non-tubercular. I have started the antibiotic for 3 months. After the decompression, responded well, but here
Antibiotic or ATT?
no antibiotic. Non-tubercular cases I was talking about. In such cases, pyogenic.
Okay.
I was talking about the pyogenic.
Okay. No, sir, you tell.
Kachra. Penfield 4.
So always keep aside also multi-drug resistant cases. They don't respond with the ATT.
So what we are discussing here is we are discussing about an hypothetical situation, or you can say practical situation also, which we have faced. So you want to say something?
So Sandeep over here.
Yes, sir.
The spinal cord is now exposed.
Yes.
This is the cord. This is infective granulation tissue, which is vascular.
This is the spinal cord.
I have finished the lamectomy, the lateral decompression on the opposite side. Now I am going to do everything over here. I need to remove this bone because that's from where my cage is going to go. So I am going to remove the bone now.
So you are planning to put a cage anteriorly, sir?
Yes, let us see what it shows once I do the transpedicular bone.
Okay, sir.
Sir, I'll read this side. I just wanted to know, do you do unilateral laminectomy and transpedicular fixation in some cases, or always it's a bilateral laminectomy and...
The other way around. Most of the times it is unilateral.
Yes, sir.
Because most of the times if you are putting a cage or you are doing in situ, your goal is to do a transpedicular decompression, not the anterior reconstruction. So unilaterally. Only when you are doing a massive shortening procedure, that is the time when you think of doing a
yes, sir,
bilateral, because then you have to want to shorten and you won't be able to shorten adequately bone.
Without removing both sides of the facets and pedicles.
So now I am trying to chase the nerve root. This is the nerve root at that level. See, can you see that? Sister, tie.
So whenever we are doing, we are thinking about anterior reconstruction in dorsal spine, we have
So
to
just have a look,
sacrifice the root.
Sandeep. This is important.
Yes, sir.
This is the vessels.
Yes.
This is the pedicle. This here is the nerve root. It's a
Yes.
very thin, small nerve root. I am going to tie it up and cut it so that I can go anterior to the dura. Okay, I am already in the already in the vertebral body, interbody space.
So in dorsal vertebra for anterior reconstruction, you have to sacrifice root.
Mosquito या artery दे दो.
So on that side, sir is going to tie the root, which you will find just below the pedicle of the whatever vertebra you are whatever the vertebra you are going to enter inside. So Dr. Harpreet, you want to say something? Dr. KD Tripathi, sir.
What the diagnostic
So
dilemma?
you can see the nerve root.
Yes.
You have to tie the nerve root. You can tie it preganglionic. You can try it postganglionic. Doesn't
Yes.
matter. So
So
now
do you always tie, or you can cauterize and cut it also?
you can do either, but I prefer tying because it reduces my risk of a dural leak. So I always tie, but
Yes.
you can do either, whatever you feel comfortable with. So artery.
So I'll just summarize what you
So I have tied it and I put a mosquito on it so that I can turn it around. Sisters, scissor, broad scissor starting में रखने को बोला था ना. तो tie cut. वही.
If biopsy is inconclusive,
Okay,
yes,
pencil
sometimes
yellow.
dry tuberculosis.
So I have tied and cut the nerve root.
In the dry tuberculosis.
Now I am going anterior. See, that's the anterior to the dural sac.
Yes.
Unfortunately, the suction is not too great. So it keeps on getting blocked.
So previously, all the old surgeon, like my boss also, under whom I have done my post-graduation, they used to do this anterior reconstruction by transthoracic or retroperitoneal route. But nowadays, that route is being used less and less often. And we are doing anterior reconstruction from posterior only by this kind of approach what sir is showing.
Okay, sister, एक कंटेनर ले लेना हिस्टोपैथोलॉजी माइक्रोबायोलॉजी के लिए स्टेराइल कंटेनर निबलर
Anterolateral decompression.
Bone. So now you can see the pus coming out. Can you see some of the pus here?
Yes.
See, it's coming, just coming out. I'll just. There, that is the pus. See?
Yes, we can see, sir. Let it, yeah.
Okay, 1 minute. Syringe
This
go
is the
without
yellow
needle.
color pus which is coming out through the transpedicular route. So we'll take the pus. This is how also we can take the pus during surgery and send it for diagnosis.
एक प्लेन फोर्सेप्स आपके हाथ में रखो सिस्टर, मैं मटेरियल दे रहा हूँ, वो सब कलेक्ट करके
Sandeep,
उसमें डाल
other
दो.
thing which you were telling,
कैन भी हाथ में लो.
biopsy was negative.
हाँ उसी में चलो प्लेन फोर्सेप्स ले. हाथ से नहीं प्लेन फोर्सेप्स, इसलिए बोला ना आपको.
You have to send the samples for pus culture, you have to send it for biopsy, you have to send it for gene expert, and you have to also send it for fungal stain. So many times you take the sample, like CT guided sample has been taken, your radiologist will say, I'll not have much sample. So you will send only for gene expert or biopsy. That is when you have a negative biopsy, because if that patient is having a pyogenic infection, you don't have culture, enough material for the culture. Maybe if he's having a fungal, then you have not sent for a fungal stain. So not having adequate sample
Pus
is
is
the
coming out.
most
Lot of
important
pus is
cause
coming out.
of the negative biopsy.
Bullet.
Sometimes there is a paraspinal abscess and there's an anterior abscess. So how can we go anterior from the posterior side? We can
Yeah, sure.
remove
We
his,
can. Yes, we can.
we have to cut
when
this.
sir is going
Yeah.
anteriorly,
Yeah.
Obviously the anterior body is completely destroyed.
So the
he
pus
can-
will come
he-
out from
So
it.
whenever
This
he
is all pus which is coming from anterior, sir,
Anterior,
between the
sir.
vertebral
Right.
body, and it is in communication.
That was
If
the
you
all
still
the
have
thinking.
worry,
That was
then
the
you
thing.
can do a costotransversectomy, remove the medial third of the rib,
That was the add-on.
and that will also help you to see that.
Exactly.
And sometimes I'm not really bothered about my job here is stabilization, my job here is decompression. I'm not bothered about removal of all the pus, because pus is going to be taken care of by
ATT.
AKT.
So this is very common question. डॉक्टर साहब ऑपरेशन करेंगे पूरा पस निकाल देंगे कि नहीं निकाल देंगे? So the answer to that question is we will take out whatever will come out, and rest of the pus will be taken care of by the ATT. Anti-tubercular drug is the treatment of this condition. Surgery is just for stabilization and decompression. So
when the patient has neurologic deficit, this case he doesn't, but when he has neurologic deficit, and किधर गया syringe?
PIP में OT1 दिखाइए.
So if you have fluid pus, the chances of neurological recovery are far better than if the compression is because of granulation or sequestrated bone. Okay, so it helps in prognosis also.
PIP में OT1.
Penfield 4.
So as Dr. Harpreet was telling, history taking in case of infection of the spine is very important. A patient of CKD, a patient who is immunocompromised, a patient who is diabetic, uncontrolled diabetic, a patient on whom any procedure has been done, either catheterization or endoscopy or some urological or gastrointestinal procedure has been done, and it is also chronology is corresponding, like the procedure was done some 3 weeks back or 4 weeks back, or I also had a patient in whom the PCNL was done, and after that he came with low back pain. So all these patients you have to suspect more and more of bacterial infection, pyogenic infections. And the patient comes with a history of 3 months, 4 months, and usually these pyogenic infections in MRI or radiology, you will find less of pus and more of symptoms. Patient will have more of fever, more of pain, and on MRI you will find more of edema and not much pus. But in tuberculosis you will find
So here,
more. Yes, sir.
Sandeep, just keep on listening. You can teach them afterwards.
Yes, sir.
Right now, just concentrate on the surgery.
Yes, sir.
Okay? So, I removed the rib, which you people did not notice. What is important is, I removed the medial third of the rib because I need to
go
laterally and anteriorly to reconstruct without pushing or retracting the nerve root. So if you see, this is the part of the rib.
This is the medial end of the rib.
So this is the medial end, inner surface.
So this has become like, sir, lateral extra cavitary.
This is not lateral. Lateral extra cavitary is even further lateral and more rib removal. This is like a costotransversectomy, where you are removing only the medial 3 to 4 centimeters of the rib.
So what are the tests you will subject the tissue samples which you obtained, just as a recap?
Exactly what Dr.
Harpreet was telling.
Sandeep and Harpreet were saying, that the sample, scoop please, scoop, curate. So exactly what Dr. Harpreet was saying. The first thing is you send the patient sample for histopathology. Then you send the patient sample for microbiology. In microbiology, you ask for tubercular smear culture and drug sensitivity. In pyogenic smear culture and sensitivity, these two compulsory. If it's a high risk patient, which is what Sandeep was saying, all the indications he suggested, in those patients you would think of doing a fungal culture also. And always send for gene expert. That gives you, say, sister was sample. Gene expert gives you the the rifampicin sensitivity. Also, it is a highly sensitive, almost 93% sensitive in terms of diagnosis of tuberculosis. So, and you get the report within 48 hours. So you can start AKT as soon as possible. In the good old days, there was this thing that you should not start AKT. You should not do surgery without giving AKT. So that theory has gone off. Previously, people, even if the patient had a neurologic deficit, would give 1 month of AKT, wait, and then start under cover of AKT. That we don't do.
Nowadays, even TKR they are doing along with ATT.
And we start off and do the surgery. Those shavers dena.
So here it was, the previous surgery was TLIF, where we put interbody spacer. Here we have done costotransversectomy. We have removed the transverse process. We have removed the medial 3-4 centimeter of the rib. So costotransversectomy, and we are going in between two vertebral body to fill this space with the spacer, which we are going to put now. So this is how you go inside anteriorly in case of dorsal vertebra, and it is very important in case of dorsal vertebra. Like we have this liberty of cutting the roots, which we don't have liberty in case of lumbar vertebra. So in dorsal vertebra, even if you want to put big cage,
दो
we
size
can put.
ऊपर, इसके ऊपर दो size, immediately ऊपर वाला. Knife sister 15 blade. Huh?
Sir, one question I want to ask, like if you want to do anterior.
So now I am removing, एक minute, now I am trying to get rid of the cartilaginous end plate, so that so that my cage can sit directly on the bony end plate of the vertebra. Okay, so here you can see the cartilaginous end plate being removed. Disc punch.
Sir, how many roots we can sacrifice when we are doing anterior reconstruction?
So up to 3 roots unilaterally seems to be okay.
Okay, sir. Sir, any thoughts about using mesh cage and expandable cage in these kind of cases?
You could use, no problem. I'm thinking of using a T-lift cage. What is the biggest size you have, my friend? 14. I think 14 will be a little small. We may have to still use a T-lift cage. ये क्या है? और दो size ऊपर.
So this is the shaver instrument which sir is using.
So I am using the T-lift instruments.
Yes.
Just to shave and clean the end plates. एक साइज और. ये कितने साइज का था? अभी शेवर दिया वो. क्या? या 14 will fit. चल. Curate. अच्छा 14 का केस. 14 ये क्या दे रहा था अभी तो?
These patients, they present like gradual onset.
14 का T-lift केस डालेंगे.
Yes.
So you can see I am curating the, when you are curating, your hand should rest on the vertebral body so that you don't plunge, and you curate the end plates. Don't over curate. If you remove too much bony end plate, your cage will sink. This punch. Cage will sink into the vertebral body.
One of the audience have asked this question, the cause of acute paralysis in case of infection of the spine.
So, I think the cause of acute paralysis can be vascular, it can be instability. Okay, usually these can happen overnight. Otherwise, most of the times the paralysis is gradually progressive compression, increasing in worsening of neurology over a period of weeks.
So this acute paralysis, how is the prognosis as compared to gradual onset weakness?
Not very good. क्या ये? हाँ? 14 मत दे, 11 का दे. केरिसन देना 2 मिलीमीटर से.
PIP में OT1 लगाइए. PIP में OT1. PIP में OT1. PIP में OT1 लगाइए.
Just trying to remove the rib. So I am removing the rib more medial like a costotransectomy, because otherwise the cage is so big that I will have to retract the cord, which I am not prepared to do.
Sir, abhi laterally the cauterization is done still on the bones?
It was on the rib.
Rib. OT1 we can see the OT light, we cannot see anything other than that.
निबलर छोटा वाला. दूसरा एक था ना कॉप, पहले वाला छोटा वाला. So now I have dislocated the. Can you hear me, Sandeep?
Yes, sir, we can hear you.
I have dislocated the rib so that I can get more room from laterally to enter the disc space and do my T-lift. Disc punch, disc punch.
Sir, I have a question. I am Harpreet here, sir.
Yes.
Sir, whenever we are trying to put cage in TB anteriorly, because the most of the times upper and lower bodies are also involved, so you don't always get a very good end plate to put your cage on, rest your cage on.
Yes.
So in those cases, how you decide about, sir?
So if you are not very comfortable with a good hold, then it's probably better not to
put the cage.
Put the cage. Hammer.
Then what to put there, sir? Tricortical bone graft?
Yeah,
sir?
put a tricortical bone graft. This is 12. 13 there. Hammer. Fuck. Put in there. No, you just put it right, putting it back. फोर्टीन का केज 14 का केज दो. बोन ग्राफ कितना है तेरे पास?
Sir, 14 is the size for that?
Yeah, 14 is the size I like. जेल फोम लिया है सिस्टर, जेल फोम देंगे.
So we are almost at the end of the surgery. We have put the screws.
So just wait for 2 minutes, see the cage insertion.
Yes, sir.
Then we'll compress and then you can leave in 5 minutes time.
No, we are with you only, sir. The other OT has not yet started.
Sandeep, can I ask one question?
तूने बोन ग्राफ रखा है तेरे लिए for the cage? ले इतना. बस. So I'm going to the cage bone inside the cage may or may not fuse. Therefore, you must put graft outside of the cage. So I'm going to put graft outside of the cage. This is too big. 1 cc चाहिए. ये अभी बहुत बड़ा है. 2 ml सिरिंज में डालो ना ये बोन ग्राफ्ट. ऐसे ही कर दो. और जेल फोम आया? दो जेल फोम. 2 mm syringe. So I'm just putting in bone graft. As I said, most of the bone graft is put outside the cage. Very limited the cage because we are never sure whether the bone graft in the cage fuses, and if it does fuse, does it become anywhere weight bearing? So the majority of the graft outside the cage is the one which we look forward to for the fusion. वो पंच था ना आपका बोन ग्राफ पंच सिस्टर, कुछ स्क्वायर राउंड कुछ तो था पड़ा हुआ था, नहीं उनका था, मैं सिस्टर का था. So we are putting graft into the cage, outside into the disc space. Okay, very good. Now you use a bone graft and punch it in, just push it in, बस हो गया, ठीक है. चलो. Now you use a template which is smaller than the one you are going to use. So this is 12 millimeter. I am just going to push it in to determine the direction of my केज दे. सियाम तैयार रखने को बोलो. So now you can see I am going from far laterally so that there is no pressure on the cord. That's my cage which has gone anteriorly. Okay, now I will take a check X-ray to see the position of the cage. Sister, अभी rod next कुछ बाकी नहीं है, कुछ नहीं है, ये बराबर निकलता है. 14 number drain, number 1 vicral, 20 vicral, skin के लिए whatever you all are using.
Can we have the Siam in the PIP? Siam picture in the PIP?
एंगल बहुत गलत है कुछ तो, ये ऐसा करो.
Yes, we can see the Siam picture. Yes.
और थोड़ा पेशेंट ये साइड नीचे आ जाए. और थोड़ा बस.
Gurdeep, you are in front of the Siam. केवी बढ़ाओ, केवी बढ़ाओ. एक सेकेंड ना. Getting an oblique view, I don't know. Is the cage gone too anteriorly? ठीक है. Okay, चलो निकालो. Suction. Penfield 4 sister. वही वो पतला वाला.
छोटा वाला सक्शन कैन्यूला.
ऑपरेटिव फील्ड वाला कैमरा दिखाइए. ऑपरेटिव फील्ड वाला.
इसे ये क्लियर करो प्लीज.
Yes.
See, this is the posterior border of the vertebral body. Or KG just anterior. We should go a little bit. नहीं? Huh? We should go anteriorly. Other than that, ये देखिए posterior border है यहाँ पे. नहीं करेंगे. Now hammer. पकड़िए गुरदीप. Show me the white. नहीं. इसलिए तो पस आ रहा था ना all the time. बस. Okay. All right. चलो. Now compressor. दोस्त रॉड होल्डर, कंप्रेसर, फाइनल टाइटनर. ओके. कंप्रेसर एंड फाइनल टाइटनर. इससे बड़ा वाला निबलर किधर गया? बोन. 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 कट कर सकता है. Okay, can I get a compressor, rod holder, final tightener? कितनी बार बोलो यार final tightener देना हाथ में. चल गुरदीप ये लो. Leave the rod holder. Or loosen the top one. Loosen the top one. So top post one. और थोड़ा कर दे लूज. हाँ करो. Put your final tightener in. Other way around. क्या गिर गया? चलो रेडी. वेट लूज कर. ओके टाइट. ओके रिलैक्स. टॉप वन. गो फॉर द टॉप वन. पेनिट्रेट फॉर. हो गया बस. ठीक है. ठीक है काम भी खत्म हो गया. चलेगा. रॉड दूसरा वाला. Cover the whole damn thing. We don't want it to. So now, before I put in the rod and do sharp work on the opposite side, I want to cover the dura so that I don't injure the dura during the manipulation. Sometimes instruments can slip from your hands. एक कॉप दो मेरे को. एक okay, another one.
So as we have done in the TILIF, we have compressed to make the cage tight. Here also we did compression to make the cage tight. And
Okay.
We have to make sure the cage is not loose either in TILIF or in this case like anterior reconstruction. Otherwise, cage might migrate posteriorly and cause neurological deficit.
Chalo, final tightener, compressor, wash तैयार रखो sister. Take it medially. करो.
Anybody has any question for this surgery? Because after the tightening and compression, the closure will start.
No, they will not start because we will be doing a posterior fusion, interlaminar fusion along the instrumented segment.
Yes.
So we will be doing, I have already started the decortication procedure. So,
So this is the compressor which is being used.
Okay, just compress. Hua? Compress? Okay, now remove. Never start your tightening without setting this anti-torque device. Otherwise your screw can pull out and the whole thing can this thing. ये भी किया ना? Okay, I'm sorry. Okay. एक मिनट पहले ये कर देता हूँ.
Any question anybody has?
Okay, compress. So now this is the final compression. Okay, now wash. We'll wash it out before we decorticate the bone because
why did we compress further
So we have
so that the cage is absolutely jammed in, wedged in. Once the cage is wedged in, the risk of it displacing is far lower. The other thing is you put in bone graft. When you put bone graft and you compress by Wolff's law, the bone graft gets under tension or compression, fuses better, and the bone graft orients in the direction of the compressive force. So therefore you do that. Gel foam.
Sir, can you put a tricortical bone graft instead of a case?
Pardon me?
Can you put a tricortical bone graft alone instead of a case?
Yes, you can certainly use a tricortical graft.
Sir, what are the advantages of putting a case
or
for
hammer?
a tricortical bone graft?
Now see how I am decorticating the posterior surface of the lamina. This is to do a posterior fusion. This whole instrumentation procedure will fail in a few months because the implants will get tired. There will be fatigue loading. So you have to put in this kind of a fusion operation. So I am decorticating by removing the outer surface of the lamina.
Sir, I have one question. Sir, what are the advantages of putting a cage over tricortical bone graft, sir?
So the cage requires less carpentry. It is far easier to get a perfectly bone graft. तेरे को bone graft दिया ना बाकी का spinous processor सब वो किधर गया? अरे इधर से काट के दिया ना मैंने अभी. क्या बात कर रहा है? अरे नहीं यार, बहुत बोन ग्राफ्ट दिया मैंने, ये सब इधर का स्पाइनस प्रोसेस में एक्सरसाइज किया, वो किधर गया? अरे नहीं यार, किधर गया? ये क्या है, ये बोन ग्राफ्ट?
Sir, any preference for PEEK versus titanium cage? Because we have seen some in revision cases like PEEK sometimes doesn't unite and just comes like that.
So, in for this transpedicular decompression, we are always using titanium. There are no PEEK cages available for this. But for the T-lift, yes, in the lumbar spine, the titanium cage has a lesser rate of displacement than does the PEEK cage. Okay, so there is an advantage of using a titanium cage. I think I am going to wash out now. We have done the surgery. I would have normally put bone graft over here and here, but somehow our bone graft has got lost. I don't know where. Anyway, so surgery has gone off well. We have achieved whatever we wanted to do: decompression, fusion, and anterior column reconstruction. I will now put a 14-number drain. Then Dr. Gurdeep and the other guys are going to close the lumbodorsal fascia. We don't close muscle. We close the lumbodorsal fascia with number 1 vicryl, subcute 2-0 and skin with whatever you want. Okay, this patient can be mobilized today itself. Patient can be made to sit, stand and walk today itself. And I don't use braces for these patients. So braces are not required. There is no need for an anterior hyperextension brace or anything, or a Taylor's brace or anything.
So will you put a transverse connector?
No, there is no need for a transverse connector in this patient. It is a stable spine. We've got two nice fixations above and below. Thank you very much, Gurdeep. Thanks to Gurdeep and thanks to these two boys here. I'm sorry, what's your name? Doctor?
Sir, what
Dr.
is...
Shripal Chaudhary and Dr. Shweta, who did a fantastic job. Thank you, sister. She washed up with me for the first time, but she was on the ball, did a fabulous job. Even the Medtronic guy, Vikas did a fabulous job. I would like to thank the anesthetist. The field was brilliant. There was no bleeding. It made me look better than what I am. And I would like to thank the Siam technicians and all the rest of the staff.
So there is one...
the cameraman who did a wonderful job of showing.
Thank you, sir. Thank you, sir.
All right. Good luck.
So there is one question from the audience. What is the, if apart from carpentry work, the tricortical bone graft and versus this titanium or PEEK cage, which is superior, tricortical bone graft or the titanium cage?
So always autograft is the gold standard. It has a much better rate of fusion. So if you can get a very good strut graft and you can carpentry it into a very good position within the it is very good. The other advantage of a titanium cage is because it has sharp end plates, or even in the other expandable cages they have serrations at the end. Those serrations grab the end plate and therefore the risk of displacement of a cage is lower than the risk of displacement of a graft.
What about the softening of the graft over a period of time?
But that again heals, na? That is the natural history of a fusion. That it will soften, but given time you are protecting that graft with your your implant.
So is it the same for TLIF also, tricortical bone graft and the titanium
100%.
cage?
Your tricortical graft will heal much faster than your titanium.
Okay, sir. Any other question anyone has? Anybody has any more questions?
If you have any question regarding the pod spine, you can ask. And right now we are going to shift for the next case, that is a traumatic spine.
Sir, one more question.
Yeah.
Sir, what are the chances of failure in this case if we are not doing anterior reconstruction?
What is?
What are the chances of failure of the implant if we are not doing anterior reconstruction in this case?
Actually, it's a really
Sir
very
is
good
not.
question.
Sir
It's,
is there.
We can
Gautam sir is there.
We can answer this question, I think. Sir, are you there, sir?
Hello, Gautam sir.
He's not there, I think. Might be. So it's really a. If you are not reconstructing the anterior column, then the problem is that your implant will go in failure.
Hello. Yeah, can I answer that question?
Yeah, you can also.
Yeah. So the issue is, it depends on how much is the void that is left after after you have done the anterior debridement. So if it's a small defect, then you can do shortening of the anterior column and compress it, and that will take care. But if it's a big void, better that you reconstruct it with a cage, either a mesh cage or a T-leaf cage like they did, or you put a dicortical graft.
Vancomycin. So the answer to answer that question, for spine you have 3 column support. You have already removed the lamina. You have removed one side facet. Anteriorly whole body is not there. Ultimately from 360 degree you have brought it down to 90 degree. So 90 degree support on the screws with big defect, there are very high chances of failure. So now what they have done is they have anteriorly putting the graft, they have secured 180 degree, one facet in intact, so 270 degree of fusion they have achieved. So if there is big defect and already you have sacrificed one of the facet, then you have to reconstruct anteriorly. If there is very small defect, you can put bone graft, chips of bone graft, like very less space, that and without removing the posterior structure, then it will hold on the screws. Otherwise either your screw will break or rod will break or screw will come out. Thank you, sir. Any other question anyone has? Duration of the okay, so duration of the ATT is big question everywhere. Even in our national conference also this will be a big question, and different surgeons will have different opinion. One from this Vellore, CMC Vellore, they have published a paper for 9 months of ATT. This from Mumbai, Dr. Bhojraj sir has published a paper for 12 months of ATT. And here we have different people who are from UP and they are practicing here. Sir, how many months you do ATT, sir?
I usually give 1 year.
1 year of ATT and you stop it?
No, then just
So
see the ESR, CRP and radiological. Radiological assessment, then we stop. Clinical, radiological, or all the assessment.
So you do MRI, sir, or you do only X-rays?
At the end of
at the end of 1 year, you will do MRI. And what you see in the MRI to stop the ATT?
Sometimes there are little bit inflammation, but if clinically everything is alright, we go for the stopping.
So after stopping ATT, do you follow your patient again, or you for how many years you follow?
6 months yearly.
So for 6 months or 1 year you will follow.
Yeah.
So how do you follow your patient with X-rays, MRI, blood test?
Only X-ray and clinical evaluation.
X-ray and clinical, no blood investigations. Okay, so can we have opinion of Dr. Abhinav, what he does? What is the parameter or what is the rule he is following for stopping ATT and further following the patient?
Minimum, I give ATT for minimum of a year, in which 3 months is 4 drug combination, fixed drug combination. I use mainly Accurate 4. It depends on the weight of
the brand can be different, that is not very important.
And it depends on the weight of the patient. What is the weight of the patient in that fixed drug regimen? And then for at least 7 to 9 months, 3 drugs, ATT. That is regular. That is
so what do you do at the end of 1 year?
At the end of 1 year, if the patient is clinically okay and there are no constitutional symptoms, then I'll stop ATT and get blood investigation done at 1 week and then at 2 weeks. And if it's fine, then I...
So you don't follow your patient after 2 weeks?
Follow, but blood investigation I do at least 2 times.
Then what is your follow-up after that?
Follow-up 6 weeks, then 3 months, then 6 months, and then 1 year.
So how do you follow your patient with X-ray, MRI, blood investigation, or just clinical follow-up?
Clinical follow-up mainly, and get an X-ray done at 3 months and then at 1 year.
Okay, so Dr. Swaroop, what do you do for your TB patients? So what you are listening here is, still we don't have very clear-cut guideline, even from our national society, that you should follow this. So let's hear from Dr. Swaroop what he does.
I completely agree with KD sir that 1 year of ATT, follow up every 6 months, 3 months, depending on the patient, how she is, young age, older age. But MRI, blood test and clinical evaluation at end of 1 year will definitely give us a clue whether we have to continue or not.
So
in some patients we do change at 9 months also we may get an MRI, but depending if they are having some problem with the ATT, they are not very happy to have it. So we have stopped in some cases at 9 months also. We have kept them on follow-up, but never recurrence of TB has been seen even at 9 months.
Sir, you do plain MRI? You do plain MRI or anyone does contrast MRI?
Plain MRI. Plain MRI.
Sir, आप contrast MRI or plain MRI?
Always plain MRI.
Abhinav?
Never contrast MRI.
Plain
And
MRI.
there are some patients.
So doesn't your radiologist give a MRI report at the 1 year that residual infection is seen?
There are some edema or some reaction.
So what is the patient reaction with that?
All blood profile and everything normal patient is, we just ignore that. Because MRI,
Okay.
you know, it keeps on showing you up to 1.5 to 2 years.
I generally have a little different regime. I usually continue in antibiotic treatment for 15 to 18 months. And generally
We
I
have
start
another
for
doctor
that-
who gives for 15 to 18 months.
Yeah.
Yes.
Generally I start with 5 drugs. And for
5
TB
drugs are which one?
5 drugs is
HRJDS or HRJDL?
levofloxacin.
HRJD and levoflox. Yes, sir.
And then at the end of 2 to 3 months, we shift to 3 drugs.
HRE.
From 5 drug to 4 drug.
5 drug to 4 drug.
Only pyrazinamide I withdraw.
Okay, this levofloxacin you will continue.
And then after about 3 months more, we generally give you 3 drug. So 3
After
drug,
like 3 months you will drop one drug and 3 months again you will drop one drug.
levofloxacin.
And you will continue for 15 to 18 months.
15 total. And I never do MRI, never need to do MRI for confirmation of the prognosis and recovery.
So
because the tests of the microbiome, the blood tests are enough to show you the ESR, CRP, hemoglobin, general picture. They are enough to show whether the patient has recovered or not.
So
if
sir,
the CRP is raised, the ESR is raised, general condition is poor, then you are of course.
Then what you do, sir? Like let's say you have a patient, you have done X-ray. Sir, you before starting treatment, do you do biopsy in all the patients, or you have exceptions like you do in some patient, you don't do in others?
Biopsy is done.
How do
very
you
rare.
prove it is tuberculosis?
Biopsy is done very rarely.
Very
For example,
rarely,
yes.
okay.
For example, biopsy is done in those patients where really the diagnosis is really in doubt.
Okay, sir.
Otherwise, if a simple case of coccyx spine, generally nobody does biopsy. 1 minute.
There.
हमारा कहना ये है कि जो डायग्नोसिस बनती है it is never on one particular topic only from as regard biopsy. The diagnosis is a comprehensive one. It includes the clinical picture, it includes the hematological picture, it includes the X-ray radiological picture as well, and of course MRI. So MRI we generally do before starting the treatment.
So that's what I said earlier, that if you have a typical history and a typical MRI with lot of abscess and pus, there's no need to biopsy. Then you can biopsy at 6 weeks if your patient is not responding.
Sir, एक second.
Huh.
Sir, what sir is doing is like sir will get an X-ray and an MRI, and sir is telling like we rarely do biopsy and we start treatment. My another question to you is, in lot of like some 30-40 years of career, how many patient of yours turned out to be MDR or XDR or pyogenic infections?
We have not come
because in follow-up, if you are not doing MRI, if you are not doing MRI at the end of stopping ATT, how are you sure that my patient was normal tubercular bacteria which was rifampicin, which was sensitive to all drugs?
So one question at a time. The take MRI. What does MRI show? MRI shows osteitis or something like that. And once the blood tests, the hematological parameters of infection are okay, then I think it is very, very difficult to prove only on the basis of MRI whether you are continuing with the diagnosis, with the infection. So in my mind, the hematological picture is supreme along with clinical picture and radiological picture. If you combine, there is no need of MRI at the end of the treatment.
So
patient refused and so much so that. But the main issue clinically, as far as I am concerned, is I become really worried when the patient doesn't show relief after about 2 to 3 months, and then I pursue it very diligently. Then I take all the precautions, do MRI once again, and do the XDR, MDR test also, as compared to a person who has shown normal progress during the recovery phase.
So that if and but that the only place I differ with you here is I agree with your protocol for biopsy. I don't biopsy all my patients. I already told I biopsy only atypical presentations like where the MRI is atypical or patient is not improving after 6 weeks, and I tell them beforehand. The other issue is that why I do follow up MRI is because I want to stop ATT earlier. Because you are giving your patients ATT for 15 to 80 months generally. Many of my patients who are diagnosed early like D6, D7, D7, D8 TB spine are diagnosed because they came with pain, we got an MRI and they had a TB. So we started them on ATT. Many times if you do at MRI at 8 months, 9 months, you will found it has complete resolution of TB is there, and already fatty marrow signals are already there on MRI. So you can confidently stop your ATT at 9 months in those patients. Why to give 9 more months to those patients? So that is where I differ. So I do follow up MRI at 6 months or 7, 8 months, where at most I can defer to 8, 9 months. That gives me idea of how much ATT I can decrease and when we can stop as early as possible. So when MRI shows good healing, I stop. Sometimes it is 8, 9 months and sometimes it is 12 to 14 months. The other thing is why to, if the patient is deteriorating, then you do MRI definitely. Otherwise there is no need to do an MRI before 6 months at least. After 6 months, if he is healing very well, you can definitely decrease your dose of ATT and maybe think of stopping earlier than going all the up to 15, 18 months. That is where I think follow-up MRI can help.
And usually when we go for biopsy, we don't go for only CBNAT. You go for CBNAT, you go for culture sensitivity, you go for histopathology. What practical experience what we have, that one case of 8-month-old pregnant lady came to us, that was referred to us by gynecology department. She has got neurological deficit. The whole picture of MRI was tuberculosis. When we operated for that neurological deficit, it was tuberculosis. But after the biopsy report, the histopathologist came running back to us that it is adenocarcinoma. So you cannot, the picture can overlay. Infection can present as malignancy, malignancy can present as infection. So doing biopsy is must. If we would have treated that patient on the line of ATT and tuberculosis, we would have landed up into soup.
My
So
2 words on this, just a minute. There are very clear guidelines given by government in this regard. So I don't see a point why do we need to give at 9 months only or 1 year only. The clear-cut guidelines as per Nikshay portal given by the initiated by the government, how long ATT has to be given, and it's for everything. It's for tuberculosis as a whole. All the tuberculosis. You can start ATT according to the guidelines. It is not mandatory that you have to do biopsy only and then only you can start ATT. You can start ATT on the basis of your MRI findings.
Clinical
Yes,
radiological.
yes, clinical radiological. For clinical for medical legal purposes, it is very, very clearly guided. So I don't think there is any confusion.
No, what is the guideline for extrapulmonary tuberculosis? If you can tell.
For spinal tuberculosis, I think it's been since long. 18 months is the standard.
No, it's not there.
That's what I'm telling. It's very much defined for pulmonary tuberculosis, but it's not defined for extrapulmonary, because extrapulmonary tuberculosis will be gastrointestinal tuberculosis also. And in gastrointestinal tuberculosis, 18 months of ATT is not defined.
There are no guidelines which say 18 months. There are no guidelines which say hard and 18 months for bony tuberculosis. We'll get back
exactly.
to this. The other thing is, Nazim, where I want to come at your cases, if you go back and look your MRI,
again, where you started ATT and it came out to be adenocarcinoma, there must have not been abscess signal changes. There must have been a soft tissue signal changes around the vertebral body. That's what I say. I will keep those on atypical MRI findings because you are not getting exact T1, T2 signal changes of abscess on pre and paravertebral area. So if it is more of a soft tissue signal changes, grayish, not whitish and blackish on T1 and T2, then you have to, your threshold for biopsy should be very, very low. So that will come in atypical MRI finding. So I will biopsy that before starting on ATT.
Just we'll add on few things that the patient of the tuberculosis, they are immunocompromised patient. They are immunocompromised patient, their GC is poor. So need to check monthly for their hemoglobin count, CBC, SGOT, SGPT, liver, LFT must be done add on, because all these patients, they are in some hidden symptom. They will not going to speak you that I have something, the yellowish of the urine there. अच्छा वो orange color का आ रहा है, बोलेगा हाँ वो hypopampas. I have seen my patient converted to the something bad end of the ATT. So need to focus on that part also. The immunity enhancer has to be add on. Protein supplementation must be given. These multivitamins must be likewise B1, B3 and B6, B12 also should be given. Extra amount of the protein must be given to these patients.
Dr. Swaroop, you want to say something?
Yeah. See, first question, when to stop ATT? It is very different protocol.
So now you have understood like when to stop ATT. It differs with different surgeon. Everybody is right till the time your patient is happy and you are not having recurrence. So sir stops at 15 months, it is right. He stops at 12 months, it is right. I stopped at 12 to 15 months, I am right. And anybody who stops at 18 months is also right. Okay. The only thing is proving that it is tuberculosis. If it is MDR or XDR or pyogenic, you have to take adequate actions and start TB accordingly.
One more thing I would like to add in this, when you are ending or you are taking the last MRI, but your radiologist, and if the radiologist is not competent enough, he will write something and you will be in dilemma. So you have to both have to be very, very smart and very, very competent in reading those kind of MRI.
I always sit with my radiologist and tell them why I am doing this MRI. I tell them this is a MRI which is being done. I do contrast MRI, I don't do plain MRI, just to disclose. I do contrast MRI. I tell my radiologist this is for the stopping of ATT. So interpret accordingly and tell me whether everything is healed or not, then I will stop ATT. If my radiologist say it is not healed, there is still doubt, I don't feel shy in continuing ATT for 3 more months. See, if we will stop ATT at 9 months or 12 months, and ultimately if patient gets recurrence, that is much better than giving 3 more months of ATT. This is my philosophy. Until now I have not got recurrence.
Very justified, I think everybody can understand, and it is very logical as well. The second point, biopsy should be done or not, I agree with Harpreet, because there is no clear-cut guideline. Doing biopsy in every case is practically not possible. It should be done. That is a very theoretical formula, because an 8-year kid, 7-year kid, you cannot go and attempt a biopsy. Atypical ones, you should.
No, for biopsy, you need to have a good radiologist, probably some person who does biopsy in CT or in ultrasound. If you don't have access to that radiologist, it becomes difficult, because we have done biopsy in a 6-year-old child also, 7-year-old child also. It was having atypical presentation. I had opinion from 3 radiologists and everybody told it's a malignancy. But the biopsy turned out to be tuberculosis. So, see, from your side, every effort should be made that this patient biopsy should be done. The effort has to come out from you. You have to discuss with your radiologist from wherever you are living, wherever you are staying. I think every district has radiologist now.
Yeah,
and all the radiologists mostly do CT guided or ultrasound guide. It's not a big thing.
I think biopsy should be done by the primary surgeon who is going to treat it. I don't send my patient to radiologist for biopsy.
See, now,
I
okay,
do it myself.
okay. If you have a big psoas abscess, what do you do? Do you do yourself or you send to radiologist?
I do it myself.
How?
I go take a needle and aspirate it out, and it's done.
You aspirate it out blindly or ultrasound guided?
You can put ultrasound guided. I have a CT scan in my operation theater. So
See, he has a CT scan in his operation theater.
Even before that, I was doing it. So it is not that.
So
that has
that's
added
what I'm
something.
telling. Ultrasound guided aspiration of a 5 ml, 4 ml abscess. If you are not trained in ultrasound, it will be difficult. Dr. Sarup has CT scan. We used to do CT guided biopsies. So you can get, it's very easy. So you can reach out to Dr. Sarup. He will show you how to do CT guided biopsy. It's very easy. So if you can do yourself, you do. If you cannot do yourself, you can do you can get it done by ultrasound guided by radiologist also. I think
SWAS, I think yes, because it's a big pouch. But if you are going to touch the bone, I think no radiologist is more experienced in touching the bone until unless he is very.
They are intervention radiologists.
Yeah, until unless he is very expert in going. Many times the disease is anterior and he has to approach from the posterior. The bone is hard. He is unable to pierce it. Those kind of things give false impression. It is always better that you do it because it can be checked in CM in multiple.
Another thing is by transpedicular route. Transpedicular route, Sarup, we can show tomorrow in cadaver them.
Sure.
We will show you how to do transpedicular biopsy tomorrow in cadaveric course. That is very easy thing. And those things that radiologists don't do. I do agree with Dr. Sarup. If it is bony sample which has to be obtained, most of the radiologists will not be able to obtain good sample. And we as a spine surgeon or we as an orthopedic surgeon can obtain. So transpedicular biopsy we will show you tomorrow on the cadaver, how to do transpedicular biopsy. And it's very easy also.
So the conclusion for the ATT is still
So
pending.
conclusion for the ATT is, it's up to you. I think minimum I will say 9 months.
I will conclude in just a few lines. I am practicing in Varanasi since 20 years. I am doing the spine surgery from 20 years. I face 100 of the cases of tuberculosis. Many of the cases they have the extra pulmonary tuberculosis and the pulmonary tuberculosis associated in the childhood. Childhood having the chest tuberculosis has started the ATT in their childhood, landed with some spine problem after 10 years of the 15th years of the age. तो 15-20 साल पहले भी ATT लिया हुआ है वो, and that has landed with some tubercular problem. So there is the problem of MDR. So need to be very specific to that.
Okay, so now we will go for this operation which is happening. Dr. Siddharth, can you hear us? Dr. Siddharth? Operation theater, Dr. Siddharth, can you hear us?
Probably, so I'll have to make some important
Dr.
things.
Siddharth. So, Dr.
Okay, so right now what we are doing in our OT, because we have like 1 scoli cases, but because of the because what we have found, we have kept 2 scoli cases there, but in 1 scoli what we have found, there is a tethering of cord, so we have postponed that case. Though the case that we have interpreted, but because the parents were not willing for this time surgery, so they have not given consent right now. So we are not taking that case. So as we have discussed, Dr. Sajan Hegde and other surgeons, so right now what we are going to do, all the lumbar spine surgery, we are again going to do one lytic type of listhesis that we have kept as a standby case. That is again one interesting case, and that is going to be taken by
Dr. Siddharth?
Sajan Hegde.
Yes, I can hear you now.
Okay.
Can you hear me?
Yeah, I'll just come to you in 2 minutes.
No problem.
Just coming back to Dr. Siddharth. So right now we are not going to perform this scoli surgery. So what we are doing in place of that, we are going to take one high-grade lytic type of spondylolisthesis. Okay. So one case is that. Another case that we are going to demonstrate soon afterwards. After this case, we are going to take that case. And the one that has been left is the disc L4, L5 microtism that we are again going to do after this case. Okay. So let's come back.
So Dr. Siddharth, can you just show us the X-ray and
Yes.
MRI, and just in short tell us what are you planning to do?
Yeah, just 1 minute.
Yeah, sure,
You
we
will
are
help
with
him.
you. We are having your feed.
You have my feed now.
Yeah.
K-wire मिलेगी. K-wire.
So we have decided to do the basic
शादी वाली
surgery
कुछ नहीं तो
stuff
discard कर
because
दूं,
after
चलेगा ये?
discussing with the surgeons, they said that instead of scoliosis, it's better to demonstrate because all of the audience that we are having, they are basic like general orthopedic surgeons or a budding spine surgeons. So they have decided not to do the scoli case this time and just to demonstrate lumbar spine surgery. As we are going to have this year theme is the lumbar spine surgery in our.
और हटाइए. सियाम सियाम आगे कर दीजिए. थोड़ा और पीछे.
Basically, what you need to learn how to plan the cases of thoracolumbar fracture. How you are planning. So first of all, you need to classify the fracture.
Yes,
which
now the
type of
CM is
fracture
out. We
this.
can see the
Then
view
afterward
box.
plan how
Okay.
you have to deal this fracture. Okay.
So
come
this
to-
is the X-ray. So some features on the X-ray is interpedicular distance is widened at L3. The horizontal height is reduced at the anterior column and middle column, and you can see a subtle retropulsion at this level.
Yes,
so
we
it
can
suggests
see,
that on
yes.
the X-ray itself it is going to be a likelihood to be a burst fracture. At the L1, it appears to be wedging. We are not so sure whether the middle column is intact or gone. In terms of the interspinous distance, they all look okay. So I am not again sure very clear that the posterior ligamentous complex is injured. But as per the AO manual, if you say that there is no column translation, so definitely not C-type injury, we still have to evaluate B and A-type injury. So we have seen the CT on the screen, and I will inform you that it is A3 for the L1, which is minimal retropulsion is there at the superior corner, and at the L3 it is a complete burst. It looks like an A4, and there is no PLC injury as per the MRI what we see. Clinically also, when we started the case, we found that the interspinous is intact. There was no widening in the spinous process, no defect felt in the skin also. Sandeep, you're with me?
Yeah, we are hearing you.
Okay. So here at L3, there is a large canal compromise. More than 50% occlusion is there, but luckily for the boy, he does not have any spinal cord injury. He's normal neurology. It's been 8 days. We are bordering on the level where so to say, the ligamentotaxis should work, I hope. When we posted him prone, we did get some restitution of height, but it's not fully there.
So what are you planning, Dr. Siddharth?
Okay, Sandeep, question from Dr. Shankar Acharya. How many in the audience would like to treat this conservatively?
Okay, so this is the question which our surgeon, Dr. Sankaracharya, want. There is a burst fracture of L3 and there is a probably wedge compression fracture of L1. And the neurology is intact. So how many of you want to treat this patient conservatively? Can we have show of hand? How many do not want to operate? Age 17.
He's a young guy. He's a young guy.
17, 1-7.
How many of you do not want to operate?
Actually,
so if
we are
somebody is
asking
not
this
raising the hand, then that means everybody wants to operate.
Actually, we are asking this question just to give you insight where you need to operate. Type A3 fracture is there, A1 fracture. This is a combination of both type of fractures, and A3 and A4 type of burst fractures which create a controversy. For A3, you can't treat conservatively. For A4, if it's a complete burst fracture, it's required. So first of all, you need to understand which type of fracture is there, and the question that sir is asking, how many of you would like to treat this fracture, this burst fracture? So anyone would like to treat this fracture conservatively or not? So sir, nobody is raising his hand.
None of the
Everyone
audiences
want
want
to be get it operated.
Sir, we cannot hear you, sir.
Second question is there is a minimal wedge compression at L1 with a small posterior burst to the superior portion of the posterior superior part of the L1 vertebra.
Yes, sir.
And there is a proper burst fracture A3 as Siddharth said of L3. So what would be the thoughts before you take him for surgery? Here we have, I think Siddharth has already discussed the plan, but would anyone, what is the plan people have? What would people do? How many of would you do all posterior surgery? How many would do percutaneous surgery? How many of you would do open surgery? And if you do open surgery, would you use fusion or no fusion?
So most of our audiences are orthopedic surgeons and orthopedic residents. Hello.
Yes, we can hear you.
Yeah, most of our delegates are orthopedic surgeons and orthopedic residents. So I think this question is going to be very difficult for them.
So one by one we can go with the questions, sir. One by one, sir, so that they can understand, sir.
Try to.
Yeah,
Hello?
yes,
Can you
yes,
hear me?
Yes, yes.
Yes, sir. It's a good.
Can you hear me?
Yes, sir.
Okay, okay. So, okay, if most of the audience is orthopedic surgeons and most are postgraduates, good, because this is when you form your thought process. So basically, Siddharth has told you that this is not a fracture dislocation, so there is no loss of alignment in the vertebral body, and you can see the spinous process all in line. There is some pedicular widening which shows that there is significant compression with at L3, which is not there at L1. So that must be seen, and there is some rotation at L3 also, which means that there is then if you don't have a fracture dislocation, which is a type C, I think a lot of the teachers who teach you would teach you the reverse way. It's not A, B, C as AO says, it is C, B, A, which means C is a fracture dislocation, B is a distraction injury, where the posterior spinous processes are distracted or there is interspinous widening. Plus there is, when you do an MR, in today's age and day, you will always have to do an MRI or plus minus CT and an X-ray. So if the posterior elements are preserved, there is no distraction, there is no facet dislocation, there is no fracture, then you know it's not a B type of injury. And then you come to the A, and you here in this classic case, you have a dilemma because you have three contiguous fractures, L1, L2 and L3. Right, L2 may there is also some edema, which so you can say A1, 2 and 3 types fracture. So there is always a worry as to in the lumbar spine when there is a long segment fixation, because normally in these fractures thoracolumbar junction is the commonest place where you get a fracture, and that is the junctional area. So there we now do a short segment fixation. And in this patient, you may have to do a long segment fixation. So you would like to do a fixation to stabilize and then take out the implant after, because he is a young boy. How much age is his?
17, sir.
So you don't want to have a large segment which is stiff, because you will have degenerative changes at L4, 5 and L5, S1. So you would like his fracture to heal, because they will all heal, and then you can take out the implant. So you can do them percutaneously also, because you are not aiming at fusion. So it's basically we are also not going to do fusion here. The plan is to do span the fracture. So the method is to span the fracture, so keep the posterior tension, allow the anterior column to heal by giving some shift of the load to the posterior surface or the posterior part of the vertebral body. So we just span the fracture from T12 to L4, and we will use less metal here because we don't want to make it very rigid. So I think Siddharth will show you the screws and prevent the capsular damage. So you want to be very careful at L4, because that would be the last mobile segment at this moment of time till the fracture heals. So you don't want to damage the capsule. So you will go outside the capsule, so you go onto the spine transverse process, and then he will show you all the landmarks, and then you put your screws. However, in T12 also you don't want to damage that segment, and so you can go into the mammillary process, and I think as you go along the surgery, they will show it to you.
Dr.
Any
Shankar.
questions?
Dr. Shankar.
Yeah.
Dr. K.D. Tripathi here.
Welcome, sir. Tripathi sahab.
So,
Dr. Tripathi is a very close friend of mine, and we did our training together in Safdarjung.
If this patient is ready to lie down for 3 months, like poor chap of the rural background, is it okay to not to operate this patient?
If the patient wants to lie down, who are we to say anything?
Yeah.
So that's up to the patient. But obviously, this can be treated conservatively. So it is not that you always have to operate. I am quite happy to treat this patient conservatively and I don't want to put him in bed for 3 months I can give him a hyperextension brace and get him up after
John,
about
okay.
4 to 6 weeks.
6.5
And he can log
poly,
roll in bed comfortably also.
5.5
So that can be done.
poly.
You're absolutely right.
40-45 ratchet handle पे 5.5 का screw तो 4.5 का time 6.5 screw तो
Any other questions?
Sir, for your
Or ratchet
conservative
handle?
management, how long, for how much period of time you recommend brace?
Well, say conservative management cannot be an arbitrary cutoff point. Conservative management also always has to be depending on the patient's progress and healing. So normally, if I am treating a fracture A3, for example, conservatively, and the patient wants to avoid surgery, there are lots of situations the patient wants to avoid surgery, then we would put him in bed rest for about 3 to 4 weeks, and then I'll get a sitting and a prone lateral X-ray, and that would demonstrate to me sitting and a prone lateral X-ray. That would demonstrate to me if there is collapse on the sitting, and if it opens up on the prone lateral. If it is significant, then yes, I would counsel him that, well, this fracture is not healing. After 6 weeks or 8 weeks, I would do a CT to see if there is any
किधर है नया वाला
healing
किधर
process
नहीं वो नहीं
on.
है वो नया नहीं है
If it is a intra-substance fracture,
नहीं, नहीं, वो नहीं
vertebral
है।
body
नया वाला
fracture
किधर
with less end plate fracture, there is a likelihood that they may heal. But if the vertebral end plate, especially the superior and the posterior superior end plate are completely fractured, then the healing may not be that good. So you will have to take it as it goes along.
not working
So you don't have to, can't have an arbitrary cutoff. But if you want to lay a general line or a general guideline, then maybe 4 weeks in bed rest, then get a
Starter
sitting
देना,
and prone
starter
lateral
वाला।
X-ray. If the patient doesn't have pain, the patient's fracture is healing, the
मैं
change in
बताऊंगा,
the,
but
change in the
6.5 or
dynamics
5.5?
of the X-ray is not much, then you can give him a hyperextension brace and then get him mobilized and see how it does.
The bed rest has to be absolute bed rest, like the patient has to do his, cannot go to toilet also.
No, man. You see, bed rest is in the bed. Home rest is in home. So when you are in home rest, you should get this terminologies right. So I tell my patient, when I say bed rest means you are doing susu potty in the bed. And when you are in home rest means you can go up to the toilet and go to the restroom.
Okay, sir. So this is trauma.
I think Siddharth is
yeah. level confirm के लिए रुके
So trauma spine patient, I think all of you are going to get trauma patients.
Yes.
So whatever question you want to ask, you can ask. Dr. Shankaracharya sir is President of Association of Spine Surgeon of India. Sir, welcome sir to Lucknow.
Thank you.
And to this spine conclave. And sir has vast experience in managing any of these kind of patients. So anybody wants to ask any question, they can ask.
I will let Siddharth show you all the screws and I can answer questions from outside. I think this is a simple, straightforward fracture, but it is important to know the landmarks of putting pedicle screws freehand, because 80-90% of the screws we put is freehand, and you don't have to check every time as long as you get your anatomy right. Once you get your anatomy right, 90% of your screws you can get them, and then you can check. So you can put your starting awl, then you can put your pedicle probe and check, or pedicle feeler and check finally with one. Otherwise you will be radiating yourself. All young orthopedic surgeons should be aware that radiation hazards are there. So you should protect yourself and then do minimum radiation with maximum safety. So you should learn your anatomy well. You should not be so dependent on radiation at this moment of time. But you must always check.
So for the sake of audience, sir, what would be the ideal timing to operate this trauma fractures, spinal trauma patients?
You either operate as soon as possible, or as soon as possible means if the patient comes at midnight, you don't want to operate in midnight. You want to operate them. Suppose there was a neurological deficit. This patient doesn't have a neurological deficit, so you can treat it anyway. But if the patient had neurological deficit, this is a thoracolumbar fracture. Obviously, in partial neurological deficits, it is more important to operate as soon as the patient, the anesthetist allows you. So you have to always keep the anesthetist in good humor and operate at the earliest opportunity.
दिखाओ और एक बार नीडल दिख ही नहीं रही है.
OT2 में ऑपरेटिव फील्ड रखिए. ऑपरेटिव फील्ड.
Okay, I think Siddharth, you can take over now.
Yes, sir.
I think Siddharth will show you the bony landmarks and then you can ask questions along.
थोड़ा ऊपर ले लो. मैडम मेरे को अंदर चलो.
So these landmarks are very important. Tomorrow we'll demonstrate the cadaver, but right now it's a chance for you to see all this. Just identify. Dr. Siddharth, it's up to you. Just show us.
Hi everyone. So what we're doing right now is we're just going to make just make sure we identify the right level. And once we have the level confirmed, we'll take off the C-arm and then just show the anatomical landmarks.
Cameraman, can you show the operative field?
Yeah, just 1 minute, just confirming the level. Once C-arm is out, we'll show you. So this was in L2. Right? Okay, everyone confirms it's L2. ठीक है. आप C-arm निकाल लीजिए. So Sandeep, we have exposed around 4 pedicle entry points.
Okay.
There was one pending because the fixation is a 5-level fixation.
So you're going from D12 to L4?
Yes, sir. D12 to L4. अभी नीचे का तरफ का एक level शायद बच गया expose करना. We'll just expose it and then we will start with the entry points.
Sure. So we'll just go to the other OT for some time.
Cameraman can switch over to other OT so that we can get a brief review about that case. In another OT, we are going to have a lytic listhesis. So these cases have like a slippage and they are different than the morning that you have seen. Cameraman, can you please switch to the other OT, please?
Skin.
So, can we acquaint with the case? Right now, Dr. Vigneshwar is there, I think. Hello, can you hear us? Dr. Vigneshwar. Dr. Vignesh, are you there?
Cameraman, OT, keep the OT1 in PIP. जो दूसरी ओटी है उसको पीआईपी में डालिए. दोनों ओटी अभी चल रही हैं, मेन और पीआईपी में. दूसरी ओटी को पीआईपी में डालिए.
निकाल देने दो.
निकाल लेते हैं, दिक्कत देगा ये जगह से.
Spinous process टूटा है. Defect है. 4, 5 में.
So, announcement for the delegates. We are going to start our poster session very soon, within 10 minutes as the proceedings. Okay. So, all those delegates who want to present the poster, just get prepared.
पीआईपी रिवर्स करिए. पीआईपी रिवर्स करिए.
By
मैडम एक spike मिलेगा.
By 4 p.m. we are going to start. Right now it's 15:24. So we are going to start by 4 p.m. Okay. So all those delegates who are going to present their poster session, just get ready with that.
Dr. Vignesh, are you in the OT? Hello? Dr. Vigneshwar, can you hear us? Dr. Vigneshwar?
Cameraman, please do the OT connection with the mic.
Dr. Vigneshwar? Dr. Vigneshwar? Dr. Vigneshwar, can you hear us? Can anyone hear us from the OT in which lytic listhesis is being done? Hello?
नहीं लाइटिक लिस्थेसिस तो उधर है ना, मेरा नहीं है, मेरा ओटी फ्रैक्चर स्पाइन का है. स्पाइक दिखा छोटा.
Hello. Okay. Hello, I am here in this theater. I think Sajan and myself will scrub up. I am Shankaracharya here again.
Yes, sir. We can hear you, sir.
Hello.
Can the cameraman put the camera on the X-ray and MRI of like other OT? Dr. Vigneshwar, can you hear us?
Cameraman, just please focus on the X-rays.
एक लेड अप्रोन चाहिए मिलेगा क्या? लेड गाउन है? Hello.
Yes, sir. We can hear you, sir.
Hello.
तो
Yes, sir. We can hear you.
कैप्सूल प्रोटेक्ट करने के लिए ये चाहिए तो छोड़ दो डेमो के लिए.
We can hear you, sir.
एंट्री पॉइंट्स वगैरह.
Yes, 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 we can hear you.
Hello. Can you hear me?
Yes, sir. We can hear
Yes,
you,
we
sir.
can hear you, sir.
Forceps. Yeah, thanks.
Yes, we can hear you.
What is that symptom?
Yes, yes, please.
Leg symptom or back?
Yes.
क्या है इसका? Back pain. कौन सा side? No back pain. Hello.
Yeah, sir. We can hear you.
Hello. All.
Hello.
Yes,
Hello?
we can hear you. Hello.
Yeah,
Hello.
we can listen you. Hello.
Yes, we can hear you.
Hello. Can you hear me now?
Yes, sir. We can hear you.
Okay. I am in another theater. In this theater, as you know, there was a scoliosis plan.
Yes, sir.
However, when we assessed the scoliosis, this child had a syringe. And
Okay,
a
sir.
syringe with a tethered cord.
Okay,
now,
sir.
if you have a syringe with a tethered cord, it is important that the tether is released first. And only then you should go ahead for doing the surgery. So
Yes,
a neurosurgical consultation was done and the case was deferred. So there is another case which has been taken here, which is a low-grade lytic listhesis in a 47-year-old lady.
Okay,
she
sir.
has back pain and leg pain, both. There is usually grade 1 or grade 2 slip, and it doesn't slip too much. There is a rattler fragment in the back, and that is there is a pars fracture or lysis at the pars, and they get then.
Can the cameraman show the X-ray where sir is showing everything?
Can you see? Can the cameraman show the MRI?
It is very dark. Yes, now we can see. Yes, sir.
McGill. pen de do.
Cameraman, we can see the C-arm, not the X-rays.
Okay, in the C-arm you can see that there is fairly vertical sacrum there, and you have a listhesis with a hyperextension.
We can see the view box, sir. View box.
Okay, you can see the view box. In the view box, you can see the MRI. You can see the MRI here. So this is an L5, this is S1. Can you see my?
Cameraman, please focus.
नहीं दिख रहा?
हाँ सर अब दिख रहा है सर अब दिख रहा है.
अच्छा, so this is a MRI picture. This is a scout screening of the whole spine,
Yes, sir.
intubated, and this is the axial picture. In the screening picture, you can see that.
Sir, your head is coming in
Okay.
front of. Yes, now we can see, sir.
Okay, so in this scout screening whole spine, you can see the L5 S1.
Yes, sir.
There is a listhesis there. Most likely, this is a lytic listhesis because the central canal is broad.
Yes.
And you have foraminal stenosis.
Yes, sir.
So, as you know, in lytic listhesis, it is the exiting foramen which gets compressed by the pseudoarthrosis of the pars fracture and the forward slip. So, the traversing route does not get compressed.
Yes, sir.
So, this patient would have L5 symptoms instead of S1 symptoms. In a disc prolapse, the patient will get S1 symptoms instead of L5 symptoms. So, these are small things you need to keep in mind. So, basically, you will have to reduce a little bit and release the foramen. So, that is important. So, essentially, you will have to do a bilateral foraminal decompression, which is going to be shown here today by doing an indirect decompression by reduction and correction of the kyphosis and posterior translation. So, you translate, correct the kyphosis, and you do a jack it up with an interbody cage and with pedicle screws. Okay. So, I think the exposure, you can now go to any questions on this?
No, sir. This X-ray, this MRI is very much clear, sir.
Okay. So, you can now go on to the operating field.
Yes.
So what's your plan, sir? How you are going to proceed? Is there anything specific for making position to reduce this listhesis?
No, they have not positioned the patient. Normally, in a high-grade listhesis, you would position the patient with hyperextension of the hips so that you try to tilt the sacrum. So, try to tilt the vertical sacrum more horizontally. So, you instead of vertical sacrum, you increase the sacral slope by hyperextending the hips. But here, I don't think you have done that. You have just placed the patient normally prone on pillows which are transverse so that lordosis is maintained. And they have done a midline exposure and they're just going to put in the screws. Any questions? You can see the exposure?
Yeah, we can see the exposure, sir.
Okay.
It's a question from delegates, sir. Just.
So there you have to identify the facet. It is important not to damage the L5 facet.
So the
obviously the S1 facet you will have to do a facetectomy and then do a keep that facet for bone grafting.
My one question is, Sankracharya sir, Dr. Anupam here from Allahabad.
Yes, Dr. Anupam.
Yes, sir. Allahabad, sir. Sir, there is one question from this case, the flexion and extension view on the listhesis, is it important?
Excellent flexion. I think in degen spine, flexion extension is important. In lytic listhesis, flexion extension may not be so important except for standing x-rays. But in degen spine, where you have a small disc height, where you have osteophytes, if you have large facets with hypertrophy, then you may not fix it. So in degen spine, you have to look at whether this degen spine is stable or unstable. So if you have vertical sagittal facets, if you have some subluxation, then flexion extension helps you, because if it more than 3 millimeter translation in flexion extension, or if there is more than angulation, then that tells you that it is fairly unstable and you must fix. But not in lytic listhesis. I don't think in lytic listhesis flexion extension is so important. However, you can see the flexion extension X-ray which has been done here. As a routine practice or as a standard framework you can do. But in my practice, I would do flexion extension more in degen spine, because in degen spine there are degen spondylolisthesis, as you know, does not progress more than grade 1. The degen spondylolisthesis is because of facetal subluxation and facetal wear and tear. And if it is unstable, then fix it. If it is not unstable, if it is low set, if the L4 is low set, if the disc height is small and thin, which is fairly stiff, and if there is some osteophytosis which shows there is some autofusion, then I may just do a decompression in degen spondylolisthesis.
So in that condition, it may be helpful.
And giving a light wash so that the anatomical landmarks are better seen. Demonstrate one or two lumbar spine, then we'll go to the thoracic at D12, and then we will repeat it on the opposite side. So I have confirmed the level. This is 4, 3, 2, 1 and 12 here. Okay. Can you see this? I have exposed the lamina and I have exposed the transverse process at D12. At D12 the entry point is pretty much in the middle of the lamina and it roughly coincides with the middle of the transverse process. Table थोड़ा down करेंगे nibbler. ये निकाल दो. Some more down. Some more down. Okay. Light. Yeah. So I'll just make a small pilot hole with the Lexel owl, starter owl. So again I see my entry point from the middle and it's about 10 degrees or so. Table और थोड़ा down करेंगे? थोड़ा down. Once we have made a pilot hole, then we'll use the Lenke probe, Lenke owl. So first I direct it laterally and with smooth rotatory movements go up to 20. And once I have 20, then I will sound the walls and then so the walls look okay. Lenke again. So now that I've gone to about 20, I will rotate this 180 degree and again by smooth rotatory movements go inside till about 30-35. I'm getting good tactile feedback, feels like all walls are intact. We'll take a sound again. Can you hold the suction as well? Yeah, suction please. Okay, so this feels good. I feel the inferior wall, superior, medial and lateral wall. I take the length, so that's about 40 on the marking because the probe has 4. So 5.5 tap, 6.5 poly, 40. Five 5.5 tap. Yeah. 0.5. So I will tap the first 30 or so. Generally most taps have markings on them, so this is about 25 is the tap length. So I put in all the tap lengths. Again I feel the probe, it goes well. 6.5 poly. No, 40. So generally at this point, if you feel that you're not absolutely certain of your screw trajectory, you can use a candle, wax it, check a CM shoot. So the hold wise it looks okay. Okay. Oops, sorry.
Sir, tapping is always necessary.
So you improve the purchase of your screw if you under tap it by 1 mm. The insertional pull-out strength of the screw actually can be compromised if you try and put a very big screw through a very small hole. So optimal pull-out strength is maintained by under tapping about 1 mm. That should be good enough. So now we are going to the next level.
तो वो तो पकड़ लिया, तुम बांध दो इसको
Can you
ना.
zoom in this level?
Because मैंने गलत पकड़ा.
So I have just exposed the extra capsular exposure. I don't know whether you can see it on zoom in. So what we have done is we followed the bars out here to the base of the transverse process, and we've preserved most of the capsular attachment so that it doesn't get unstable.
Can you give suction to someone else so that the hand is coming right directly in front of
Okay, which hand? My hand or Akshat's hand?
the suction's hand? Whoever has suction. Now it's there. Now it's okay.
Now it's better?
Yes, yes.
Okay. But since I'm right-handed, I might have to move a bit.
Okay.
Okay, so there are 3 techniques. You can follow a mammillary process technique, you can follow an intersection technique, or a pars articularis technique. So generally what I do is I find the transverse process and I follow the intersection technique. We take a small bite at the base of the transverse process. ये पकड़ेंगे? आएगा क्या? नहीं, उस हाथ से. Suction
कौन
is
सा है?
साथ
कौन देगा थोड़ा?
So this is
हेड आ रहा है
the
क्या?
top, this is the bottom.
इसको पोजीशन चेंज करना पड़ेगा.
This is the midpoint, and that's
like
where
this
the
one, sir.
intersecting the base of the facet. This is L1, so not much medial angulation.
S1 डाल दिया.
So about 10 degrees should be fine.
And this is the fractured one.
Yeah, so in the fractured one, but it's not a very bad fracture. But
So
still
like
I'll
this,
direct the
मेरे
screw
को
slightly
starter दो.
inferiorly so that I can avoid the end plate.
That's
So,
good. Bipolar है?
so up to 20 with the line K laterally.
No, I have the.
So at any point, if you're not feeling all the balls, you can always ask for a Siam.
So I do it.
Like
And
here,
then,
Dr.
yes,
Sid-
I agree.
Dr.
Completely.
Siddharth is putting the screws all freehand, so he's always feeling the pedicle, which is the cancellous bone, and how easy it is going, what is the resistance he is offering. So he has that experience now that he can tell he is in the right channel.
Bipolar कितने में है?
But you can always call a Siam and see if you are going right in or not, and then maybe proceed forwards.
So I have developed a trajectory for about 40 mm.
थोड़ा निबलर मिलेगा.
So
I am
tap again.
This one you will put 6.5 or 5.5?
No, I'll put a 5.5 in this one because it's fractured.
Yes.
So I'll tap with 4.5 and put maybe a 35 level screw, slightly shorter, so that I don't end up in the disc space. So I have slightly angulated it inferiorly.
No, I am.
So in fractured vertebra, he's putting a one diameter smaller screw, like other he's putting 6.5, here he'll put 5.5, and also he'll use a little shorter screw. So actually 80% of the hold is in pedicle, so even if you're putting a shorter screw, it will not compromise your hold, but because body is fractured, so you try to avoid putting a longer screw.
This is how you do it? अच्छा अच्छा.
नहीं सर, दूसरा second.
No, मेरे को वो link ही चाहिए. I
नहीं,
know
second
Sergeant
on my
uses
side,
the
first side.
hard Prof because the fellow who assists me, Aditya, he always tells me, sir, you guess Prof.
Okay, we'll go to the next one.
It's good for osteoporosis.
So again, I have exposed a similar anatomy, par. You can see a better mammillary process here.
Then you can use your probe. No? medialize better होता है if you use a lanky ना. I like to medialize my screws.
Bipolar 30, right? 35.
Yeah.
Hello?
Yes.
Dr. Siddharth?
Yes, boliye.
So in that tuberculosis of the spine which Dr. Gautam Javeri sir was doing,
yes,
he made the whole of all the pedicles, then he put the K-wires and the marker and took the CM picture to confirm the position of the trajectory of the screws.
Okay.
So have you been doing that thing before and now you have started putting directly screws, or what was the trend which you followed?
So generally in the middle areas, it's okay. Even if I screw is slightly up or down, I think I will be able to revise it. But then if it's the top of the construct, maybe safer option is to do it that way. But now that you are saying this, you are getting me conscious. So what we'll do is after this screw, we'll just get a C-arm shoot inside and just check.
So even like previously, you must be doing that, putting the K-wires and checking the screws and all.
Yeah, if I feel intra that there is something amiss.
No, what you used to do during your training?
Yeah, K-wire and check.
So you listen, like this is the Dr. Siddharth is also telling, like previously he will also used to put the K-wires, check it on C-arm and make sure that the trajectory is right, then only he'll put the screws. As you do more and more cases, then probably you will start putting screws directly.
चलो देख check कर लेते हैं.
So what?
और एक दे देना. हाँ?
PIP reverse करिए, PIP reverse. The take home message should be, if you are not confident about the landmark, take CM picture, localize the pedicle, then go inside.
All डाल दो, अब बाकी Prof डाल दो, होगा पतला वाला.
Then only you go inside and put the screws. Checking on the CM is not bad. So that's what Dr. Gautam sir was also telling. There is no ego when you are operating. Take adequate time and make sure that you are doing the your trajectory is right, your screw are in right position, and ultimately give good result and come home and sleep nicely. Because my neurosurgeon colleague, so this is the okay. Shankaracharya sir, hello.
Hello.
Sir Sandeep here, sir. Sir, can you tell us what all has been done in this case?
I think a midline exposure has been done.
Okay, sir.
And we have made the 4 holes, L5, S1 and L5 and S1 from both sides. So we have made the pedicle holes. We are going to just check with the image, and a facetectomy of L5, S1 has been done by Dr. Sarjan's consultant. And I have actually scrubbed in to see, because Dr. Sarjan Egde will show me. I'm also learning, as someone just said, there's never an end to learning. He will use the mesonics and he does a special osteotomy cut. So that's why I've scrubbed up to see what he's doing. So let's wait for the...
Here you see sir has also put the owls and is going to check in the CM the position of the screws. So midline will not be removed, sir.
और नहीं है तुम्हारे पास ऑल वॉल पेडिकल प्रोब नहीं है?
ये फ्रैक्चर है, इसमें 5.5 डालूंगा, 35 डालूंगा, छोटा. कैंडल बाद में ना, पहले स्क्रू का होल तो बना दो.
So how many of you operate a wedge compression fracture? Wedge compression fracture, how many of you will operate that patient? Any reason? Can you give the reason why you will operate that patient? Like as it was discussed, a stable burst fracture also can be managed conservatively. Any specific reason of operating a
होल दिख रहा है, बड़ा कर दो थोड़ा होल.
नहीं इतना ज़्यादा नहीं. 1 mm का, 1 या 1.5 mm. वो कर दो थोड़ा. नहीं कैंडल है ना, कैंडल चल रहा है.
Noise to the patient. And usually when it is of multiple levels, it is like neurology intact burst fracture. I pretend to give first option. Ultimately the patient decides. And I give the warning signs to the patient in case of needed for surgery.
Okay. So what you will do in case of fracture dislocation? Type C fractures, let's say it is D12 L1 type C fracture, what are your fixation level? How many screws you will use?
It is a fracture dislocation easily will go long segments, sir. 2 level up and 2 level below.
2 level down. Okay, great. So you are from which place?
Nepal.
Great. So anyone can is it? Will you always rely on indirect decompression, or you will sometime go for direct decompression also in case of burst fracture? Anyone?
पहले
Sir,
bone wax लगेगा फिर K-wire.
direct decompression.
K-wire नहीं लगेगा,
burst
candle
fracture
डालेंगे.
में कि indirect decompression is
Bone wax.
sufficient.
Need a
In
proper,
thoracolumbar fracture, let me interrupt
radiological
since I am
changes
hearing the
must be,
question. Can you hear me?
Yes,
No.
sir.
In thoracolumbar fracture, there is never a need to do a decompression unless more than 70% of canal compromise is there. Most of the decompression is done by positioning. And if you fix the fracture in situ, if the superior end plate, as I said earlier, is not too badly fractured, they will heal. Now, the concept of distraction and reducing the fracture fragment is only possible in early days of the fracture. You must understand that the PLL is a cruciate type of longitudinal ligament which when distracted, which is thin, fairly thin, and only if the burst fragment is midline and large, then it will go down a little bit. Otherwise, you can do a small laminotomy and push that fragment down. That's more than enough. There are good studies to show that even if the canal is, if there is no neurological deficit, there is no need to do it. Get the alignment and it should be all right. If there is total neurological deficit, they are mostly fracture dislocations, so once you fix them, there is not much retropulsion usually. However, in partial neurological deficits, you may want to थोड़ा angle करना पड़ेगा ना. So we have to angle it down a little bit. बाकी तो ठीक है, मेरा वाला सब control किया है.
OT1 can you show the picture of OT1?
I like subcontrol. He doesn't like subcontrol. I like subcontrol.
OT1, can someone put
That we
picture
can
of
change
from
that actually.
OT1?
Change कर देते हैं. Huh?
Sir, we can see the X-rays, the C-arm picture.
Yeah. इसको निकालना है.
Dr. Sandeep,
yes, sir.
Meaning thereby the
Bone wax
anterior
डालने
and
से होगा.
middle column if it is intact,
नहीं है.
fraction the posterior column intact, then no need to.
मेरे
go
को
for
एक
the
वो देना,
only the fixation
लंकी
is
देना.
enough. Dorsal lumbar
है.
function at the dorsal
Only
lumbar.
posterior column is fractured.
No, posterior is intact, only the wedging is anterior and the middle.
Anterior column only wedging is there.
Yeah, yeah.
We usually manage by conservative method. And obviously no decompression.
No decompression.
No decompression.
Only the distraction.
Change कर देता हूँ direct.
Yes.
Okay.
Even if you fix it, it will do.
और एंगल में. क्यों? एंगुलेशन ज़्यादा करना है ना. हाँ.
ठीक है, अभी एक मिनट, इसमें भी
Want to check again? No.
Bone wax.
इस साइड
45 डाल
करेक्ट कर लो.
डाल
इधर देना.
अरे बाबा, इतना तो पूरा केस में ही खत्म हो जाएगा. नीचे में कर देगा.
ये है ना. कौन सा है? Angle. Which one you want to change?
कैंडल दो तो. आपके पास कुछ पेनफील्ड ड्यूरा जैसा कुछ है?
What do you want? We have not put the screws. No, the L5 seems. You want even more down? Okay, okay. Come.
एक CM tube ले लो, AP और lateral.
Wait, give me bone wax.
Dr. Shankaracharya sir.
Bone wax ना.
Dr. Sanjay.
Bone wax नहीं है? He got confused with me, I think.
Not before 1 year.
Before 1 year. Let's hear from everybody. It is like
AP और lateral दिखाना है.
आप कब निकालो? Same case. You have that. When to recommend to get this
AP भी दिखाएंगे? क्या सिर्फ lateral दिखाएंगे? ठीक है, lateral दिखाएंगे.
The whole table. What is the rationale behind 1 year or 6 months or it?
नहीं नहीं. एक wash देना, एक scrub देना. Just.
I think you got disturbed because of the positioning and everything. This is not how we would position on the
You would do extra hyperextension, na?
No.
Then?
Our positioning would be very different. Not the way we do.
Well, how would you do?
This is not the way we do it. Chalo, let us.
There is hyperextension L5. I also would not do it this way.
I don't know. Mostly not better.
Dr. Siddharth.
Yes.
So in this case, when will you plan to remove
On this
the
side
implants?
is the center of the pedicle. My side
At
is
least
slightly
18 months.
subchondral.
18 months?
Yeah.
You want
18 to 24 months before I offer implant removal.
Okay, so not after 1 year?
No, I think I am a little conservative. Even then, I would probably do a CT scan, counsel the patient that sometimes you can have late progression of deformity. But once you are convinced on the CT scan that the fractured bone has united, then you can be more confident in offering
table
an
is
implant
lowest?
removal. Okay, can you show from the top screw? I have put 3 above that. So because you have said, that's why we have just put a candle and taken couple of shots for the last 2 screws.
Right.
This is not the way we do.
So
Not how we do.
I think we are okay so far on the lateral. We have put slightly shorter screws in the fractured vertebra at L1 and at L3. The other ones we have put 6.5 40 mm, and at L1 and L3 we have put 5.5 35. You're okay with the Siam? We'll go ahead.
Yes. We are.
Yeah. Okay, thank you.
I don't know what it is, what is different, but this is
Dr. Harpreet, you take on this. Put this through.
something has to be.
I think it will open up at least 80%. Better than 1 week.
5.5 35.
If you'll put a good lordotic rod, which Siddharth will put, I think, it will open up at least 70 to 80%.
tap करेंगे 4.5 से tap.
But you will have to measure it with the pre-op and it will open up.
बड़ा स्टूल नहीं है बिकॉज इसमें गिरने का चांस है. बड़ा स्टूल है नहीं है ना?
Yeah, 5.5
तो
35. नहीं ये सामने वो लेंगे
Like to do in a normal. Okay, go.
हाँ ठीक है. 5.5.
Put on my light. Apaji.
Okay, next 6.5 poly. 45.
What's the blood pressure now? I'm not used to doing this spine surgery this way. I don't know what is different, what my anesthetists do. They do a lot different. I don't know what. I think people should come, see. Okay, give me the, what are the, give me the Prof.
can put bone voice. I think there is a hole there. No?
Where did you start?
Dr. Santosh,
5.5 time.
my one question that these patients, if you are performing a longer period of the surgery, there is a bleeding. So, anesthetist दे से कि क्या blood pressure को थोड़ा कम करके चलें? Need to
blood pressure in spine surgery we maintain mean blood pressure of 80 to 85. This is what we always do. Blood pressure has to be like around 100. Systolic blood pressure. If it is not contraindicated. And obviously we will give tranexamic acid before surgery 1 gram. And sometimes we give infusion of tranexamic acid also. To make sure that there is less and less of bleeding.
Give me the scraping. Come on. Scraping.
This skin, before incision we do put xylocaine with adrenaline in the skin.
This is what you like.
No, that is the like spine. When you are doing spine surgery, hemostasis has to be there. You do one TILIF and ultimately transfuse 2 units of blood. That is not acceptable. And normally we in 1 level TILIF we don't ask any blood because usually it is 150 ml blood loss or maximum 200 ml blood loss.
You want me to come out?
No, I put xylocaine adrenaline. So that I discussed with my anesthetist. They were telling like whenever we put incision. No, just like after induction, when we induce the patient is lying prone, putting xylocaine and adrenaline, I discussed with my anesthetist. So adrenaline we can understand, it will decrease the bleeding. Xylocaine will anesthetize the skin. So when you are putting the skin incision, it will not cause fluctuation in blood pressure and this heart rate. Because any noxious stimuli at the skin, even after anesthesia, does causes fluctuation in blood pressure. They will say कि after अभी आपने incision लगाया इसलिए blood pressure बढ़ गया है because of the pain stimuli, and after some time it will settle down. With xylocaine adrenaline, this fluctuation is less.
Different view because I operate all my lumbar spinal.
That is
but
not
don't use VA for lumbar.
I can change my.
Till what level you do spinal anesthesia?
Anything below L1 is all spinal.
And how many hours of spinal?
Hours, 2 hours, 2.5 hours.
2.5 hours for spinal. So you will do TILIF in spinal.
Yes, with OR.
So how do you manage this blood pressure?
I don't feel if it is bleeding, you have to find the bleeder and stop it.
Spike
No, the good thing about general anesthesia.
Even before I was doing percutaneous in my center, I think more than 15,000 surgeries have been done. But every surgery in lumbar spine is being done.
So this is, in my life I have done only one discectomy in spinal. It was L5S1 disc, that's why I agreed. And when I did fenestration, that patient started coughing. So whenever he was coughing, the dura was bulging in the field, and the bleeding which was there, I told anesthetist, please control blood pressure. He told in spinal we cannot control blood pressure. So next time that anesthetist told I'll give spinal again, I told I'll not do the surgery. Because in spine surgery, why we stress about bipolar? We stress about bipolar because with that you can achieve the hemostasis. If everywhere there is blood, what you will do? So hemostasis is the key. Blood pressure or management of a patient under anesthesia, if you talk to any anesthetist, they will say, sir GA में हम patient को अच्छे से manage कर सकते हैं, spinal में हमारा control नहीं है. जब हमारा anesthetist ही comfortable नहीं है तो हम कहाँ से surgery कर लेंगे? We are the surgeons. We need to do the surgery. And if you have an anesthetist like Dr. Swaroop, then probably we all can do under spinal. No, if we have doctor anesthetist like you have. I have heard many people doing spine surgery under spinal, but we don't do. I don't do. Sir.
Yeah.
I have the unique experience of doing this surgery under local anesthesia. So, no point in laughing. In our Campbell, there were actually 15 pages of Campbell operative orthopedics devoted to this surgery under local anesthesia. This surgery, under local anesthesia. The first surgery that I did, this surgery, was under local anesthesia. Reading the book, reading Campbell, and it was suggested that it is a very good method so that you can identify the disc that you are, the nerve that you are touching.
5.5
tap,
awake, 6.5
you can talk. So I used to give
6.5 screw
and put a
40 years. All broken.
So grip can be increased or decreased. If you want more
Yeah,
and
ratchet
more,
angle,
increase the diameter of grip. And if you want less, you can reduce. That was 79. That was 78, 79. And since then, we have come a very, very long down the lane, and the pages in the books have never been written again. अभी कैम्बेल में वो pages नहीं है.
Now give me an all
pages of वापस आएंगे.
6.5 poly 40
is very much being done under local anesthesia, and it is done beautifully. Just with local anesthesia, with or without adrenaline, it's
Sir, even endoscopic fixation.
Endoscopic discectomy, endoscopic laminotomy, foraminotomy, even endolith, we call it.
मेहनत कम करनी पड़े इसलिए उसने भगवान ने बनाया है.
Are being done under local anesthesia plus some amount of epidural anesthesia in those. Patient is very comfortable. Actually the patient is aware, and whenever we go near the nerve or whenever there are any chances of nerve damage, the patient will scream and shout, and they will stop you. So it's a kind of self neuromonitoring by the patient himself. You don't need any fancy monitors for that. So this is coming up.
Next
really
6.5 40 load.
So in Campbell's soon it will be there.
Fracture spine में
History
एक
will
side
repeat
बोला था
itself.
ना.
Sometime we can perform the vertebroplasty and kyphoplasty too in the local. Just you put this cannula inside and you can put the cement as kyphoplasty and vertebroplasty.
Vertebroplasty, transpedicular biopsy, everything can be done under
Local anesthesia, we can do it.
But the only thing is like you have to counsel patient. We will try local anesthesia.
That
try
is-
and doing under local anesthesia. If
But-
you are comfortable, then only we can continue.
But putting a pedicle in the local anesthesia and if it is in the open,
There are
then it's
people
better.
who are doing, so I am not the, I should not comment on that.
I never did it, so I may not having experience.
Just for the purpose of bleeding in the field is there. Some basic things you have to remember. Basic things being the positioning of the patient and whatever comorbidity is there, hypertension is there, that has to be controlled either by medicine or anesthesia team. Positioning is must. And in lumbar you can go for hypotensive anesthesia, but there are two things. In cervical you are operating, and dorsal spine you are operating. Even if bloody field is there, you have to keep your mean arterial pressure above 85 because it alters the result, post-operative result. अगर आप hypertensive के लिए जा सकते हो, आपने hypertension control
above
करना है,
80.
patient की position ठीक रखनी है, and you have the better option of tranexamic acid infusion. You go for tranexamic acid infusion before your surgery, just before incision. It gives optimal results, excellent results. These are the basic parameters you have to keep and follow to get a proper lumbar spine. And cervical and dorsal, that you have to keep.
This to like remember in short, keep mean blood pressure above 80. Whatever you are operating, it has like in number you can go down, but I think keeping above 80 Nazim is good enough wherever you are doing the surgery. And this tranexamic acid, you can use in every cases.
And in open surgery, subperiosteal dissection is the key. You cannot leave muscles attached or cutting with the cotton. Subperiosteal dissection, if you have done it, you will get a really clear, clean feed.
How many of you do dissection with the osteotome? Does anyone do dissection with osteotome? Cutting the knife cutting with the knife the deep fascia, then taking the osteotomy, erasing the muscle from the spinous process. You have done it.
Yes, when I used to do open, then
So anybody else has done it. So I have also even done it. So the
6.5
exposure or the field which you get with the osteotomy is not as bloodless as we get with the cautery. So that's why it has become now a standard of care. General anesthesia, having cautery, having bipolar, all these are standard of care.
One thing Dr. Sarup mentioned that.
So Dr. Siddharth.
Hi.
So Dr. Siddharth.
Yes.
Can
Sandeep,
you tell
we
us
can hear you.
till like you are putting screws on the other side, I think.
Yes, Dr. Akshat is putting on that side.
Okay.
We have completed 3. So just want to ask the audience, how many would like to put a screw on both fracture levels on both sides? I have put one on fracture level on one side. I was planning to skip on the other side. Is Waliullah okay with that?
Waliullah sir is not here. He is gone for poster presentation.
Okay, but what about you? दोनों साइड डालने की जरूरत है या छोड़ दूं एक साइड?
I think Siddharth, you put both sides, so you'll get a better correction of lordosis, I think.
Okay.
I will skip lesions. I will skip the levels.
So the initial plan with Dr. Shankar Acharya was to skip one of the pedicles on the fracture levels.
I think it's L1 and L3. So I'll go for bilateral screw in D12 and L2 and L4. And I can skip one screw in the fracture vertebra.
Okay.
So my question to Dr. Harpreet is, you are telling there is a wedge compression fracture. There's a compression fracture. So what has happened, like the trabecula has fractured, and obviously there is decrease in height. So when you distract and open, will it not leave a void and ultimately not lead to pseudoarthrosis?
You do ITPL osteotomy in tibia. You open up the wedge and leave it, and the God will fill it. So that's how it is. It's a cancellous bone, and it's a young patient. So if your job here is to maintain the spine alignment and get the lumbar lordosis back to as normal as you can, and get the height back. So if you have to open it up, that will give you indirect reduction, and that will also correct your lumbar lordosis properly, and then that all will heal up. I don't think because that cancellous bone is only crushed, so whatever hematoma will be there, it will become bone finally. So I'll prefer to put both sides and get a good correction with the lordotic rod.
But doctor, तो उसमें भी होगा. Same.
Shankaracharya sir, can we know what all you have done till now? Acharya sir?
Siddharth is there.
Hi.
Hello?
Yes sir, we can listen to you. We can hear you sir.
Yeah, okay. I think we have put 3 screws and we are putting the last screw.
Okay sir.
And you can watch how Dr. Sarjan does. He does it slightly differently. He uses a hard pedicle probe and he goes in for a few millimeters into the pedicle and then pushes it to the cancellous space after making a pedicle hold. So his technique is slightly different. Our angle. So he uses a Steffi, which is an older version, old one which we used to do in our early days. Nowadays we don't do that. You will just see him using this angle gun. You can use your wire and angle it. So after the 4 screws are put in, which is standard for most people, then you would have to do a facetectomy of the inferior facets of S1. You want to preserve the facets of L5. And after doing a facetectomy, you want to expose from one side and then go into the disc space. You must get the angulation correct, and then you can distract in the disc space, put a rod on the other side and distract, and then you can put a cage and then reduce over it.
5.5.
So what Dr. Siddharth was doing was he took a ball probe and he was checking all the walls of the pedicle hole. So
that is not, now what is being done here is slightly different.
Yes, sir.
This is like a open percutaneous fixation. You put in the, you start with the pedicle or starter or a awl, and then you put in a hard probe till you reach the pedicle into the posterior vertebral body and then push it in. That time you feel the vertebral body.
Okay,
And you
sir.
can feel. So this is slightly different, as you can see. Yeah, this is cannulated screws.
सीएम के लिए बुला लीजिए. Okay, give me the mesonex. बस. और एक टर्न, आधा टर्न. बस. मैं काट रहा हूँ. मैं usually wash डाल. निकल देता हूँ. EP और lateral दोनों shoot.
Huh?
But we can put a.
He has his own ways of putting the screw, na?
Yeah. Realign. Okay. Yeah. Lateral दिखा लो पहले. Is it too small? A little bigger. Okay. आप press. No, this is. आप press it.
These patients can be mobilized next day.
Fractures.
Yes, the fracture, traumatic patient can be mobilized even on the same day. Like if he does not have lot of back pain, what we do is like we make the patient sit on the bed. If he is comfortable, he can stand. If he is comfortable, he can walk. From surgical point of view, we don't have any restriction. From pain point of view, he can move on the same day or on the next day. It's up
No
to
brace. No brace and etc.
No brace. Brace is not required.
Dr. KD?
नहीं मैं सिद्धार्थ ही बोल रहा हूँ.
Yes, Siddharth. Yes, Dr. Siddharth.
Okay, so we are just seeing the final Siam shoot now.
Focus on the Siam.
So Siam ka. Let us see. Give me the. और ऊपर.
Yes, we can see.
Maybe one turn of the last thread.
Now you can see that Dr. Sajan has put up a rod at S1, and now
So
he's
we have
using
not
the
put
reducer,
fracture screw on both sides.
which
We
is
have
the
put on
screwing
only one
device.
side.
Can you switch to, can you show the OT1 in PIP? OT1 in PIP? Yes.
Okay, so any other questions?
Any question from the trauma case?
Last was the screw का एक turn.
नहीं हुआ नहीं और करना लाइन दोनों सेम आएगा.
Sir, don't you think the fractured screws which you have put in the fractured vertebrae should be little longer so that we achieve a better and a
So
full
like I think it was discussed earlier, we put a 35 mm screw. The pedicle length is generally 30 or so. So the most purchase is in the pedicle because that is the unfractured portion of the vertebra.
Agreed.
In the body per se, because of the comminution, the last whatever 4 threads or 5 threads of the screw that are there in the body might not serve much of a purpose. But yes, on the X-ray it looks maybe a 40 will also go. So I can maybe do the on the opposite side, at least at the L3, which is the burst fracture, I will put one slightly longer screw. And at the L1, which is mostly like a wedge and not much retropulsion, we will just accept this current screw because we have 2 good screws above.
While they
The above screws are 6.5 and 40 mm, so I think that's a good enough purchase for the proximal UIV.
Agreed.
Okay. Additionally, we are not disturbing the midline. We have not disturbed the facet capsules on both sides. So a lot of the natural barriers against progressive deformity are still being left intact.
So I think this should work well for this gentleman or this boy here.
OT1, can you show the CM pictures? OT1.
This is OT1.
नीचे में एक फ्रैक्चर साइड में 5.5 का 40 का स्क्रू रेडी कर लेना L3 के लिए सर हाँ
that you were discussing about the screw in the fracture segment, fractured vertebra. Sir, you were saying to put one screw on one side on your screws on both sides. Sir, what to take into consideration when we decide either we have to put index or this fractured vertebra screw or what are its advantages and why did we put
थोड़ा
So once you have a disc fracture, you have to see the MRI sagittal views and you have to see the fractured vertebra sagittal views on the pedicle side. So if you see the pedicle is intact, then you can do a short segment fixation. You don't need to go 2 up, 2 down. So you can put 1 up, 1 down. The condition is that you should have at least one screw in the fractured vertebra. So if both the pedicles are intact, you can put on both the sides. Or if your one pedicle is fractured, you can put on one side. But if you're not able to put on any of the sides on the fracture vertebra, then it's better to go at least 2 level up and
in a burst
2 level
fracture
down.
that he's talking about.
Yes. So it will become burst. No. If your pedicles, if you don't have any pedicle to put, then it is not a flexion distraction injury or a wedge compression fracture. It becomes a burst fracture once both the pedicles are fractured. You got my point? Put a 4 screws. Put 1 level up.
Like T12, L1, L5. In these cases, we have to go 1 level above or not. Like in cases of Angstborn.
Which fracture you are talking about?
So if it is junctional, like thoracolumbar.
You are telling about D12 fracture.
Yes.
Okay.
In that case, we have to go 1 level above or not.
Just move.
1 up, 1 down, put in the D12 also. So 6 screw construct is sufficient. The concept of going to D10, this we follow more in case of degenerative spine, not in traumatic, not in even tuberculosis.
Not even in case of junctional,
Not even in junctional cases. You have to follow the fracture morphology and then accordingly decide whether you are going to put 8 screws or you are going to put 6 screws.
And sir, what about cases like Angstborn?
Angstborn has to be long. 3 up, 3 down.
Pre-cut rod 150 का है. Pre-cut rod नहीं है तो 300 का rod दे दे. उसको आधे में काट दूंगा.
So Dr. Sarup wants to answer about Angstborn.
See, Angstborn different ball game. It is not like a normal fracture which you say. So this is an entirely different thing. I don't think we are going to discuss that. We can discuss first.
150
I don't think you have to treat it in similar way. But if you are a learner, I think 2 up, 2 down is the dictum. Until unless you start getting your own judgment and better understanding. So put 2 up, 2 down. If you are starting with your spine cases, that is a safer side to go. And as you progress in your career, you can definitely go with 6 screws construct, and your understanding will also improve by that.
And getting a CT scan in fractured traumatic spine is not bad. Even the guideline says you don't get MRI, get CT scan. So if you get a CT scan apart from X-rays, you'll have much better understanding in case of traumatic spine.
See, I'm starting lower down. Sandeep, you get CT and MRI.
So in my case, I'll not say that is in my hospital.
3,000 rupees CT scan and 3,000 rupees MRI.
In my hospital, if we are getting an MRI for traumatic spine, by default they'll do a CT scan also, free of cost. So that's how I get benefited.
That depends what is the cost of the MRI.
No, it is irrespective. That is for the radiologist purpose.
So
but if I have to do with even with the payment, I will get a CT scan in case of trauma spine.
So what we do is like we prefer MRI because that shows actually the neurological compression, and then there are with advancement of technologies there are artificial intelligence protocols which develop the bone window with your MRI.
In India till there it's not there.
And right for angspond actually it causes fusion, so they have got long lever arms. So in ankylosing spondylitis, the Anderson lesion, the lever arms are long, so you need to go long segment. What we have seen at AIMS and all, they at least 3 levels up and 3 levels down.
In angspond, what is there? It is like femur fracture. You have shaft of femur fracture. You want to plate. Will you put a plate with one screw up, one screw down, or you put a long plate? If you can answer that, you can answer angspond also.
Now give me the rod, long rod. Realize.
We are also going to have one more piece disc that is
just
increasing
S1
on
screw.
the roti.
One
So
S1
within
screw.
probably few minutes you will also see.
Because he is good. Hold अच्छा है. It's in an odd place. It's not going to be a lovely looking X-ray.
Shankar sir, we have a question, sir. Your tips for how to avoid post-operative radicular pain.
We'll put this at the same level.
Shankar sir.
नीचे जाएगा और नहीं एक मिनट.
Shankar sir.
Yes.
Question for you, sir. Sir, how to avoid this post-op radicular pain? Your tips and tricks, sir.
Post-op radicular pain in which patient?
Yes, sir. Lyticlesis, sir.
In which patient? In
Sir,
the one
this
we
is
are doing?
Listhesis patient, sir. Listhesis patient, sir.
Well, I think post-op radicular pain means you have to take pre-operative, per-operative precautions, obviously. So you don't want
That's
to.
what we want to know, sir. That's
You
what we
don't want to fiddle around too much with the dorsal root ganglion and the exiting nerve, because that is where you get post-op radicular pain. So you should be very careful. Sometimes you don't need exiting nerve, only the traversing nerve you need to see, and you want to work between the exiting and the traversing nerve. After you do your facetectomy, superior S1 facetectomy, you want to distract the other side a bit so you get a working space, and put a cottonoid or a cottonoid at under the surface of L5. As you know, there is a listhesis, so there is always a height difference. So you have to be careful, and sometimes because of the pseudoarthrosis, the fragment the pseudoarthrosis fragment may impinge on the nerve. As you know, the vertebral body slips forwards and the pseudoarthrosis slips downwards. So that is where it impinges. And a lot of times you get pseudoarthrosis causing pain on the exiting nerve root. So these things you have to avoid. You don't want to fry too much. You don't want to cauterize too much. Don't want to put some traction. When you are putting in the cage, you be careful not to brush along the margin of the exiting nerve.
Okay, give me on my foot on the thing. That is become loose.
So what is your line
Oh,
mark?
Yeah, hold it.
इन्हीं देना भैया.
In this, it is not a classical.
Sir, are you going to remove the rattler, sir?
It's a light here. We are going to remove this.
Sir, what are you doing, sir? Sir, are you removing the rattler, sir? Fascectomy.
Bang and back.
Vineet निकाल दो.
Pusher.
No, give me a scoop.
Sir, hata. Sir, hata.
Gentle.
इन्हीं दे और. Bang and back.
Okay, knife. Do I need to knife?
Next pulley. Next. Okay.
Clear that. Yeah. Take it out. Okay. Up cutter.
Yes, please ले लीजिए.
Okay. Take the dissector. Cutter.
Tell me when on.
Okay, take a black.
Neurology of all the patients that we have previously operated today is intact. All the patients are doing well.
Take it. No.
High grade listhesis and
like
everything.
that.
It's very intact.
Yeah. Vignesh, come distally. Yeah. No. Take this back. Yeah. Okay. Knife. You'll be ready to
Now
start.
he's doing this annulotomy.
So presently you are working on the disc, sir. So can you explain what you are doing, sir? Sergeant, sir, what you are doing presently, sir?
Okay. Next slide.
Exercise 8.
Section. Center. Okay. Next slide. And big one. Keep the big one ready. 10 or 12.
Right now they are entering inside the disc.
Next slide.
They are trying to enter.
What is that? Give us 12. I think we have to really get it. Yeah. Okay. Shankar, blow. Right, gentle blow. Yeah. You good? Okay. Get in there. Yeah. Are you in? Very good. Okay. Okay. Now,
Want me to distract?
yeah, keep that. Very gently देखो. घुमाना है. 90. घुमाना है.
सर मैंने लूज नहीं किया
Okay. एक मिनट. घुमा नहीं अभी.
नहीं.
Can we have in PIP the other OT, OT2?
Every bit.
Cameraman?
Yeah.
Shankar, do you
Yeah.
feel it?
Yeah.
OT2 in PIP.
The goal is to get as big a gauge as possible. Okay. Now, bro. And erasers, everything ready? I may not need that black color. You're good here. Yeah. We still have a listhesis, but it is less. This is osteopenic bone. So using these razors, you have to be careful because it can dig into. Let us be careful. But it is okay. So I move it all direction. Okay. Okay. Globus. Already it is good. Shankar, you want to feel it?
Yeah.
Already, just keep it up, upward, and gently move it.
Yeah, you can feel it.
Take it. Okay. Chal. Or Abhi. Yeah. Okay. See, you said that sound.
Yeah.
You're happy with it?
Yeah, I use this all the time.
Okay. Yeah. Okay. Chalo. Now wash. Okay. I'm okay with this also. I don't want to overdo it.
Yeah.
Okay. So Pidget, come on. Very good. And thank you, Doc. Whatever you have done is now it's not oozing or anything. I hope the patient is okay. Okay, right. I am good. Okay. Pidget. end plates are okay, so we don't need to do lot more. Yeah. Wash, now the size.
So now we are preparing the end plate and the preparation for the cage, as you saw.
Yes, sir.
So you can see the picture, na?
Yeah, yes, yeah, we can see.
Basically, we are using a distractor, distract the and keep it in place, and then use shavers, and then you use angled curettes, and once you feel the bone
No. Signature. Not ready, yeah? Yeah, we need a signature here. Is the graft enough? Graft is very little? No, very little. We'll Mesonex. Just get me that. Okay, somebody take a. Yeah. The bone is very, very soft, Shankar. So we are playing with fire actually. But let us hope it all comes out well. So my use of rough cutters, everything has gone dramatically down. Anyway, with my arthritic hand,
it helps.
take it for निकाल दो. Be careful. Yeah. Okay. Did you break it?
No, this is
Okay. Take this. Okay, I think I need dissector and a knife. Okay. Hold this, somebody? Can somebody hold this?
Yeah, I'll hold this.
Yeah. Okay. ये निकाल दे. Okay. Let's move again. Go. You got the entire? Yeah. Yeah, all this we can use. Okay, chalo.
And make bone graft.
Sir, there is a small query from the audience. Any special advantage in preserving that midline structure which
I think you want to say that. Any special advantage? I think Dr. Hegde doesn't like to sacrifice the midline at all. Yeah. And so do I. I never sacrifice the midline. I keep the midline always intact, except when it is stenotic.
So in degenerative listhesis, sir, you remove midline?
No, not really. In degenerative spondylolisthesis, also maintain the midline. Only in light, elongated listhesis, elongated lytic listhesis, you will observe that there is a central stenosis at L4-5, and that needs to be then removed, because otherwise you can get cauda equina on reduction.
Okay, sir.
Okay. The reduction is not full, Shankar. We are quite okay. Okay. Graft. Are we having any more, or is it done?
How much we have? That is for the graph.
What?
What graph? For the cage. So the bone graft has been put anteriorly first. So you want to have a small layer of bone graft anteriorly, and then we are going to put a banana cage. So this is a cage which will rest anteriorly and transversely, not obliquely and straight. So you have two types of cages. You have an oblique cage and a banana cage. Traditionally, we always used to use banana cage, and I also at L5S1 always like to use a banana cage.
The screw in the sacrum will look a little odd, but that's okay. As long as they're holding it, okay.
So this is just show them this. This is a special banana cage which will go in vertically. This is special banana cage which will go in vertically, and as
And
you
I will turn it.
and as you turn the golden knob or the black knob, it will turn transversely. थोड़ा और पुश करके टर्न करो.
Okay, turn.
और थोड़ा पुश. हाँ मैं मारू. How do you know? Maru? I think okay. और जा सकते हैं.
We have to see this clearly.
Do you have a measuring there?
No. Mark, थोड़ा hard.
How did you know?
ये पूरा सॉफ्ट टिश्यू के साथ में आने लगा.
अच्छा ठीक.
Anyway, some minor this thing we will make. Oh, what is it? Wash.
Hammer.
Yeah, it is a little superficial, so we'll hit it. ये पकड़ा.
मारो.
We accept it. छोड़ो. Did it fall?
Yes, it falls.
Very good.
Question with
Rod. Realize. Give me that small rod.
Rod sir.
Get the fucking thing, please. Okay, ये rod वाला उसको हाथ से डाल दे. The reason why I like this shotgun is because of this configuration of the closing mechanism. Unlike the Medtronic, where you put tremendous torque on screws.
Yes.
And if it is osteopenic bone, सब हिल जाता है.
हाँ हिल जाता है. सही बात है.
देखो इसमें नहीं
हिलता.
कम है. Dramatically कम. No, I am not good. wash, big wash with antibiotic solution. I still like it intact.
Yes,
It
I
may
also
not
like
be very useful here.
Yeah, yeah, I also like it. I agree.
They don't. Okay.
Any questions before we take a CM?
No, sir, we have seen the cage going inside.
Is there any questions from the audience?
How far we can go lateral side? Yes. How far we can go for this? Making a window to go inside the disc. Kitna? Yeah. We can go from lateral to anterior here, from midline.
So,
No.
can you please shift
Making
to the
this
other OT? Like,
window from going to the disc E space.
As in this
exactly.
Screw,
How
this screw gone subchondral
far we can go from the lateral side?
इस side वाला अभी भी subchondral.
Exact. Yeah.
हाँ.
Yeah. नहीं. Lateral कितना जाना है?
Yes.
Exactly.
The lamina, then the medial
Agreed,
facet, lateral
100%.
facet,
Exactly.
and then you can make.
I've told Nizam.
Exactly.
So that will be called transforaminal because you are going through the foramen. You have removed the medial facet, you have removed the lateral facet, and then you are lateral to the nerve root. So
Lateral to the nerve root.
lateral to the nerve,
Okay.
and then you go inside.
cameraman, can please shift to the other OT? So the last case of the day is like discectomy that we are going to see. Dr. Appaji and Dr. Gautam Zavi both are there. Let's see who is going to. For the sake of, no, it's not a microscopic that we are doing because of the, we want to show everything how to go ahead. So it's not a microscopic discectomy, it's an open discectomy that we are doing just for the sake of demonstration.
Lytic listhesis, can we have picture of the C-arm? Lytic listhesis, picture of the C-arm?
Yeah, we'll show you in a minute. I think the reduction is good, but one of the S1 screws has cut through a little bit, but it should reduce तो हो गया पूरा. हाँ, change कर देता हूँ, मैं कर देता हूँ. Which side is it? AP दिखा दो. अच्छा मेरा side. हाँ, so we can change the screws. हाँ, कर दो screws. We will change the screws. We have to change one screw, S1 screw on the right side, because that has cut through a little bit of end plate. So we'll change that now. पीछे कर दो. चलो खोल दो विघ्नेश, कर दो change. तुम्हारा तरह से करो.
Can we have the C-arm picture?
Yes, we can show you the C-arm picture. इनको
The reduction is complete.
Yeah, reduction is perfect.
The cage is good.
Cage is good.
Cage is in a good position.
The cage is in a good position. The reduction is complete, and only
You have to go distally.
Distally, yeah.
We cannot see the
Yeah.
C-arm pictures.
Yes.
हाँ?
तभी जाके होगा.
कर देगा?
हाँ. वही कर देगा. I think in a training course it's always good sometimes to have a problem and then know how to solve it. That also is important.
So can we have the C-arm picture? We have
Yeah, उनको दिखाओ यार CM picture.
It's dark. Cameraman, it is looking very dark.
नहीं but अच्छा नहीं लग रहा ना, ठीक नहीं लग रहा. I think we should need to. हाँ, lower and distal. It's holding only at the pedicle, na? So light.
The screw which is going into the disc space, that one you are removing, sir?
हाँ?
The screw which is going into the disc space?
ये previous था, तो उसी में जाएं. अब नया होल कौन सा था? नहीं, इसी में. Bone wax. अच्छा, bone wax देना please. डाल थोड़ा लाइट देख. एक डिसेक्टर देना, नंबर 1 पेनफिल्ड या कुछ देना. बहुत ज़्यादा हो गया ये नीचे. और थोड़ा एंगल ये नहीं करना है ऐसे. डालो, ठीक है, डाल दो. हाँ, मैं देखता हूँ कहाँ, मेरे को दिख नहीं रहा इधर से. हाँ, you can tilt it a little bit more. Yeah. हाँ, कर दो. यही वाला एंगल है. हाँ. हाँ. तो इसमें क्या क्या? You use the stepping. I'm not used to the stepping. इसको पकड़ो.
और एक है
क्या करना पड़ता है?
मैं तो करियर.
हाँ?
स्टेराइल है क्या आपका सेट? ठीक है, वो गरम तो मैं सहन कर लूँगा. मैं गरम हो जाऊँ, उससे अच्छा इंस्ट्रूमेंट अच्छे गरम हो जाए तो अच्छा.
Yeah. How do you know how far you go?
Broad curve scissor. Scissor बड़ा वाला.
नहीं, तुम करो.
जाड़ा वाला दो ना सिस्टर.
तुम करो, तुम्हें आदत है इसका.
जाड़ा वाला और जाड़ा वाला. नेओ सीजर बोलते हैं. जितना जाड़ा उतना अच्छा.
और एंगल करना पड़ेगा ना, हाथ थोड़ा
all the delegates who are going to present posters just come over. Sir,
माइक्रोडिस्केक्टमी रिट्रैक्टर आ गया,
the posters.
वहाँ पे प्लेट तो दिख रहा है उसका. 1 मिनट
Sir, just have 5 minutes. I will arrange it. Just have 5.
ये मैं लेता हूँ.
अरे ऋषभ posters कहाँ पे लगाए हैं? कहाँ पे? वहाँ पे लगाए हैं ना? लड़कों को बुला.
इसके बाद में बाकी के प्लेट
all the guys who want to present the posters, just go ahead. Just go ahead. Okay.
हाँ, वो है ना, उससे बड़ा वाला है. हाँ, ले लीजिए.
Thank you.
Thank you, sir.
हाँ, ये बराबर है. और हुक्स रहेगा, हुक्स.
ठीक.
उससे बड़ा वाला है.
Any questions you have? I think did you see the X-ray?
Yes, sir. We saw the X-ray. It was very nicely placed cage, and the screws and everything. Reduction was perfect, sir.
And the listhesis is reduced.
Yes, sir.
And that has been reduced by distracting it a bit and putting a 12 number cage.
So perfect caging, sir. Excellent, sir. Excellent reduction. Really good screws, especially S1 screws. They are really good.
Sister, मेरे को ये दो.
Cameraman, can you please switch to?
So we have put the same size and length screw for that S1. We have changed the direction or change in the size of the screw.
The size of the screw is same, 40 millimeters into 6.5. 6.5 है ना?
So another learning point is before we come out of the OT, it is always wise before the closure to check the.
एक minute, I can't hear. Say that again. What is the question?
So the screw size is the screw which you have changed the direction, the screw size is same.
Screw size is same.
So now we have the last case, which is discectomy. Gautam sir, can you hear us?
I can hear you, but you don't want to hear me. Because I am ready to blast.
Sir,
देने को तैयार हूँ यहाँ पर.
Sir, we need to see the case like X-ray and the MRI.
Wait, we'll show you. Wait.
Yes, sir.
चलो एक towel दो. Towel. नहीं वो नहीं, sister बड़ा drip दे. Sheet दो.
Actually, you require either microscope
उसके
or
बाद
something like
Harrison
loop.
है कि नहीं?
You don't require this much of incision for doing discectomy, but we are trying to show you. But still, I don't feel like that we are able to see everything because of the camera focus. But still, whatever you are able to see, just see it today, and tomorrow we are going to demonstrate.
इसमें क्या है इधर? ये क्या है? ये 2 ही है. बताइए.
Challenges made in India.
एक मिनट सिस्टर जाने दीजिए प्लीज. हाँ. एक कुछ तो मेरे को दिखाने के लिए पेशेंट्स इन लोग को हार्ट ये ठीक है, ये स्ट्रेट वाला.
Height बढ़ा दो.
थोड़ा.
Yeah, you just can't see anything.
पीछे. हाँ. So Sandeep, can you hear me now?
Yes, sir, we are here.
I can hear you, sir. Yes, sir.
So this is a Rajendra, a 29-year-old male who has come with acute left-sided leg pain.
Focus on the sir. This is a MRI. We are not able
So
to
that's
see
good.
the MRI.
I can show the
दिखाओ
X-ray.
जरा भैया, इधर दिखाओ X-ray, MRI. Focus करो.
Sir, Gautam sir, the cameraman is showing the final picture of the T-leaf case. We just want to tell to the audience that this is the listhesis is done, beautifully reduced completely.
We'll also show you a final
so
picture after discectomy is done. Now root is free. I'll show you a beautiful picture.
Sir, now we have come to you, sir. Just elaborate, sir.
Now you can see.
So
you see the
This
picture.
is a 29-year-old male with
So we
acute
have changed the
left-sided
S1 screw on the
sciatica. He
right
has
side,
received
and that was,
conservative treatment for 3
cutting
months.
through the superior
It
cortex,
has not
so that's it,
settled
we've
down.
changed. Now we've gone slightly lower, but you can see both the screws have bicortical purchase. The fracture is, the lysis is reduced. The case
So
is
he has
sitting,
not
the cage is sitting
improved
right
in spite of
front
3 months
S1
of so.
in the middle of L5.
It was decided
So
to do an
it's well
X-ray and
reduced
an
well,
MRI. So if you see this X-ray, nothing
set in
contributory,
between.
but
We have
there is a
already
reduction in
compressed it, so it's
L4-5
well
S1
compressed.
disc space, a
And
little reduction in 4-5
the bone
also.
graft has been put in from the
Go
facet
to the
joint
MRI,
and from the lamina of both
and
sides.
what you find is
Yeah.
the
Any other
L4-5 disc
questions?
is degenerate. You can see it's a black disc. L5S1 is white,
There
L34
are
is
some
white. This
tips
is a
I
black
think
degenerate disc
which I observed.
which
One
has
is
herniated out.
Dr. Sarjan
Can you
distracted
focus on
using
that
a
side,
Steffi
please?
distractor, and then
वो उसके ऊपर
after distracting
अरे
use the
sister
rod
जरा
to
हिलाएंगे ये
tighten
कौन हिलाएगा
so that
आप नहीं हिला
face
सकती
is distracted and then put in a cage, then you can turn it.
मैं ही हिला
The
डालता
other
हूँ
thing
सब
is,
कुछ।
as you
चलो,
see,
ठीक है।
using a
So इधर
and
can you see this?
Dr. Sarjan ko bula.
This is the L12 disc space.
Using a horizontal rod,
dual sac,
straight rod to a
Both
curved
are
rod.
communicating.
free with
I
no root.
normally would use
But
a
now
curved
if you
rod.
go down
This. Would
and
you
you see
say
an
anything why you
L4-5?
use a
Gautam
straight
sir,
rod?
Gautam sir, Dr. Shankaracharya is telling.
So Dr. Sarjan says for one
To
segment.
me or to some to audience?
Sir, because both are like
Appaji?
audio cameras, audios are working.
No, but
so we are not able to anyone, not able to hear.
So
but
cut him
I,
off.
Just a
somehow or the
messenger
other, I routinely, I also if you bend it, and then you can get the reduction even still better. Yes, sir.
Thank you, sir. Thank you, sir.
Because
Sir, now we come back to you, sir.
there are, I think most people would, but I take your point that you don't bend it for a single segment. For,
दिख रहा है क्या अंदर?
for two segments.
आजा ऊपर से और ऊपर आजा हाँ मेरे को टच कर
For a, no, I don't think this X-ray is representative of the normal X-ray you would see in an erect patient, because this looks a little odd, in which the sacrum looks completely vertical, which is not the case, I think, in this. So, खोल देना मेरे को.
Dr. Shankar,
हाँ.
when you when do
हाँ,
you go
KD
into
बोलो.
the L4 as well?
जोर से बोलो, सुनाई नहीं दे रहा मेरे को.
Hello.
हाँ.
Am I audible?
हाँ, बोलो.
When do you go into the L4 vertebra as well, if need be, sometimes?
In high-grade listhesis, you may go to L4, but in this, not in this. Not in high-grade, you may go. Here the disc is pristine and good, so you don't want to go.
Okay.
Or kuch?
Bas. Thank you.
Okay, thank you.
It was very nice surgery. We all enjoyed it all. Great applause to Dr. Shankar and his team.
So, sir, now we are coming back to Gautam, sir. Clinically, it's like you will have to. So we have we need to make a diagnosis which one is functional, which one is causing the problem. So you can give the nerve root block and see the effect, because it's whether it's L5 or L4, and the amount of listhesis also matters, whether it's a stable type or unstable type. If they are a 2-level anterior probably it's a multi-level stenosis case. In that case, you need to do the flexion extension views and all, and assess whether which fragment is unstable, whether both the fragments are unstable or not. And if you want to see whether, because in majority of the cases you require to do the decompression of the root, because they have radicular pain and back pain. These are the two complaints. And which root is causing trouble? For that you need to give a root block and identify which is the source of pain generating, and accordingly focus on that root.
Penfield for Kerrison. Kachra, collect.
Sir, people want to see the MRI.
Can you see the surgery first? Let me show.
No,
Go take
sir,
you back.
We are just seeing the hole as you have previously said.
Can you see? This is the L4. What
No, sir, we
I've
cannot
done
see,
is
we
a
are just
small
able to see the
incision.
hole.
This is an L4. Can you see inside?
Cameraman just try
तो
to
आजा
focus
अंदर
if you
आजा
can.
अंदर आजा लीन कर थोड़ा इसको ऐसा कर चलो you tell me what you can see then I will tell you ये दिख रहा है अभी दिख रहा है क्या tell me something
नहीं सर अभी नहीं दिख रहा सर अभी हम
अभी
लोग
वो
को नहीं
क्या
दिख
कर रहा है
And
he's
the
practically
cameraman,
leaning on me outside of the camera I don't know I am out of the range ये L4 lamina है
Yes, right now we are able to see sir.
L5 lamina है
Yes, yes.
ये ligamentum
दूसरा
flavum
video
है
दिखा दो
ligamentum flavum में I have made a vertical slit
अभी second cameraman जो अभी आया था
I
वो
have
कहाँ
been
गया?
into the canal this is the epidural fat
Yes,
and
yes,
I am
this is
removing
the
the
viewer.
ligamentum
Sir, can you
flavum
please explain again sir? Can you please explain?
so
Sir, just a
we
minute,
are
sir.
doing a micro discectomy without a microscope it is also called as a fenestration discectomy
कैमरामैन अब यही वाला कैमरा रखना चेंज मत करना
हाँ बस अभी ये देखो this is the I am operating on the left side this is the left side
yes sir
this is the right side
yes sir
this is the upper end
yes sir
this is the lower end
yes sir
now I have in this patient he has a left sided L4-5 disc prolapse
yes sir
so the plan is to do a L4-5 fenestration discectomy
okay sir
if you are doing a fenestration it essentially means you are not removing much bone you are just removing ligamentum flavum to access the disc now what you have done I have done is I have exposed the L4 lamina this penfield
Sir, yeah.
L4 lamina
yes sir
this is the L5 lamina
yes
this is the ligamentum flavum
yes we can see sir
what I did was I made a vertical incision in the ligamentum flavum
yes
from L4 to L5 that is usually done as medial as possible because in the midline there is maximum space
yes sir
then the last layer of ligamentum flavum you don't cut you use this pencil for and pop the last layer so that you got into the epidural canal
yes sir
once you got into the canal this is epidural fat
yes
and I am now using a kerrison I need a 3 millimeter there is no 3 millimeter kerrison I hope I don't cause a dural tear or pull out a nerve root with a L4 4 millimeter kerrison
so this is the ligamentum flavum getting removed we can see sir
yes sister do you have a thinner suction cannula the 3 millimeter is such a phenomenal instrument na? So can you see this?
yes sir we can see
This is the L4-5 facet joint here.
yes
You should not remove too much of facet or remove too much of pars intraarticularis, otherwise you are creating instability.
yes sir
This is the dural sac over here I am trying to show. कैरिसन ना हमेशा पकड़ने का ऐसे छोड़ दे होल्ड क्लीन हाँ और फिर छोड़ने का so that when you hold you will get the grip to remove this and when you leave I will realize that you have finished so I can remove How much of this you should remove? You go on removing till you see the shoulder of the nerve root.
Yes, sir.
Pen 2 millimeter. Wapas 4. You are a resident, no? Can you check how old this MRI is? When was it done? Oh, not too far back. Penfield 4. Patties ले लो sister दो. See that? Can you see that, Sandeep? This is the dural sac, and this is the nerve root which is going out laterally. I am retracting the dural sac medially.
Yes, sir.
पैटी
वो ऐसा रहेगा उसको
सिस्टर आपने क्या लिया है टेबल पे? मेरे को तो मालूम नहीं, सभी चीज आप मंगवा रहे हो. छोटा आधा करके दो. प्लेन फॉरसेप्स के साथ दो. और एक पैटी सिस्टर. Put it on his hand and give it. Is anybody there for me to ask?
Yes, sir. We are here, sir.
Okay, Sandeep. Now you can see I put 2 patties.
Yeah, we have seen.
One patty went
Yes.
up in the spinal canal.
Yes.
The second patty went along the nerve root.
Yes.
So what it has done effectively is pushed the nerve root medially. The patty is working like a hemostat, but it's also working like a passive retractor.
Yes, sir.
And now you can see this is the nerve root which has been retracted. This is the dural sac. I am lateral to it and I will begin my discectomy soon. Some more patty, sister. There is plenty of space. So I'm
Kindly clear the caudal and the
Pardon me?
cephal direction of this your surgical orientation.
ये this is head end.
Head end is
ये वाला.
ये वाला.
ये
Okay.
tail end है.
This is
ये
tail
right side है, ये left side है.
Okay.
Okay, you can clearly see the disc here now. Focus करो, zoom in करो. This is the nerve root.
Yes.
Which I am retracting. And this is the disc. There is a large protruded fragment of the disc.
Now focus करिए cameraman.
Knife 15 blade just one.
Cameraman थोड़ा focus करिए. We can see the big disc. Yes, sir. Now we are. It is very
कोई
clear.
बड़ा लंबा वाला blunt hook था ना वो दे दो.
ये
इधर था, इधर पड़ा हुआ था पूरा। और वो बड़ा मैकडोनल्ड ड्यूरा डिसेक्टर ये है ना, चलो ठीक। So I have made an incision in the disc, and I am now taking out that, वो किधर गया hook? So I am teasing out the disc fragment which has extruded.
Yes, sir, we can see that. Cameraman, can you focus?
Disc punch.
Cameraman, focus.
So now you gradually tease out the disc fragment.
Cameraman, you can zoom out and focus. Zoom out and focus. Zoom out and focus. Yes. And now focus.
This is the disc fragment. Part of it has come out.
Yes. Just keep it like this.
Blunt hook.
अभी ठीक है. Cameraman, अभी ठीक है. With the thread we have retracted. Yes, yes. With the thread we have retracted.
It is just shearing the disc. It's not holding the disc.
छोटा वाला नहीं स्ट्रेट वाला कर्ड बनी
You can see the sir is what he is doing is slowly trying to take out the fragment. If he'll just catch the fragment and pull it out suddenly, it will break. So again he will have to search the fragment. So slowly he'll tease out and take it out.
So the disc punch is not very good.
Yeah, we
Sandeep.
are seeing it is slipping.
So it is shredding
not
the
holding
disc.
the
It is not bringing the disc out. I cannot hold the disc.
Yeah, it is slipping, sir.
So it is. We would have got this out in one piece.
Yes.
Instead, we will have to make the effort of doing it in multiple. This thing, which is dangerous. ये नहीं चाहिए अभी. I'm in the disc space. Sister, I want a 20 cc syringe an 18 number needle और उसमें fresh saline ले लो.
मोटा needle 20 cc syringe.
Thank you, sister. That's good. 20 cc. So now whatever little I could remove, I've removed.
Yes, sir.
Now I'm irrigating. I put in a forced irrigation into the disc space. What it does is, if there are any loose fragments, they tend to come out.
Sir, you are putting with the needle, sir?
Yeah, 18 number needle, 20 cc syringe.
Okay, sir.
And saline.
Okay, sir.
ब्लॉक हो गया ये
पतला वाला. जिंदगी के सफर में गुजर जाता है जो मकान फिर नहीं आते. डिस्क आ रहा है. Start holding it.
So this is the fragment which sir is trying to pull out. It is lying just below the root.
So there are a lot of equipment which we use in spine surgery.
Yes,
there
sir.
is one equipment which I always use foreign, and that is a disc punch.
Okay,
I
sir.
always use a Caris disc punch, because if your disc punch is not proper, you can land up in a lot of mess. So this is one instrument which I always use, Caris 2mm, which I use foreign. The rest I don't mind using Indian.
Now it is patty is out.
Let me try. Enfield 4. Wash again, sister. So now, Sandeep, this is the dural sac, this is the nerve root, it's absolutely free.
Yes, sir, we can see that.
When I started, I could not retract it at all.
Yes.
Now I am able to retract it freely. I am going to again go into the disc space and give a wash. artery देना है वालों artery there is nothing here. This is just annulus.
Yes.
एक मिनट पकड़ो इधर आइए. Disc punch.
Sir, annulus is very difficult to pull out with the disc punch even.
Yes.
So, sir, do you cut it with the knife and take it out if it looks like?
I don't want to remove that much.
Okay, sir.
There was just one piece which was a little. Here. Yes. Knife then a 15 blade. Yes. We'll do it a little bit. It looks ugly. Wait for a couple of minutes. Usually most of it reduces, and then you turn the patient, you close the wound over a drain, and when you turn the patient supine, this bleeding stops, because this bleeding comes from epidural vein.
Yes, sir.
The moment the pressure on the epidural vein goes away, your bleeding will stop.
So when there is bleeding, sir, you put drain in discectomy.
I always put drain in discectomy. I don't see any reason why I shouldn't put a drain in discectomy.
Okay, sir.
Okay,
any other delegate has any question? Because this is
so
the
I'm
last.
done. Can you see now? This is L4 lamina, L5 lamina. This is the dural sac. This is the nerve root.
Yes, sir.
This was the disc which we removed. I'm just giving a wash and then we'll close.
So any question to sir? Because
Chalo,
we
I
are going to close it now.
Drain डालना है. Drain डाल के दूँ तेरे को कि तू डालेगा. संभाल के इधर से निकालने का. नर्व को इंजोर मत करना. चलो.
Thank you, sir,
Maybe
for
so
excellent.
You can help him to put the drain. Then he can close.
Thank you, sir, for excellent exposure and showing every step of this discectomy.
Thank you.
Thank you, sir. Sir, Gautam sir? Sir is not there. Anybody who is there? Steroid, there are practices of putting steroid over the root. Some people put it directly. They take the Kenacort and just put it. Few people take gel foam and put the steroid in that and just put over the nerve root. Few people don't do it. So it's all individual practice. There is no hard and fast rule. Siddharth boss, anything? So Dr. Siddharth put over the gel foam and put it over the nerve.
Yeah, just a gel foam slightly larger than the fenestration so that it doesn't fall inside. No, only in very tight canal where I feel that I have retracted too much. So usually in 10 cases maybe I will do in 1 case. 8 or 9 cases.
Not in all cases.
Yeah, very tight if retracted much. If it was a very central, there was a central component apart from paracentral component, ज़्यादा retraction हुआ midline तक, then otherwise not.
I don't do it.
In discectomy I don't.
I also don't put it.
In multi-level decompression I sometimes put. If it is 2 or 3 level or 4 level decompression.
So lot of people, if we are like, if there is a bleeding, I'll put patty, I'll put Surgicel also. I'll wait for at least 3 minutes. Then I'll remove the patty, remove the Surgicel. Once the bleeding stops, then only I close. Until the bleeding stops, I don't close because I don't put drain. If I am putting the drain, then I can probably. Later we are going to see in the cadaveric course putting lumbar pedicle screws, the fenestration, laminectomy, TLIF, and all the or any other thing which delegate want to learn. We are going to see all those things. Okay, so Dr. Wali will come, Dr. Shah Waliullah, he will tell you about further what all are there in the evening. Delegate has all the 6 cases have been done. So yes.
Sir, how it is decided the bend of an interconnected the connecting rods? Decide the bend of the
of
is
the
it due to experience by experience or anatomical, or is there some criteria or something?
So if it is lumbar spine lordosis wise, 60% of the lordosis is between L4-5 and L5-S1. 30% is between L1, 2, 2, 3 and 3, 4. Depending on the type of level you are doing, how many levels you generally control into lordosis. For thoracic it's generally kyphotic, and in thoracolumbar region it is neutral, so you might have little kyphosis on the top end of the rod and lordosis in the bottom.
By anatomical.
Yeah.
One is another way is also like you see the X-ray. You see the X-ray of the patient. We have X-ray, the MRI of the patient. You see the X-ray of the patient and the region which you are instrumenting. Just see the curvature and accordingly you bend the rod and put it. Until unless if it is degenerative things, like if it's not trauma. If in trauma obviously the fracture is there, it will go into kyphosis. You want to correct that. So accordingly you have to bend the rods. You want to ask some question? Can you give the mic to him?
Sir, what is the role of ozone therapy in case of...
I don't have any idea about ozone therapy. If anybody has, they can answer. I just don't. I have zero idea about ozone therapy.
Thank you, sir.
Anybody knows anything about ozone therapy, they can tell.
It's just like an obsolete procedure right now. I don't feel like nobody's doing
So,
initially, because there are few things that they comes and they goes. So this is one thing.
We don't have any idea about that. You ask us about cupping, we don't have any idea. You ask about chiropractic, we don't have any. I don't have any. Maybe some of the people might be having.
Dr. Sandeep, very common question for this PG and for the practitioner is that the patient is having a low backache. We are just demanded the patient for MRI, and after seeing the MRI, just we have suggested the patient for the physiotherapy. How many of us that we suggest the patient for the physiotherapy in acute PID? Acute disc prolapse in the moderate
give me a
disc.
few minutes, I'll explain. So there is one important announcement regarding today's evening dinner. So what we have given all the guys who are registered and they have got the coupon, they will come, because they have guys who will check, because they have policy in the hotel that they will do like that. So I request everyone to come with your coupons, so that there will be no issues with that. This is the one issue.
And also tell the timings and the venue.
And the timing is 7:30 p.m. That's we are going to start our inaugural ceremony. So I request everyone to get there in time so that you can enjoy the cultures that we have arranged there. So all of you are welcome and to come there and enjoy with us. Thank you. Venue is Clark's Awad, very nearby. I'll put down again in the talk. So you can go there. It's a very nearby area. Okay, very nearby. And tomorrow morning we have a CME session that is going to be in Kalam Center. It's room number 222. Room number 222. Okay. So Kalam Center is in the vicinity of our college, but it is opposite side. So you can Google it out. Again, put down the venue on that WhatsApp group. So you will reach there very easily. Okay. If you have any query, any question, you can ask me regarding on that group, so that we can facilitate you. And tomorrow we are going to start CME by sharp by 9, because today we were having like OT, what to do, how to evaluate, and how to decide. because majority of the patient, they do manage conservatively, and you need to decide where you need to operate and where you need to put conservatively. So I have I've tried and I've persuaded all my speakers that these lectures should be kept very basic, so all of you will